RCC, Tirunelveli Medical College and Devas Cancer Care Clinic.
Let's begin with the oral presentation. The first presentation is by Dr. Kamakshi Shubhashri from Vaidehi Institute of Medical Sciences and Research Institute to compare two different fractionation schedules of HDR brachytherapy in the management of cervical cancer. Okay, we'll begin. Everybody settle down.
Hello. Good morning everybody present here. I am Dr. Kamakshi Shubhashri from Vaidehi Medical College, second year resident from Bangalore. My topic for today is comparison of two different fractionation schedules for HDR brachytherapy in management of cervical cancer. Coming to the introduction, cervical cancer is a major global health issue, especially in low income. The objective is to compare the local tumor response between two fractions in brachytherapy and to assess and compare the treatment-related toxicities. So, in our study, figure stage 1B3 to 3C with ECOG performance status of 0 to 1. And we have randomized into two groups. We have group A and group B. Group A is a single arm application and group application. In single application, the dosage is 6.5 gray into 4 fractions, and in dual applications, it is 6.5 gray into 2 fractions, and take apart, we again give 6.5 gray into 2 fractions. Assess response using the RECIST criteria 1.2 version, the dosimetric data such as HRCTB, D2CC bladder, rectal, and sigmoid, and RTOG of bladder, rectum, and sigmoid toxicities. So, have included patients of age between 30 to 70 and have equally distributed 35 patients in group A, that is a single application arm, and 35 patients in group B, that is a dual application arm, and have included figure stage 1B3 to 3C. And the overall application arm and the yellow is a dual application arm. When coming to the HRCTB D90 dose, there is better dose coverage in the dual application arm compared to the single application arm, and it is statistically significant. Now coming to the D2CC bladder, there was a much better dose to the bladder in dual application arm compared to the single application arm, and it was statistically significant. But coming to the rectum and the sigmoid, there were no much difference compared in both the arms. Toxicity, using the RTOG criteria, assess the toxicity. In single application arm, it was slightly higher, and in dual application arm, it was slightly lesser, but it was not statistically significant. They always lie on stretcher. That's a common thing we follow in our institute.
Don't you think we are doing an LDR there rather than HDR there? Isn't it? LDR is finishing 24 hours,
Yes.
less than 24 hours.
Yes.
But here we are going in for almost 48 hours,
48
nearly
hours.
48 hours. So did you give any DVT prophylaxis or anything like
Yes,
that?
sir. We have
We have given.
Yes.
And it's surprising that they are tolerating, the advantage of that is. Thank you.
Thank you, sir.
Thank you, Dr. Kamakshi.
Before moving on to the next talk, I welcome the chairpersons Dr. Mallika, Hashumita Hospital, Tiruchi, Dr. Selvamani, CMC Vellore, Dr. Damodara Kumaran C-Square Cancer Center and Research Institute for the session. Please come to the dais. Hello, sir.
We'll call the next speaker,
And
Dr.
to
Vinayak from Government Arinyar Anna Memorial Cancer Hospital, Kanjipuram, to present on radiologic signatures for predicting PCR and rectal cancer.
Is Dr. Vinayak here? From Kanchipuram?
Just a minute.
Dr. Rasi is there?
Hello.
Dr. Rasi? Yeah.
Dr. Rasi from Sri Mugambika Institute of Medicine.
Dr. Rasi from Sri Muhammad Institute of Medical Science.
For the title point based versus dose volume histogram based evaluation.
Point based versus dose volume histogram based on evaluation of doses to organs such as OARs and high dose rate brachytherapy planning of cervical cancer.
Good morning, everyone. I'm Dr. Rasi, and my topic is point based versus dose volume histogram based evaluation of doses to organs at risk in high dose rate brachytherapy planning of cervical cancer. Cervical cancer remains a significant global health burden worldwide, and in India it is the second most frequently encountered cancer among women, especially among the reproductive age group. And treatment of cancer essentially depends upon the stage of the disease, with surgery being the treatment of choice for early and non-bulky diseases of FIGO stage 1A1 to 1B1, and concurrent chemoradiation being the followed by intracavitary brachytherapy being the treatment of choice for FIGO stage 1B2 disease and above. High dose rate brachytherapy offers precise and localized radiation delivery to tumor tissues while minimizing the dose to the adjacent healthy tissues due to its heterogeneous dose distribution and steep dose gradient. Conventional planning with ICRU 38-point based doses often prove poor surrogates for the doses received by the target volume and OARs. While three-dimensional planning helps in better delineation of the OARs and target volumes, they also help in near accurate quantification of the doses received by the OARs and target volume. The primary objective of my study was to compare the doses of OARs in both point-based and volume-based plans with an intent to explore the impact of patient-specific factors like tumor characteristics and anatomical variations on dosimetry. So methodology, it was a single institutional observational study conducted in the Department of Radiation Oncology and Shubhagarmil Institute of Medical Sciences from November 2023 to August 2024, recruiting 21 patients with biopsy-proven cervical cancer of FIGO stage 1B2 to 4A who received concurrent chemoradiation. This is a chart showing the age-wise distribution. The mean age of the population was 57 years. And the inclusion criteria, biopsy-proven cervix patients with 1B2 to 4A, above 18 years of age, and ECOG performance score of 0 to 2 were included in the patient cohort. And coming to the stage-wise distribution of the population included in the study, most of the patients had a stage 2B disease. And the study procedure was that all the patients received a EBRT dose of 45 gray
over 5 weeks duration with concurrent cisplatin of 40 mg per meter square weekly dose. And post 1 week of completing the treatment, they were given iridium 192 HDR remote afterloading technique of intracavitary brachytherapy using CT-based 3-dimensional conformal planning. Point doses to bladder and rectum were defined upon ICRU 38 points, and dose volume histograms were computed for bladder, rectum, sigmoid colon, and small bowel after contouring the OARs according to the GESTO guidelines. And the minimum doses to the highest irradiated area, 2cc area, that is D2cc, was recorded, and a comparative analysis was made between the D2cc values and point doses. The results were statistically significant with bladder point doses significantly lower than the actual doses received by the bladder, and rectal, sigmoid colon, and small bowel doses of point doses significantly higher than the mean D2cc values, that is actual value received by the OARs. And this is a scatter plot showing the comparison between the point doses and D2cc of OARs taken for the study. And from this we can see that sigmoid colon is the highest organ receiving D2cc value, following rectum and then the small bowel. So bladder doses were higher in anteverted uterus and in patients with anteverted uterus, and rectal D2cc values were higher for patients with retroverted uterus. This is a chart depicting the same. And coming to the discussion, the bladder point doses significantly underestimated the bladder dose, and this was comparable to the studies by Srivastava et al., Maiti et al., and Vinod et al. And the rectal point doses overestimated the D2cc values of rectum, and this was an agreement to the Maiti et al. Study. However, it was in non-agreement contrast to the studies by Kim et al. And Vinod et al., who suggested that point doses were better surrogates for D2cc values of rectum. And sigmoid colon was the frequent organ receiving the highest D2cc value of 4.2 in the study, and this was in agreement with the studies by Kim et al. And Mahanshidi et al. To conclude, despite widespread use of HDR brachytherapy in cervical cancer treatment, gaps still persist in understanding the optimal dosimetric parameters for organ sparing and tumor control. So 3D image-based brachytherapy planning will help in reducing the undesirable doses to the OARs by optimizing treatment plans while minimizing late toxicities and decreasing the morbidity of the patients. These are my references. Thank you.
Reiki எவ்வளவு கொடுத்தீங்க? How many fractions?
3 fractions, ma'am.
Dose?
7 grade.
7 grade 3 fractions for all the patients.
All the patients, ma'am.
How will you treat 3A patients? Stage 3A.
All the patients were we had the same dose, ma'am. After brachytherapy, we assessed the residual disease, and almost all patients had good response to the disease.
You put cylinders or you put ovals? For 3A, I'm asking.
Ma'am, in our center we used modified flesh suit applicator, ma'am. So we used both cylinder and voids.
For 3A.
Yes, ma'am.
Dose, how will you compute the dose? 3A.
Undergoing content chemoradiotherapy. cervical cancer is a global burden, especially in a low socioeconomic country. Even though the response between patients vary. Like hemoglobin, neutrophil lymphocyte ratio, platelet count, and human hypoxia, systemic inflammation, and immune status. Next slide. Based on the literature review, hemoglobin more than 12 suggests a better outcome, and high NLR is indicator of immune suppression correlating with the disease recurrence and poor survival, as well as increased platelet count suggests a tumor supporting microenvironment and poor prognosis. Next slide. My study evaluated the baseline and dynamic hemoglobin parameters and its correlation with the disease-free survival, progression-free survival, and overall survival. Next slide. The study design is a retrospective study conducted at GAMCH Kanchipuram. 87 women with biopsy-prone cervical squamous cell carcinoma of FIGO stage 2B to 4A were included, and these patients received concurrent chemoradiotherapy between January 2019 to December 2019. My inclusion criteria include 80 to 70 years of patient who completed CCRT and brachytherapy dose of squamous cell histology and who has available CBC data before and during treatment and a minimum follow-up 12 months. The exclusion criteria include patient who doesn't complete the treatment and who doesn't receive concurrent chemoradiotherapy, and patient who doesn't have CBC data and the other histology with the patient with hematological disorder. Next slide. The data collected include the age, FIGO stage, and hematological parameters like hemoglobin, WBC count, platelet, and NLR, and outcome measured at EFS, PFS, and overall survival. All patients received a concurrent chemoradiotherapy of 50 grade 25 fraction with the weekly cisplatin, followed by brachytherapy of 21 grade increased fraction, sublingual fraction. Total HRCTV or ETV to more than 85 grade. Analysis was done using SPSS software, and the significance was set as 0.05. Next slide. The results are median age is 51 years. Most of the patients were stage 3B and 2B, and the mean HB was 10.8 plus or minus 1.3. Mean WBC was 8,000 plus or minus 1,500. Platelet was 3 lakh plus or minus 75,000. NLR 3.3 plus or minus 1.8. Next slide. The median survival was DFS 48 months, PFS 45 months, and overall survival 52 months. Next slide. As you can see, both pre-treatment and during treatment hemoglobin analysis, patient who has hemoglobin less than 10 has poor disease survival, PFS, and overall survival, and compared to hemoglobin more than 12 gram per deciliter, and all their DFS, PFS, and OAS were significant. Next slide. And patient who received blood transfusion, about 19 patients, accounting for 21.8% received blood transfusion, who accounted an increase in HB. When comparing the patient who has increased HB with the patient who has decreased HB during treatment, they end up with better DFS, PFS, and overall survival. Next slide. About 16 months in DFS are not significant. Similarly, an NLR rate of less than 2.5 was prognostically significant when compared to an NLR rate of more than 3.5, both pre-treatment and post-treatment. Next slide. This NLR rate was mainly due to the lymphopenia experienced by the patients during treatment, whereas the patient who has severe lymphopenia of less than 500 has about 20 to 30 months survival difference when compared with the normal leukocyte count of more than 1,500. Both are statistically significant. Next. Based on my study, I have stratified the patient into 3 groups: low risk, intermediate, and high risk group. Low risk patient has HB more than 12 and NLR less than 2.5. Intermediate risk has HB 10 to 12 and NLR 2.5 to 3.5, and high risk patient has HB less than 10 and NLR more than 3.5. As you can see, the DFS, PFS, overall survival has significant difference, about 20 months over the intermediate group and 25 to 30 months over the high risk group. There's next slide. Conclusion: hemoglobin and NLR demonstrate a significant prognostic value which independently associated with DFS, PFS, and overall survival. Being these blood markers are available as in low cost and wide availability, these markers can be used to enhance the risk stratification, enabling tailored intervention, particularly in resource constrained studies. My study has certain limitations. Subset analysis for the unmeasured confounders like nutritional status and comorbid condition, infection, and radiation status may be done. And direct tumor microenvironment biomarkers like hypoxia, event cell infiltration, angiogenesis provide a deeper prognostic insights. By generalizing the study to a multi-sector design may improve its generalizability to the general population. These are my references. Thank you.
How did you assess DFS and PFS?
Ma'am, DFS,
What is the difference?
ma'am, the BFS was patient who was after achieving a cure, the patient was followed up, ma'am, and patient at the point of diagnosis of a recurrence was taken as a disease-free interval. Recurrence, death lost to follow.
So your follow-up is only 12 months.
No, sir. I have followed for 60 months, sir.
60 months follow-up.
Yes, sir.
Okay, so according to you, the NLR is high. So what will you do if what is your solution for this problem? What do you think will be the
Mainly
solution?
the NLR rate of high is because of lymphopenia, sir. Most patients does because mainly due to the immune suppression, bone marrow suppression, sir. By using GSF during treatment, we can improve the we can reduce the NLR rates by improving the lymphocyte.
So do you think that will improve the OS and DFS?
My study patient who has a better lymphocyte count and who has a reduced NLR rate has a better survival compared to patient with increased NLR ratio.
How will GCSF improve lymphocytes?
It will stimulate the radical cells.
No, the neutrophils increase or lymphocytes increase? See, when neutrophils increase, obviously there is going to be lower lymphocytes. And obviously the NLR is going to be the same. Now, how will it improve GCSF?
Why? What is the significance of neutrophils? Why not basophils, eosinophils? Why neutrophil is considered?
I have calculated every WBC parameter, but lymphocyte and neutrophil has a significant difference.
Why? What is the reason?
Ma'am, when lymphocytes are reduced, the immune-mediated tumor killing becomes reduced. So the several different.
Neutrophils, you are taking neutrophils now?
Increased neutrophils suggest tumor favorably.
Why? Because it contributes the vascular endothelial growth factor. Main source of vascular endothelial growth factor is from neutrophils. So that will cause angiogenesis, that will cause the metastasis, there is disease-free survival, overall survival is reduced.
Thank you.
Announcement. The postgraduates are requested to load the presentation at the to the earliest at the desk. Those who are not uploaded, please come front and upload your presentations.
Dr. Vishnu, Dinesh. Dr. Dinesh from Madras Medical College, dosimetric analysis of conversion of the 3D CRT versus hybrid VMAT techniques in carcinoma left breast patients.
Good morning to one and all present here. I am Dr. Dinesh from Bharad Institute of Radiology and Oncology, Madras Medical College. My topic of presentation today is on dosimetric analysis of conventional 3D CRT versus hybrid VMAT technique in carcinoma left breast patients. Introduction. Radiotherapy is a cornerstone in the management of breast cancer, significantly improving local control and overall survival. In left-sided breast cancers, however, achieving the adequate PTV coverage while minimizing the radiation exposure to the critical organs such as heart and lungs is particularly challenging. While deep inspiration breath hold technique is the preferred modality to reduce the cardiac dose, a significant subset of patients were ineligible for DIBH due to their poor respiratory reserve, compliance limitations, or comorbid conditions. So, in such cases, alternative free breathing radiotherapy techniques must be optimized. So, my aim of the study is to compare and analyze the organ risk doses, particularly heart, lungs, and contralateral breast, between the hybrid VMAT plan, which I describe as plan A, and 3D CRT plan, which is plan B, and to evaluate the PTV coverage, conformity, and homogeneity between both the techniques. So, it is a cross-sectional study conducted in our departments for the past 1 year. Carcinoma left breast patients who are indicated for PMRT are taken into the study, and ECOG 1, 2 patients with baseline stable cardiac status and not able to do DIBH are included in the study. And known metastatic diseases and cardiac diseases are excluded from my study. So based on this inclusion and exclusion, 22 patients are included. So target volumes were delineated in the planning CT using RTOG guidelines, and the dose was prescribed to PTV 50, which includes chest wall and regional nodes. So 2 technique was planned. Hybrid VMAT plan. In our institute, we are following a protocol of 50 gray in 25 fractions, 2 gray per fraction in conventional fractionation regimen. So in my study, I have conducted taken as 2 plans. In HVMAT technique, 80% 3D CRT and 20% VMAT was used. That is 40 gray in 3D CRT and another last 5 fractions, 10 gray in VMAT. In another arm, conventional 3D CRT technique, whole of 50 gray was treated in 3D CRT only. So 2 plans will be generated during the plan evaluation. A hybrid VMAT plan and conventional 3D CRT plan, and dosimetric analysis will be done for the OR constraints and PTV coverage. So this is a DRR and axial image showing the target volumes. And this is the images showing the dose distribution and the beam arrangements of plan A, that is hybrid VMAT technique, and plan B, conventional 3D CRT technique. So these are the dosimetric parameters I have taken into account. OIRs like heart, V, volume received by 5 gray, 25 gray, left lung, the same 5 gray and 20 gray, right lung, right breast. PTV coverage, both chest wall and supraclavicular dose received by 95%, and the indices like PADX, conformity index and homogeneity index. And these are the constraints in accordance with the quantum guidelines. So age, most commonly in my cohort, mostly the patients were 50 to 60 years, and T stage, T2 being predominant and N1 being predominant. The results, we can show that this graph clearly shows that all parameters are similar in both the techniques. We can clearly note the low dose areas like V, volume received by 5 gray is somewhat upper head in hybrid technique. Otherwise, the volume received by 25 gray as well as for right lung and right breast are comparable between 2 techniques. Coverage wise, both for as well as supraclavicular fossa and chest wall are equivocal in both the plans. And indices wise, it is obvious that hybrid VMAT plan has superior conformity index as well as homogeneity index. So my inference is that hybrid VMAT plan shows superior conformity index with a p-value of less than 0.008 and homogeneity index with 0.021 for both chest wall and supraclavicular PTVs, indicating the better dose distributions. So mean and high dose parameters like volume received by 20 gray and 25 gray were comparable between the 2 techniques, but however it resulted in significant low dose exposure like volume received by 5 gray to the heart and left lung, right lung and as well as contralateral breast, which was clinically statistically significant. So discussion, hybrid VMAT plan showed a significantly higher heart dose, though P25 remains similar. So these findings reflect a known trade-off between these 2 plans, with the it shows that improved conformity and homogeneity come with the increased low dose bar. So further subset analysis has been done with comparing the hybrid VMAT plan with complete VMAT plan, but it shows increased low dose bar as well as monitoring indexing complete VMAT plan. So this shows the superiority of hybrid VMAT plan over the complete VMAT in treating the patients who are not eligible for TABH than 3D CRT, where conformity matters. So in summary, these tables assume that hybrid VMAT offers a clinically significant improvement in PTV dose quality over 3D CRT in non-TABH patients, but careful patient selection and meticulous planning are necessary to balance the trade-offs in OR exposure. So conclusion, as the diagram clearly depicts, there are advantages and disadvantages in my hybrid plan. So hybrid plan offers improved target dose conformity and homogeneity over the conventional 3D CRT with slightly higher low dose exposure, but we have to remind that it is all within constraints. And hybrid technique remains better than complete VMAT technique in terms of low dose exposure, and it may be reserved for cases requiring enhancing PTV conformity. And the study supports selective use of hybrid VMAT technique compared to the conventional 3D CRT as well as complete VMAT technique, as the choice of technique should be individualized, balancing the target coverage needs with OR protection goals, patient anatomy, clinical condition and institutional expertise. So these are my references, and thank you for giving me this opportunity. We have
how frequently CT, how frequently it was done? Weekly, once, twice?
Weekly once.
Both cases?
Yes. Same patient, 2 plans were generated, sir.
They check the main dose to the heart.
Yes, sir, we have checked.
What is the main dose in both the plans?
It was about 6.5 in hybrid, sir, and 6 in conventional 3D.
So now you say this mean dose is something which we are doing in the market.
Yes.
But you didn't mention that can we discuss it?
No, sir. But
Heart, the main thing is the main process. And that is what is to be checked when you're doing the left breast track. That is not being coming onto the slides. So it's very important, not the V5 and V25.
Sir, suppose in other constraints also V25 is being achieved.
The thing is fine, but mean dose is very important. And what was the mean dose in VMAT plan? Complete VMAT plan, it should be definitely less. In a complete VMAT plan, the mean dose is much better than the hybrid or the polycythemia.
Yes, sir. Please
check that again.
Mandatory constraint. We have to achieve that.
This is for particularly patients who are not able to perform re-irradiation. Whether any alternative being tried or not.
Move on. Thank you.
I call upon Dr. Vishnu, Madras Medical College, topic of CT radiation based enabling modeling for early detection of residual disease following radiotherapy in patients with attendance commercial carcinoma.
Good morning all, I am Dr. Vishnu from Madras Medical College. My research is on use of CT radiation based and machine learning for early prediction of residual disease in head and neck commercial carcinoma. Radiotherapy plays a vital role in definite management of head and neck cancers, where the residual disease ranges from 11 to 23% associated with inferior overall survival. Several trials have explored the role of dose intensification to improve local control, but are limited due to acute and late toxicity. This warrants proper case selection. The early prediction of residual disease can act as a patient selection tool to achieve best possible benefit risk ratio. In this context, the radiomics and machine learning have emerged as promising solutions. With the radiomics, we can extract multidimensional quantitative parameters from the routine medical images such as CT, MRI, and PET-CT, which can be used as non-invasive biomarkers for machine learning model development. The objectives are to identify the radiomic features that are associated with post-RT residual lesions and to develop a machine learning pipeline which predicts the post-RT residual disease using those features and to validate the model's predictive performance using various metrics. This is a retrospective observation study on head and neck commercial carcinoma patients treated at Madras Medical College during the years 2021 to 24. The patients with biopsy-proven commercial carcinoma in head and neck sites, for those who were treated with definitive anti-inaugural chemotherapy, and for those whose residual status were available retrospectively were included in the study. The softwares used for model development as well as the radiomic feature extraction were made sure that they are open source, standardized and validated. With the selection criteria, 127 patients were selected in consecutive sampling method. Among them, the 56% patients were with residual and 44% without residual. Among subsets, the oral cavity cancers and T3 N2 diseases formed the majority, and most of the patients have received concurrent chemotherapy with cisplatin. All the patients have undergone CT simulation in 3 mm slices, and the assessment imaging by either CT, MRI or PET-CT was done by OEMs. The residual status were established by clinical and/or radiological with or without pathological confirmation. After patient selection, the planning CT images and the already contoured GTV primary structures are exported from the TPS, and with the help of 3D slicer software and Radiomics, PyRadiomics open source Python script, we extracted 107 radiomic features for each of the patient. Before feeding the radiomic features for model training, the pre-processing has to be done, which is made sure that the radiomic features are properly and efficiently used for model development. The process includes conversion of strings to numerical values, and from the selected 107 parameters, the top 10 best correlated features are selected using correlation filter and select key-based Python script, and the numerical values are normalized to have common range. After mixing with clinical data such as T stage, N stage, the chemo received or not at the site of the tumor, the data is split into two, one for training and one for test. The 70% data is used for training two models, namely XGBoost Re-ensemble model and RProp MLP model. The both models give their predictions in two forms. One in binary form, which predicts the patient either case or control, and the next form is probabilities. That is, both models give a probability of a patient being a case and the probability of the same patient being a control. Both outcomes are then ensembled into using various logics to arrive at a single prediction out of two models. The final ensembling from the logics is done by another Boolean logic only when both logics predict a patient to be case, it's a considered case, and if any one logic predicted the patient to be controlled, the patient is taken as control. That is without a residual. The use of AND logic for cases and OR logic for controls is to prioritize specificity over sensitivity of The use of AND logic for cases and OR logic for controls is to prioritize specificity over sensitivity in order to avoid over-treatment of the patients. Coming to the results, the top 10 selected features using various scripts include the shape features such as elongation, maximum 2D diameter, surface area, surface volume ratio, and various textural parameters which talks about tumor heterogeneity. The significant and near significantly correlated radiomic features shown here are in concordance with the clinical and radiological understanding of tumor response to RT. That is, the results shows that the tumor with the larger size, tumor with the irregular surfaces, tumor with the invasive margins, tumor with the necrotic areas within, and tumor with a higher range of heterogeneity within or at higher risk for developing residual tumors. This proves the clinical validity of the selected features. Using those features, this table consolidates the performance of the individual model as well as the ensemble assembly. We can see that the ensembling of two models, outcomes from two models, improved the overall performance. The final performance ranged from 72 to 75% in terms of sensitivity, specificity, F measure, and area under the ROC curve, which is considered good for a prediction model. In the study, the radiomic features, which including tumor size, shape, textural heterogeneity, showed significant predict value, which were consistent with already published multiple multi-center studies. The combining clinical data with radiomics and ensembling of more than one model for predicting one outcome have improved the strength of the model and generalizability. The use of open source and standardized tools ensure reproducibility and transparency. With this context, we can conclude that this model can very well be used in clinical settings for selection of patients for novel intensification methods such as radiomics-based subregional tumor dose painting. With this, I can conclude that the CT-based radiomic machine learning modeling demonstrate promising non-invasive early prediction of residual disease in head cancers with improved accuracy and generalizability when integrated with the clinical data and ensembling.
The time is up.
Though prospective multi-initial validation is necessary. Thank you.
You said early you can pick up the residual disease. How early you can pick up the residual disease?
Even before starting the treatment, sir. All the planning CT images used were images used for CT simulation. So actually there are multiple models that included temporal features. They included CBCTs taken during treatment for prediction of outcome. But like main thing I wanted to use here is it has to be reproduced and it has to be as early as possible. So the treatment decision can be taken even before starting of the treatment. And all the tools used here are like free open source.
That's not enough, no? One set of imaging is not enough. You do weekly because hypoxia and everything shifts within the tumor. So you have to do multiple images to predict the model, not just one set of images.
Was the dose similar in all the set
Yes,
of
sir.
patients?
I screened almost more than 1,000 patients and I was very stringent with the selection criteria. So only 127 patients with the similar characteristics were selected for this study.
So did all receive chemotherapy in that term? Or?
No, sir. About 88% were received chemotherapy. That was also included in the model training, sir.
Okay, so which means a patient who did not receive chemotherapy may be having inferior survival?
No, sir. It was not correlated in the study.
No, it could have an inferior.
It could have, but it was included in the the main concept is combining CT radiomics, not only the CT features, along with the clinical data. The clinical data I used as T stage, N stage, site of the tumor, and whether the patient received chemo or not. So the model trained all these features along with the clinical data to give the outcomes.
What about the nodal sizes? Was it compared equally? See, a 2 centimeter node may look different from 4 centimeter node.
Yes, sir.
And it's not going to respond, it's going to have a residual.
Yes, sir. That's one of the features that was selected, sir.
And also the subsides also will have a difference.
Yes, sir.
So was all this taken into consideration?
Yes, sir.
So in spite of all this, you say there will be a definite prediction before?
Yes, sir.
Doctor, what is your take home? Are we evolving into radiomics or is there to stay? Because all the TNMs what we have been there for all these, at least for generations now, and still the answer lies there only. Where is radiomics? Is it just evolving or we are trying to build something?
The clinical features did not find major decision changing platforms in the model training, sir. The features I shown the most predictive value was size, maximum to design.
For residue as a therapy, as of now is TNM. Okay,
yes, sir.
Plus adding chemotherapy, minus adding chemotherapy, all those.
Yes, sir.
What is that? This is done different.
I combined the clinical existing data with CT mix. Yes, sir.
Not there.
Yes, sir. Like AI can be a playground we can play on, but when to be used in clinical context, it has to be proved with the existing parameters, sir. Yes, sir.
In textural heterogeneity, 3 things are important.
Yes, sir.
One is angiogenesis, hypoxia, and then necrosis.
Yes, sir.
How you are tracing that intratumorally?
So
in machine learning, in that concept, it's doing it, or how do you differentiate the dose inside the tumor?
So the radiomic feature extraction include like 107 parameters, sir. They include just the mean, median values and shape parameters like how elongated.
Shape and size.
Yes, sir. I'm coming to the next. And other than that, the third order features include the gray level matrix, which compare the like Hounsfield units of nearby voxels or group of voxels, or nearby pixels or group of pixels. It forms multiple matrices in mathematical algorithms and it matches. It reads the necrotic area as well as heterogeneity. Thank you.
I call Dr. Lakshmi, Madras Medical College, Interfraction Optic Nerve Movement and Planning Organ at Risk Volume Constraints, Designation.
Good morning all. My topic for presentation is interfraction, optic nerve motion and planning organ at risk, volume margins determination. Optic nerve is one of the important organ at risk in head and neck cancer radiotherapy. It is a serial organ with a dose constraint of Dmax less than 54 gray. As it is a mobile structure, it is at risk of interfraction and interfraction during radiotherapy. And the optic nerve remains a concern of unintended dose exposure that necessitates a PRV margin for it. As per head and neck OAR guidelines, the PRV for optic nerve is not particularly prescribed. My objective is to measure the interfraction positional variation of the optic nerve to derive the PRV margins for the optic nerve using adapted Van Ness formula and to determine whether the derived PRV margin is adequate. So it is a retrospective study conducted in Department of Radiation Oncology, Madras Medical College over a period of 3 years, studied on 50 patients. That includes sinonexal carcinoma and nasopharyngeal cancers and excludes the patients for whom the protein CT images are not available and for patients for whom the optic nerves are not identified in those CBCTs. So, the CT simulation was done in 3 mm slices. Then the target volumes and the OARs along with the right and the left optic nerves were contoured separately as per the standardized protocol. And during the course of treatment, CBCT was taken weekly. So in this study, 50 sinonasal and nasopharyngeal carcinoma patients were selected who had a minimum of 5 CBCTs that was taken during the course of treatment. 250 right and 250 left optic nerves were contoured in each CBCT. These CBCT were then registered with the planning CT. The interfraction movement was then measured at 3 anatomical reference points. These points are point A where the optic nerve meets the optic disc, the point C where the optic nerve enters into the optic canal, and a point B is a midpoint between A and C. The respective points were then compared in the axial slices of both CBCT and planning CT. The range of movement at these points were measured in millimeters and then documented patient-wise. So this image shows the pink color is the optic nerve that is contoured on the planning CT, and the green one shows the optic nerve that was contoured on the CBCT, and the movement measurement is same. So for deriving at PRV margin, the parameters required are the mean of individual patient, the population mean, the standard deviation, the variances, and the systematic error, that is the standard deviation of individual means, the random error, that is the square root of mean of the individual variance. So the PRV margin is derived using the adapted Van X formula that was given by McKenzie et al. As 1.3 times as a systematic error plus 0.5 times the random error. And the adequacy of the derived PRV margin at these points were assessed by calculating the percentage of the measured position variation within those margins. So my results. In this box with skirt plot, we can see the range of movement decreases from point A to point C. So from the collected data, the PRV margin was calculated at the point A as 3 mm, at point B as 1.7 mm, and at point C as 1.3 mm. My next objective was to check whether the derived PRV is adequate. So this chart shows the cumulative percentage of movement that was covered within the specified PRV margins at all the points. So if we give an isotropic margin of 3 mm, then it would cover 97% at point B and 99% at point C, but only 88% is covered at point A. So if we give a 4 mm margin, then 95% coverage can be seen in point A. Increase in coverage of movements with 1 mm increment in the PRV margin. So, highly significance can be seen when 3 to 4 mm movement is given. Where at a higher threshold, especially after 4 mm, the changes are generally not significant. So, a margin of more than 4 mm is not generally used. So optic nerve has 4 parts, out of which the intraorbital part being the longest, and it is the most mobile because of movements of the eye. The studies have shown that the anterior part of the optic nerve can move up to 5 to 6 mm, especially because of gaze shift. These movements are most in the anterior and it diminishes as it moves posteriorly. Patient instructions like gaze fixation or closing the eye can minimize the movement, but it can't diminish completely. So the main causes for optic nerve sparing misses are inter-observer variability and optic nerve motion, which causes unintended dose exposure that can lead to radiation-induced optic neuropathy, which is a severe complication with a threshold of 50 gray in conventional radiation, which increases sharply up to 20% when the dose of more than 60 gray is received. So, incidence of 9% is seen in nasopharynx and sinonasal carcinomas. The studies show that motion-induced optic nerve dose increase up to 9% in SRS. Isotropic PRV margins of 3 to 4 mm are recommended to encompass the observed movement and minimize geographical mistakes. In this study, the formula-driven PRV margin of 3 mm would cover 88% at point A and 97 at point B and 99 at point C. So, next. So with this study, it can be confirmed that differential PRV margin of 4 mm anteriorly at point A and 3 mm at point B and C can be given to the optic nerve to encompass the interfraction movement during radiotherapy. And these are my references.
Why do you really require point A in a sinonasal treatment or in nasopharyngeal treatment?
For measuring the movement of optic
Correct, but how significant it is? Point A is not going to come there at all, right? So why do you really need that point A there? Unless you are treating something in the orbit. So sinonasal you don't cover full orbit. So you don't need a point A there. You need only point C probably. So it really doesn't carry that significance for nasopharynx or a seminasal malignancy. So, and when you look at point D of dose, what about retina? Retina tolerates even lesser than that. How much does retina tolerate? 50 to 54, but actually 45 is an ideal dose to be safer on retina. So retina is much more sensitive there. You can have a blindness there rather than an optic project. Thank you, Dr.
Dr. Kaviyaredi, Government Hypofractionated Medical College, study on assessing the oral mucosity in patients with oral cavity carcinoma with intensity modulated radiotherapy.
From Government Hypofractionated College, this is my topic, study on assessing the oral mucositis in the patients with the oral cavity carcinoma with intensity modulated radiotherapy. Introduction: the oral mucositis is a common and debilitating side effect of radiotherapy in the patients with oral cavity carcinoma. It significantly impacts the nutrition, quality of life and the treatment compliance. The intensity modulated radiotherapy, with its ability to deliver the highly conformal dose by sparing the surrounding normal tissues, offers the potential to reduce the mucosal toxicity. To assess the severity of acute oral mucositis in the oral cavity cancer with intensity modulated radiotherapy of carcinoma oral tongue in oral mucosa sparing group and oral mucosa unsparing group. This is my methodology: prospective randomized control study with a period of 1 year from Jan 2024 to March 2025. 80 patients included in this study. In this study, no patients received prior adenic radiotherapy, no patients received prior induction chemotherapy. Inclusion criteria: histologically confirmed squamous cell carcinoma, patients consent for radiotherapy. The study variables were assessed: age, sex and surgery type, ECOG stage and dose to the oral mucosa and toxicity grading using archaeological reports. This is my methodology: patients with squamous cell carcinoma of oral cavity coming to the radiation and JOVI will be selected. Inclusion criteria were adopted: informed consent from the patient and randomized the patient to the arm A and arm B with the oral mucosa sparing and oral mucosa unsparing. Both patients underwent simulation with the 3 to 5 month dissection and oral mucosa was granted IMRT planning for oral mucosa sparing patients and unsparing patients only granted, no constraint was obtained. And the toxicity assessment weekly and followed by 3 weekly for post-RP stages. The study on arm A, the oral mucosa sparing group, oral mucosa was granted outside the PTV with the mean dose. This is my contouring. The mucosa covering the buccal mucosa, upper lip and lower lip. This is my result. There is no significance between the age and surgery type, gender of the patient and laterality of the tumor. This is the weekly assessment chart. There is a grade reduction in grade 2 and 3 in sparing group. While unsparing group, many of the patients, about 40% of the patients with with grade 3 toxicity, need for treatment intervention and rise to the incision, need of analgesics. This is my discussion. Oral mucosa sparing group significantly reduced grade 2 and 3 oral mucositis, improving the patient comfort and compliance during the treatment. Significant reduction in the mean dose to the oral mucosa was seen in the sparing arm. The p-value is p-value of 0.021. The dosimetric advantages of sparing the oral mucosa translated into a clinically meaningful reduction in oral mucositis-related pain and analgesic use. The limitation is a small sample size and single-centered test. This is my conclusion. The prospective randomized trial shows the oral mucosa sparing can reduce the severity of acute oral mucositis and improve the quality of treatment during the treatment. This is my reference.
What was your oral care protocol you followed?
For all the patients, we have soda salt carbon for all the patients. But for grade 3 and grade 4 toxicity, we have include glutathione and IV antibiotics.
How did you take an informed consent for both the groups? You told that one will have less toxicity than the other. How did you randomize? For the informed consent, you would have explained, no, it's a trial in which one group will have more toxicity than the other.
No, not for that, ma'am. We have informed consent for radiotherapy, ma'am. For radiation treatment also, not for constants.
Is it a prospective randomized or a retrospective study?
Prospective.
Then you must answer madam's question. What is the consent? See, what she is trying to ask you is, one arm you are doing sparing and one not sparing. Which means you should tell the patient that I am not doing this, I am doing that. That is what consent means. Because you are doing a research, right? But as a standard, you will do a sparing. So when you are doing something standard or not standard, you must always inform the patient. That is what she is asking. Inform the consent.
Generally, the consent is not informed consent. For the trial, you should take an informed consent. And they have taken that.
Your ethics committee should ask that. Whenever you are present in the ethics committee, they should ask what is the ICF that you are going to give to me. You know, you included some post-op patients. What are those post-op cases that you?
Local excision patients.
So that means the mucosa will excise?
Mucosa not exist, but tongue mucosa exists, sir. We can't have only buccal mucosa.
Only tongue lesions,
Yes.
not the buccal mucosa.
Not buccal mucosa.
Thank you. Carry.
Thank you, Doctor.
I call upon Dr. Vinay Padmanabhan, Government Parigarana Cancer Hospital, Kanchipuram. Radiologic signatures for predicting PCR and rectal cancer, a multivariate model based on MRI biomarkers and post-neoadjuvant chemoradical.
Good morning. I bring on greetings from Government Haryana Memorial Cancer Hospital. I am Dr. Vinay Padmanabhan, and my presentation is on. My presentation is on predicting PCR and rectal cancer with radiologic signatures based on a multivariate MRI-based biomarkers. And since the background of rectal cancer is slowly moving towards organ preservation, we need to be able to reliably predict what is going to be the result that we are going to achieve with neoadjuvant chemoradiation. If we have reliable biomarkers with possible prediction variables, we could identify which patients are good possible choices for de-escalating therapy if possible. So we aim to develop a multivariate predictive model with radiomic biomarkers for pathological complete response following neoadjuvant chemoradiation in locally advanced carcinoma rectal cases. So we did a prospective analysis and we took in all the patients who had completed long course concurrent chemoradiation for locally advanced biopsy adenocarcinoma proven rectal cancer patients. And preoperative MRI was done and it was reviewed for the MR-based tumor regression grade, extramural venous invasion, circumferential resection margin status, and hyperintensity on DWI-weighted imaging, and craniocaudal tumor length and distance from the anal verge, and other factors that were taken from the clinical parameters were also included in the model based. all the statistical analysis was done with SPSS. Since the number of patients was comparatively less for making a machine learning model sufficient, we had to go with a logistic regression pattern. And we took the definition of pathological complete response to include near complete responses, because several studies including Electran, Desco, Ectal and Cocaine et al. Had already taken near complete response as with YPT1N0 and minimal residual tumor cells to be equivalent to pathological complete response, that is YPT0N0. And therefore we also did a stricter analysis with the sensitivity constraints saying YPT0N0 is only PCR, and it reflected real world data as with around 17% rates of PCR. But it was with attenuated significance, and due to low event numbers, we had to go with the near complete response being included in the study. Multivariate logistic regression was done, and the discriminative performance was also analyzed with the receiver operating characteristic curves. So what we found with the logistic regression model was that the MR based tumor regression grade was the only significant parameter that could independently predict the performance of the model. And we did, with the sensitivity analysis, we found that both MR based tumor regression grade, that hyperintensity in DWI weighted imaging and tumor craniocaudal length were all significant factors in the ROC curve. But still, MR based tumor regression grade was the only one which was independently able to predict it with a p-value of 0.012. So, absence of DWI hyperintensity was also significantly associated with the AUC values being significant with 0.295, but it did not reflect upon it in the multivariate regression model. With a statistical significance of less than 0.001, MR based TRG was the most accurate predictive model for pathological complete response, which is slightly contradictory to what Mercury and several other larger trials have been documenting. So we wondered whether MRI can be taken up as an adaptive tool in addition to being the investigation of choice in rectal cancers. We can also already MRI is being implemented into the high resolution MRI has been implemented into the clinical paradigm. And why can we use MRI as a proper decision making tool to be able to predict complete clinical response and therefore spare the patient of a debilitating surgery earlier. So with larger validation and incorporation of total neoadjuvant therapy data, we might be able to make a more robust predictive model using this as a initial building framework. So we conclude that MRI-based biomarkers, mainly involving MR-based tumor regression rate, is a good non-invasive imaging biomarker capable of making adaptive management strategies for carcinoma rectal. And we believe that prospective validation with a higher sample size might be able to give a better prognostic model in the future. We also believe that apparent diffusion coefficient data as measured with DWI could also be incorporated into structured reporting of MRI parameters, since this data is often not inconsistently being reported in common MRI reports. So with this we may be able to make a reproducible and generalizable MRI based predictive model for the same. Thank you.
What sequence?
T1 weighted imaging, T1 with contrast, T2 and flare imaging.
What MRI you have?
Our definitions for high resolution MRI included all these sequences, but some of the sequences were deficient in reporting several of the one or two of the parameters. So we took whichever had near completely documented the MRI.
Do you have 1.5 or 3 Tesla? What MRI you have?
1.5 Tesla MRI.
So do you think 3 Tesla will give you more information than 1.5? Did you ask your radiologist?
We had not looked into the same.
I believe MRI is obviously used as a marker.
Yes, sir, but with the MRI, we plan to make a predictive model itself with a formula-based calculation. But if multiple parameters had become significant, we could have developed the logistic formula with the same, sir. Since MR-based TRG score was found to be the only parameter that was statistically significant, we didn't make a formula for the same.
Very excellent one. Very happy Kanchipuram is doing this because all over the world this is being followed, and MRP, tumor regression model is what's being used everywhere, especially in weight and watch policy. It is mandatory to incorporate this. Very happy that this comes from Kanchipuram, and I think you need to sit with the radiologists more, and they also should look from oncologist perspective because this is RCC person, so they should look and say from deficiency in reporting that should never happen from that instance.
Yes.
Okay. Thank you.
Thank you, sir. Thank you. Next talk.
Dr. Nirmala Priyanka G. Kupuswamy Hospital, a comparative dosimetric study in patients with locally advanced cervical carcinoma, understanding high dose brachytherapy performed under general anesthesia versus consciousness.
Good morning, everyone. I am Dr. Nirmala Priyanka, first year oncology resident from Keynote Hospital. So we have done a comparative dosimetric study in patients with locally advanced cervical carcinoma who are undergoing high dose intracavity brachytherapy, which is performed under conscious sedation versus general anesthesia. The aim of our study is to compare the doses received by the tumor and the OAR in cancer cervix patients who are treated with high dose intracavity brachytherapy under general anesthesia and conscious sedation. And our objective is to answer how HDR ICPT performed under GA and CS is going to influence the doses to the tumor and the OAR, and to evaluate the pain score in these patients using Wong-Baker's spatial pain scale and the time to rescue analysis. So our study is an observational comparative study. Sample size is 76 in each arm, with each fraction of brachytherapy was taken as an individual sample. Methodology. So we included patients who are histologically proven cancer cervix with FIGO stage 1 BC to 3C2, with ECOG performance status of 0 to 2 and age between 18 to 75, and to completed concurrent Re-irradiation with HDR ICPT, with cisplatin dose of 40 mg per meter square once weekly and EBR dose of 50 to 50.4 grade with 4 pills, plus or minus simultaneous integrated boost of 56 grades involved notes, and ICPT using Fletcher's amplifier, tandem and ovoid, the dose prescription of 7 grade to 0.8. The clinical and the demographics of the above patients who are fulfilling the above inclusion criteria, we are collected from the EMR. And the dosimetry and the clinical parameters of the GA arm we collected prospectively. And the data we collected prospectively, we compare it with the retrospective data of the patients who underwent ICPT under conscious sedation. The general anesthetic agent we used were propofol and sevoflurane, and in conscious sedation we used formol and phenol. Brachytherapy schedule we used CT-based brachy planning using onset planning system. With the dose prescription of 7 grade to 0.3, and the source we use is iridium 192 remote anesthetic unit. And these are the parameters we assess: the length of the tandem, size of OR, D90 dose to point B, D 0.1 cc, 1 cc, 2 cc of the OAS, and the pain assessment using Wong-Baker's spatial pain scale. So based on patient tumor characteristics, majority of our patients were in the age group of 41 to 60 years with a median age of 54 and the ECOG performance status of 2, EBR dose of 50 grade, and histopathology of squamous cell carcinoma with grade 2 and FIGO stage 3 C1 being the most predominant category. So coming to the results, as we can see in the GA arm, most of the patients were lying between most of the patients we are able to insert a tandem lens at till 5 to 6 centimeters with a median of 5 centimeters, whereas in the conscious sedation arm we are able to insert only between 4 and 5 centimeters with a median of 4 centimeters. So this the length of the tandem in the GA arm showed a statistically significant difference. Coming to the overt size, in the GA arm we were able to insert only between 1.5 and 2 centimeters, whereas in the conscious sedation arm we were able to insert between 1.5 and 2.5 centimeters. But the median in both the arms remained the same as 2 centimeters. Coming to the D90 dose, D90 dose in the GA arm, as you can see in the box is specified, that's slight increase in the dose, D90 dose in the GA arm compared to the CS arm, but it didn't show any statistically significant difference. And the point B dose, both in the right and the left side, there is a slight increase in the point B dose in the GA arm compared to the CS arm, and it showed a statistically significant difference with the p-value of 0.0. Coming to the OR doses, the D2cc of the rectum and the bladder, as you can see in the GA arm, there is slight increase in the D2cc of bladder and rectum, but it didn't show any statistically significant difference. Whereas in the sigmoid dose, there is an increase in the dose to the D2cc in the GA arm, and it showed a statistically significant difference. 50% of our patients we have seen in the GA arm experienced only mild pain with a median time to rescue analgesia of 90 minutes. Coming to the discussion under GA, we were able to insert longer tandems than in the than in the conscious sedation, but the median ovoid size in both the arms remained the same, and the D90 doses are also similar between the two arms. The point B doses show a statistically significant increase in the GA arm compared to the CS arm, and there was no statistically significant change in the bladder rectum dose between the two groups, and most of the patients in the GA arm experienced only mild pain. These are reference that was similar to the following reference like Sharma et al., Ratu et al., Mahapatra et al. Conclusion: providing adequate sedation in the GA arm enabled the insertion of longer tandems with mild peri-procedural pain, which needed minimal intervention, and our study did not demonstrate a dosimetric advantage of GA compared to CS, but provided utmost comfort to the patient, both the patient and the physician. The limitation of a study where each fraction of the same patient was taken as a separate sample with no head-on comparison between the fraction, and pain was announced prospectively only in the GA arm, and it was not compared with the conscious sedation arm. Further, a long-term study with a larger sample size with head-on comparison is required. Thank you. Sir, since there is a retrospective data, we could not assess the pain score.
Okay, what were the indications for CS? Why were they done under conscious sedation?
Initially, we were practicing only, we are doing brachytherapy only in conscious sedation. So while we are starting the study, we have shifted to GA, sir. GA has become standard of care in our institute, sir. So that's why we have collected retrospective data of conscious sedation patient, and we prospectively followed up the other
Your point is study or volume study? Why there's increase in point B doses? Point A you have said, point B will be longer, dose will be high. Why?
Yes, we could not interpret that well. Actually,
so when longer tandem, point B will be high. Short tandem, there will be less.
Okay.
Because of longer tandem, contribution to
point B dose is higher.
I have only suggestion. Hello. Kindly do not use local, always GA. Because it's for study whatever you do is okay. But it is ideal to have maximum packing, which is possible only with GA. Otherwise it will be painful. Number one. Number two, the separation is more important to extend the door to the lateral wall of penis. So under local, they are able to have only 2 centimeters. If it is GA, it is going further. Itself will indicate the possibility of pelvic errors.
Yes.
Thank you.
Thank you.
Thank you, doctor.
I call upon Dr. Godson, Cancer Institute. Prognostic insights from metabolic tumor volume and total glycolysis esophageal radiology.
Good morning all. My presentation is titled Volume Speaks Louder, Prognostic Insights from Metabolic Tumor Volume and Total Lesion Glycolysis in Esophageal Cancer Radiation Therapy. Esophageal carcinoma is often diagnosed in a locally advanced stage, and all patients will invariably require multimodality treatment. So for squamous cell carcinoma of esophagus, cross protocol is our standard of care, and esophagus. And as oncologists, our eyes are always driven towards the this parameter, SUV max. We always end up looking at it. But then it got me thinking, are there any better parameters to assess the tumor volume? So when I did some digging, I was able to find out that we do have two parameters. One being metabolic tumor volume and the other one being total lesion glycolysis, which we tend to forget a lot of times. So now the aim of the study is to assess the prognostic implication of PET-CT based parameters, both being MTV and TLG, with relevance to pathological response rate in patients with squamous cell carcinoma of esophagus. The rationale for this being our conventional PET marker being SUV max does not completely reflect on the tumor heterogeneity. Thereby, its accuracy is very limited. But when we talk about volumetric parameters such as MTV and TLG, it integrates the tumor volume as a whole, and it gives us a holistic assessment of the tumor biology. Since I've spoken about SUV, MTV, and TLG, when we look at a picture, it's made up of a lot of pixels. So a pixel is a two-dimensional representation, whereas when we look at a CT or an MRI, it is a three-dimensional volume. So that volume will be broken down into multiple small spheres which are known as voxels. So an SUV max refers to the maximum FDG uptake in one single voxel of our given tumor. SUV mean will refer to the average SUV uptake across all voxels. But when we talk about MTV, it talks about all the tumor voxels which will have an FDG uptake. So this will give us a better idea of how much of the tumor is actually metabolically active. A tumor may have certain areas with no FDG uptake. There may be certain necrotic areas which we may take into consideration, and this may help us overestimate the actual tumor volume than what it actually is. TLG is nothing but a product of MTV and SUV mean. In this study, we used fixed thresholding method to assess the metabolic tumor volume. For that, fixed uptake SUV cutoff of 2.5 was used. So all voxels beyond 2.5 were taken into account for addressing the metabolic tumor volume. This is a single-arm prospective study done across 12 months. We had 18 patients who are all squamous cell carcinoma of esophagus taken for cross-protocol. So our workflow is, after diagnosis, we do a PET-CT and we assess MTV and TLG. And after MDT discussion, the patient is taken up for cross-protocol. We complete neoadjuvant CT-RT, with, following which, after 4 weeks, we do a repeat PET-CT. We reassess the patient's MTV and TLG by week 4. And by week 6, the patient is taken up for surgery. And we go through the post-op histopathology reports. And in our post-op reports, we use modified Ryan's tumor regression score. So it has 4 grades. Grade 0 is complete response, grade 1 is near complete, grade 2 is partial, and grade 3 is poor or no response. So for statistics, we clubbed grade 0 and 1 as complete responders, and grade 2 was incomplete or inadequate responders. So we had 18 patients, and out of which 12 had complete response and 6 had inadequate response. It is to mention that 9 of these 18 patients had pathological complete response in our cohort. So these two tables, MTV definitely had a significant decline post neoadjuvant treatment. Same goes for TLG. For MTV, there was almost a 4-fold decrease, and in TLG, there was almost a 6-fold decrease post neoadjuvant treatment. On the left is MTV, right is TLG. We are comparing MTV and TLG with histological response. These results, we were not able to find that it was statistically significant. In the responders, post-treatment from 42, MTV volume had reduced to 13, and in the non-responders from 15 it had reduced to 10. Despite non-responders having a much higher drop in MTV, still PCR rates or complete response was not attained in them. Same goes for TLG, it was more or less a steady decline across both groups. and we try to assess the magnitude of fall in MTV and TLG. Delta MTV is the difference between pre-treatment and post-treatment MTV. Same goes for TLG as well. In the non-responders, they had a higher variation in their delta MTV values, but this did not correlate with histological response. So both MTV and TLG did show reductions after neoadjuvant therapy, which was statistically significant, confirming that metabolic tumor regression is present. However, neither absolute delta MTV or TLG values correlated with PCR rates. One of the few factors were tumor heterogeneity and hypoxia. The merits of our study was that we had a single nuclear medicine physician who altered our PET CT and gave us MTV volumes. So there was very limited inter-observer variability. And demerits include limited sample size and lack of survival endpoints. So I can conclude that these volumetric parameters reliably capture treatment-induced metabolic changes. And in future directions, now there is evidence for wait and watch in esophageal cancer as per the SANO trial, where after cross-protocol, patients with complete response are kept under observation. So building on this study, we will be able to quantify metabolic tumor parametrics to assess those patients who will do well post neoadjuvant chemoradiation, and we can keep them under observation.
You conclude saying it doesn't have any predictive value.
In our sample size, because it was limited.
With 18 patients, you don't have a predictive value. What do you expect if you increase it? It's a negative study.
With a larger cohort, we do feel that it can more insights.
Thank you.
Study in the right direction. Study in the right direction. But only, of course, as you said, limitation is your sample size. The comparison always is with the SUV itself, because you have never compared anything with SUV. 3 arms, one is SUV, your main MTV, and then TLG. SUV was never there in the picture. Okay. Everybody works only with SUV right now. These are future directions. So when you incorporate, I think you should incorporate study with SUV also. Increase the sample size, it will give you results. Because like wait and watch in rectum, esophagus also is coming to move. Here MRI there scores, here MRI is difficult to score. You need a PET here to do that. It's a good direction, but you need to work more on it.
Do you think the dose what giving and concurrent chemo is enough for esophagus to be in the observation now?
For definitely.
So what do you do in an inaugural patient where surgery is not the?
We can escalate up to 50 grays.
Other thing, do you give an adjuvant chemo after that? Possible or not? Yes, sir. Yes. So do you think that the dose will be sufficient for these patients? 41 grays and just 5 weeks of paclitaxel? Even though there is a response, we will see an early recurrence, right?
As far as the study that I have quoted is the SANO trial, and their 2-year survival rates for the observation arm was 72%, whereas those underwent surgery was 71%, showing that so far it is non-inferior. So we do require
the pathological CRs, or maybe the CR is good, but how early will the recurrence be there? The recurrence chances are very high in arm which doesn't have any further treatment. So in our routine practice, what we do is, though we see a CR, we add 4 more cycles of chemo. Thank you.
Thank you.
I call upon Dr. Shivani, Cancer Institute, Radaya. Evaluation of post-mastectomy chest wall surface dose in 3D conformal radiotherapy. The virtual bolus versus gel bolus in D.
Good morning. I'm Dr. Shivani, finalist resident from Cancer Institute, Radaya. I'm here to present my topic, evaluation of post-mastectomy chest wall surface dose in 3D conformal radiotherapy with virtual versus gel bolus in TPS, a pilot study. The aim of the study was to compare the surface dose received by the chest wall, including the scar agent when a virtual bolus is used, and when an actual bolus is placed over the thermoplastic mold in the TPS. So rationale of the study: during the routine CT simulated planning of mastectomy subjects, we do not usually use gel bolus over the patient for planning purposes, but a virtual bolus is placed during the computerized radiation planning and dose to the chest wall is computed accordingly. However, there will be air gaps in the areas of surface irregularity between the gel bolus and the mold, which will attenuate the dose received at the skin surface. So primary objective of my study was to compare the surface dose distribution with virtual bolus with the plan done on CT with the bolus applied. So secondary objectives was to prove whether bolus must be applied over the mold during CT planning procedure and to analyze the factors that are influencing the skin dose in the virtual and the gel bolus plans. So 20 patients requiring post-mastectomy radiation to chest wall, SCL, plus or minus IMN, plus or minus axilla were included from September 2024 to December 2024 at Cancer Institute, Adyar. So inclusion criteria: more than or equal to 18 years of age, and radiation to chest wall, SCL plus or minus IMN, ECOG performance status 0 to 2, no prior history of irradiation, no history of autoimmune disorders like SLE, rheumatoid arthritis or Sjogren's, and patients receiving trastuzumab TDM were also included. Exclusion: male breast cancer, pregnant or lactating women, serious medical illness or psychiatric illness that will limit the study, and tissue expanders or implants or autologous tissue reconstruction, bilateral breast cancer, and patients requiring boost doses. Thermoplastic methods: thermoplastic mold was done with the arm subjected over the breastbone, and a 0.5 cm bolus was applied over the mold, and a CT was taken. One more CT without the bolus was also taken with 5 mm cuts. The contouring was done according to the RTOG contouring guidelines. The PTD for the separate structure called skin was generated by cropping 3 mm from body for both the chest wall and the scar regions. The treatment plans were generated from the Varian Eclipse planning system TPS version 15.5. 3 plans were generated, one with visual bolus, one with gel bolus, and the one with no bolus. So fractionation was 2 gray per day, 5 days a week for a total dose of 50 gray. So hotspot of 115% was allowed. All patients were executed with the visual bolus plan. During the treatment, 0.5 cm bolus was placed on the mold, and the treatment was executed with bolus for 3 treatments and no bolus for 1 treatment up to 30 gray, and thereafter no bolus was placed till completion of 50 gray. The maximum, minimum, and the mean doses were evaluated on the TPS for the organ skin and then compared for both the plans. Various factors like age, size, location, grade, stage, type of cancer, molecular classification, type of chemotherapy, comorbids, menopausal status, height, weight, BMI are also evaluated for any association with these doses using the Kendall-Stowe correlation test. So these are my results. Majority of the patients were less than 60 years of age group. Majority of patients were more than 60 kgs. Majority of the patients were shorter of 155 centimeter and less. There was equal distribution between the premenopausal and the postmenopausal patients. So right side patients were more than the left side patients. Upper quadrant tumors were more than the lower quadrant tumors. Invasive ductal carcinoma was the majority, occupying around 85%. We also had invasive papillary, metaplastic, and mixed ductal and lobular carcinoma. So grade 2 was the majority, followed by grade 3, followed by grade 1. Staging we had from 2A till 3C, the majority was 3B. Type of chemo, the dose AC Taxol was the majority, followed by 3-weekly AC Taxol. We also had other chemotherapy like AC Taxol Carbo, 1-weekly Taxol Carbo, and dose AC Taxol Tras2, 3-weekly AC Taxol Tras2, and 1 patient with no chemotherapy. So you can see the differences here. The minimum difference in the minimum skin dose was around difference minimum was around 0.5 gray, and the maximum was around 4.2 gray. And the maximum dose, the difference minimum was 0.1 gray, and the maximum was 2.7 gray. And the in mean skin dose, the minimum difference was 1 gray, and the maximum difference was 3 gray. So you can clearly see the separation of curves between the virtual and gel bolus plans for the minimum skin dose here. There's a wide separation. Here you can see the mean skin dose. Also there's some points of coincidence, still there is a difference. Not much of a difference, but still there is a difference. And max skin dose, some points of correlation, still there is a difference between the two plans. So this is a color wash showing the virtual bolus plan, and you can see the uniformity of the virtual bolus, and there is no air gap underneath, and the uniform dose distribution of around 55 gray around the target. This is the gel bolus plan clearly showing the air gap and the underdosed skin below. So it's receiving only around 45 gray compared to the other areas of 55 gray. factors influencing the type of chemo showed negative correlation with the difference of the mean skin doses and was statistically significant. Next slide. Next. So among the 7 groups, no chemotherapy group had the greatest difference compared to the chemotherapy given group. So within the chemotherapy group, Dostan's AC-Taxol and Dostan's AC-Taxol with weekly Trastru had the highest difference, while 3 weekly AC-Taxol Harpo had the lowest difference. Next. Height was negatively correlated and grade was positively correlated with the difference bolus max skin dose, and both were statistically significant. Next. Next slide. Next slide. Age and menopausal status both were negatively correlated with gel bolus minimum skin dose, and both were statistically significant. Next slide. Group staging was negatively correlated and comorbids were positively correlated with Richmond bolus minimum skin dose, and both were statistically significant. So patients with multiple comorbids had higher Richmond bolus minimum skin dose. Next. So post-mastectomy radiotherapy has regularly been used to improve the local regional control and overall survival in high-risk breast cancer patients. So it has been a routine practice to use a gel bolus in the ratio of 3:1 in our institute for locally advanced breast cancer patients. Next slide. So however, during the routine CT planning of these patients, routinely gel bolus is not used during the planning purposes. However, the ritual bolus is more uniform and conformal, whereas the gel bolus that is used is showing air gaps between the bolus and the thermoplastic mode, which may attenuate the skin dose that is received underneath. Next. Previous studies have shown that for up to 10 mm air gap between the bolus and the skin, there is only a small difference in the skin doses received by Butson et al. And there is a wide difference for patients with small field sizes and large surface irregularities. It was reported by Yusuf Khan et al. Next slide. In our study, we have found that there is a statistically significant difference between the minimum, maximum, and the mean skin doses of the gel and the visual plants.
We are running behind time.
Yeah. While analyzing the color wash chart, we can see that the skin beneath the air gap clearly shows a lower dose compared to the other areas of the skin. So other factors like age, height, grade, and menopausal status, group staging, comorbids also affected the skin doses received, though these are non-modifiable factors. So however, the air gap beneath the skin that is creating the underdosed area can be modified by using methods like 3D printing. So conclusion, that since there is a significant difference in all 3 skin doses between the 2 plants, it is ideal to use a physical bolus during CT simulation instead of using a virtual bolus for plan evaluation. Next slide. So future perspectives, a randomized trial can be done with virtual bolus and gel bolus, comparing the to clinically validate the same, like evaluating the 5 DFS and overall survival of the patients. A randomized trial comparing the use of 3D printed bolus and gel bolus in our patient population can be tried, and use of in vivo dosimeters like TLDs or MOSFET should be used instead of TPS calculations, which should be more accurate. These are the references. Thank you.
I have
Yeah, sir, we have one record.
I have 2 questions.
It's a pilot study. We do it features.
I have 2 questions. Like nice presentation, but one thing what I'm not able to understand, we have moved on from bolus to this thing and up to 3D printing. Why not from 50 grade to 40 grade?
We are doing 40 grade as well.
Why was your study was in 15, 25?
We are
So
slowly changing
when you're
to
practicing 40, 50, you should try protocol also should reflect.
Now, volume are very big. Sir, ma'am, the volumes are very big, ma'am. We have got a lot of IML positivity and axillary node positivity. It's difficult to achieve those constraints, ma'am.
Yeah. So the second question
We
is,
are moving forward, but still not.
the second question, what is the hypothesis of this study? Because everybody knows that when you place a flash like a virtual bolus, it's going to fit into the skin. So what is the hypothesis of this study?
there is a, we have dosimetrically analyzed the skin dose, whether there is a difference between the 2 or not. So there is no difference, will be the null hypothesis. There is a difference will be the
So you crop the skin of your body. You expect it to be less. You not crop. So you're not following RTOG protocol also. But everything is still.
We have a discussion among yourselves during the break.
Thank you, Shivani. Thank you very much.
I call upon Dr. Sri Vishnu Cancer Institute, the prospective pilot observational study and the impact of sarcopenia on acute and late toxicities in locally advanced head and neck cancers receiving concurrent chemoradiation.
Good morning on the top. This is Dr. Vishnu, pioneer postgraduate My topic is on the era of obesity, impact of sarcopenia on acute and late toxicities in locally advanced head and neck cancers receiving concurrent chemoradiation. As we all know, concurrent chemoradiation remains the cornerstone in managing the inoperable locally advanced head and neck cancers, but it carries a significant toxicity burden. Increasingly, sarcopenia means the loss of skeletal mass and the function, and that is being recognized as a key determinant of treatment tolerance and outcomes. So, this prospective pilot study evaluates the impact of pre-treatment sarcopenia on acute and late toxicities in patients undergoing chemoradiation. Using the CT-based skeletal muscle assessment at the C3 level, we stratified the patients and correlated sarcopenia with toxicity grades, treatment interruptions, and early response. Our findings aim to position sarcopenia as a clinically relevant predictive marker, supporting its integration into routine pre-treatment evaluation to guide personalized supportive care in this high-risk population. So, the study aims to prospectively assess whether pre-treatment sarcopenia influences the frequency and severity of acute and late toxicities in patients with locally advanced head and neck cancers, receiving definitive CTRT, and to examine its relationship to treatment tolerance and short-term oncological outcomes. So, the rationale behind this study is the patients with locally advanced head and neck cancer often present with the baseline malnutrition and catabolic stress due to tumor location, dysphagia, and systemic inflammation. So, body mass index is traditionally used to assess the nutritional status. It fails to capture the skeletal muscle depletion, especially in sarcopenic obese individuals. So, sarcopenia quantified CT-based skeletal muscle index at the C3 level has emerged as a potential biomarker of treatment vulnerability and predicting both the acute and late toxicity and treatment response in various cancers. However, its prognostic utility in the setting of CTRT for head and neck cancers remain underexplored. So, this study addresses the gap by prospectively correlating the baseline sarcopenia with treatment-related toxicities, nutritional compromise, and radiological response, with the ultimate aim of guiding risk-adapted supportive interventions and improving the therapeutic outcomes. So, as our study is a prospective pilot study, and we had treated the patients with received a treatment with the different RT techniques, that is 3D conformal, IMRT, and VMAT techniques. A total dose of 66 gray and 200 centigrade per fraction and 33 fractions as per plan. Chemotherapy of concurrent CTRT with a 3-weekly or weekly cisplatin or weekly carbamazepine or docetaxel or TPF will be decided based on the fitness and initial protocols. The inclusion criteria includes the patient of age 18 to 70 years were included, and the biopsy proven squamous cell carcinoma of oral cavity, oropharynx, larynx, and hypopharynx were included. The stage 3 to 4 disease were deemed unresectable. The ECOG performance status of 0 to 2 with the adequate liver and the renal function tests were included in our study. And patients with the performance status of more than or equal to 3 with a prior radiation to the head and neck region and presence of metastatic disease were excluded. And assessment were done, toxicities were graded using CTCAE 5.0, and acute toxicities were monitored weekly during the treatment and up to 3 months post-treatment, and late toxicities were assessed beyond 90 days post-treatment, and tumor response were evaluated at 6 to 8 weeks post-treatment via RSS 1.1 criteria, and local disease control were determined through clinical examination and imaging at the follow-up. And this is our workflow for assessing sarcopenia. The patients were first screened, and if their eligibility were assessed, and if the patient is eligible, then getting that informed consent, the baseline data collection, then during our routine CT planning, CT simulation, then we have to grade that patient as sarcopenic or non-sarcopenic individuals, and after that the patient have to receive that CTRT or CTRT with any chemo or and post the chemo, then we have to do that monitoring of acute and late toxicities, and after that we had analyzed our data, and that will be discussed in the results. And 40 patients with the stage 3 to 4 unresectable head and neck cancers were recruited for this prospective pilot study, and all the patients were planned for definitely CTRT or radical radiation. The pre-treatment contrast enhancing CT stimulation of head and neck were performed per protocol, and skeletal muscle mass were assessed at C3 level due to its validated correlation with the L3 muscle mass. Where manual segmentation of bilateral sternocleidomastoid and paravertebral muscles were done using that minus 29 to plus 150 pounds per unit threshold, and the cross-sectional muscle area were calculated using the imaging software. Whereas CSA at the C3 were converted to estimated C3 at the L3 using the SWOT regression formula, and with the sex ordered as 1 for female and 2 for the male, where the L3 CSA is normalized by the patient's height in meter square to derive the skeletal muscle mass index to the whole body. Whereas skeletal muscle index is used to categorize the patients into sarcopenic, borderline sarcopenic or non-sarcopenic groups, where this is the cutoff groups for the males and for the females, and based on their BMI, it's been termed as sarcopenic and non-sarcopenic. Now you can see the results. As from our study, where 70% of people were males and 30% were from females, and their comorbid associations were 60 were associated with comorbids, and 40% were not associated with any kind of comorbids, and 63% were smokers, and 37 were non-smokers, and the smoking and sarcopenia association were significantly established, and among the 40 patients. Among the sarcopenic individuals, 40% were associated with the smoking, and even the tobacco association and the alcohol association was established. So the BMA across the cohort, even the overweight and the obese and normal weight people are also having sarcopenia was established. Excellent. And the acute toxicity.
Time is up.
Yeah. So with the stacked bar chart, even with the sarcopenic individuals, even with the non-sarcopenic individuals, the grade 3 or grade 2 acute xerostomia and the toxicities were seen more among the sarcopenic individuals than the non-sarcopenic individuals were assessed. Next. So in a cohort of 40 head and neck patients, 51% were sarcopenic and 37% were borderline, and 12 were non-sarcopenic based on CT derived muscle index, and the sarcopenia were more common in older males and not limited to underweight patients. BMI did not reliably predict sarcopenia, which was found across all BMI categories. Diabetes was the most common comorbidity and significantly associated with the sarcopenia. Sarcopenic patients had a higher rates of feeding tube dependence and persistent dysphagia post-treatment. They also faced more dose reductions and interruptions due to the acute toxicities. Severe mucositis and dermatitis were more frequent in the sarcopenic group, and the sarcopenic individuals experienced greater weight loss, and late toxicities like aspiration and chronic dysphagia were predominantly seen in the sarcopenic and borderline sarcopenic patients. Next. The limitations were the small sample size limits the statistical powers and increases the variability and restricts the subgroup analysis, and the short follow-up of 8 weeks for the response assessment, and also for the late onset toxicities and recurrence, underestimating the sarcopenic's long-term impact. The muscle was assessed via the C3 CT scans and converted to the L3 SMI, which may introduce the measurement bias.
Thank you so much.
No, that is all mentioned in the limitations, but we can do it in our further studies.
Thank you, Doctor. It was nice. We'll go to the next stage. Thanks. Thank you.
The compound of Bhavani Venkatesan Cancer Institute, Adaya, a pilot study for hypofractionated neoadjuvant concurrent chemoradiation in stage 3 inoperable and locally advanced breast cancer patients from a tertiary cancer center in southern India.
One and all present here. Myself, Dr. Bhavani from Adaya Cancer Institute. I sincerely extend my thanks to the guide and HOD, Dr. Priya, for giving me this opportunity. My topic is hypofractionated neoadjuvant concurrent chemoradiation in stage 3 inoperable locally advanced breast cancer patients, a pilot study. Next slide. Next slide, please.
Study introduction. Hypofractionation has revolutionized the breast cancer radiotherapy, delivering the same powerful punch to the cancer cells in fewer and smarter sessions with equivalent oncological outcomes. Backed by game-changing landmark trials like START, FAST and FAST Forward, reducing the treatment time from 5 weeks to as short as 1 week without compromising the cure rates. Patients experience fewer side effects, better comfort and improved quality of life as well. It's a win-win, less travel, less cost and effective approach. My study is also the same, and this is being globally endorsed by ASTRO, ISRO and NCCN as hypofractionation isn't just a convenient but also the new gold standard in breast cancer care. Aim of the study's primary endpoint is to assess the feasibility and the safety of hypofractionation in stage 3 inoperable locally advanced breast cancer inoperable cases, and secondary endpoint is to assess the quality of life of these patients. Study rationale is that patients with locally advanced breast cancer who are inoperable at presentation, we usually treat with NACT, neoadjuvant chemotherapy. But we have our own institute data adding the radiotherapy along with the chemotherapy in the neoadjuvant setting. And this study is looking for the feasibility and safety of hypofractionation, delivering a total dose of 42.5 gray at 2.66 gray per fraction for 5 days a week, combining with the 5th and the 6th Taxol, which is given dose days. Study design, we had included 8 breast cancer stage 3 inoperable LABCs, single center, single arm pilot study. Inclusion criteria, all inoperable stage 3 cases, age between 18 to 70 with good performance status and EF more than 50. Rest all are the exclusion criteria. Next. Workflow is that patient selection followed by counseling and getting an informed consent for the same, and baseline evaluation with ECG, echo and base lab investigations. CT simulation, we had done treatment planning with 3D CRT and to a total dose of 42.6 gray, then combining with the 5th and the 6th Taxol. This is a schedule for radiation chemotherapy, and we add that 42.6 gray along with the 5th and the 6th cycles of dose dense Taxol. Next. So radiation therapy, 3D conformal treatment, clinical target volume includes the entire breast along with the nodal areas, and the aim is to achieve more than 95% PTV to receive 95% of the dose, and less than 2% of the PTV to receive 107% dose, and Tmax at 110%, and B12 of the ipsilateral lung to be less than or equal to 15%, and B10 of the heart less than or equal to 5%, and contralateral breast to less than or equal to 2%. This is the color wash images. Next slide, please. So assessment, and all patients will be assessed weekly, daily, and also weekly for skin toxicity as per RTOG grading system, and all patients also will be followed up for monthly skin reactions till 6 months, and thereafter 3 monthly as per the schedule from the institute. And these are the study results, and most of our patients were less than 50 more than 50 years of age, and index site was left side most common, and luminal B the most common subsite, and radiation induced dermatitis grade 2 reaction was the majority seen in these patients. And this is the feasibility criteria. We are able to achieve the dose as discussed before. Quality of life assessment is being assessed with the standard URTC questionnaires QLQ C30 and QLQ BR23, which is done by a dedicated psycho-oncologist alongside. This is the result of the quality of life data, and the results were that there were moderate distress in majority of the patients and severe distress in young breast cancer patients with respect to the breast cancer occurrence as such. However, the patient-related satisfaction was better because of the shorter duration of treatment and accelerated treatments for the locoregional site. Next. All patients had received NACT with initial 4 cycles of dose-dense AC followed by dose-dense Taxol. We had combined 42.6 gray along with 5th and 6th cycle, and those constraints were achieved. And only one patient had grade 3 reaction, and however she had faster recovery, proper inpatient care. So as per the quality of life is concerned, patient had better psycho-oncological outcomes with respect to the shorter overall treatment duration time. However, the moderate distress, especially in the young patients, warranted more detailed assessment as such. conclusion, I hereby conclude that neoadjuvant hypofractionated CTRT is a feasible and safe option with acceptable and manageable toxicity, and most patients experience significant tumor shrinkage, allowing for the better operability and treatment outcomes. And this approach importantly had reduced the overall treatment time and minimized the delays in achieving the local regional control. And patient-related quality of life assessment, which was done, revealed that the patient-related satisfaction was better with respect to the treatment time. So, NACTRT thus represents a promising and practical option for managing the inoperable LABCs. However, the challenges were the grade 3 skin reactions, and patient selection as such was a challenge. The limitations is a small sample size, and this allows for more definitive conclusions after the treatment modalities, efficacies and safety. These are my references.
One question.
All these patients went in for surgery, right?
Yes.
Now, how many had pathological CR?
We didn't actually, pathological complete response was
Not there. But normally with chemo also you get to see some pathological response, right? Triple negative and all those things.
Yes.
And accepting was added in patients with urine packing or HER2 positive patients. What was the protocol?
Trastuzumab was given as per schedule, sir.
No, accepting was given 2 weekly or? See,
3 weekly only.
dose dense was dose dense you said it is actually was 2 weekly. When did the receptive schedule come in? Or was it different schedule for receptive positive patients, HER2 positive patients?
Yes.
What was the schedule there?
3 weekly
Chemo. See, Herceptin is 3 weekly. What about the patients receiving back?
Sir, Batley is 2 weekly. Herceptin is 3 weekly.
I'm asking. And did they, I mean, all patients received Adria or they other prototypic TCH or anything like that?
Only dosed in AC and Taxol.
So these were very large tumors which was actually inoperable even after NACT they would have been. So because we gave the CTRT, they were operable. So PCR is very, very far-fetched, sir. We could not expect them to even be operable with the routine NACT actually.
Thank you, Doctor.
Thank you.
And
Close
thank
the
you so
session,
much.
and thank you all the speakers, and thank you for the opportunity to the organizers.
Thank you.
We'll move on to the next lecture.
Thank you all. This marks the end of this paper presentation session. We now welcome the chairpersons, Dr. Mallika, Harshamitra Hospital, Trichy, and Dr. Selvamani Ma'am, CMC Vellore, to the dais. And Dr. Damodar Kumaran sir, C-Square Cancer Care and Research Institute, onto the dais. To felicitate the chairpersons, to felicitate Dr. Mallika ma'am, we now call upon Dr. Balaji sir, Secretary, AROI-TNPY, onto the dais. To felicitate Dr. Selvamani ma'am, we now call upon Dr. Balasundaram sir, President, AROI-TNPY, onto the dais. To felicitate. Moving on to the scientific sessions of today, the first session, it gives me great pleasure to welcome Dr. Vasant Christopher Jaipal, Cancer Institute, Adayar, to the first talk of the event. Is concurrent chemoradiotherapy the standard of care in cervical cancer that lies at the very heart of gynecology oncology? And to chair the session, we welcome Dr. Baladev, VS Hospitals, Chennai, and Dr. Balasubramanian, VS Hospitals, Chennai, as chairpersons.
Dr. Kumar for offering this opportunity to chair the first session of this conference. And without wasting much time, I got Dr. Vasan Christopher to speak on rectal tumor in the management of cancer cells.
Thank you, sir. And I am really thrilled to be here because I did my MBBS at Inaugural Medical College, and actually the college has been transferred so great now. When I saw the picture, probably today evening I am going to witness the college, and it's a place where I got confirmed as a doctor. Not only confirmed, and it's a place of my transformation. And then I come from Cancer Institute, and we all know that it has driven a lot of value system into me. The rich and poor should be seen as common, and we should not do anything with selfish motives, and we need to value others above myself, and you need to spend yourself. This is what Dr. Shanta ma'am lived and showed us, and I think it's a good words of inspiration for the next generation. So the topic today is concurrent chemoradiation the standard of care in cervix? Next slide. And I don't know whether it is a question or yes, I don't know whether it is a question or an exclamation mark, because that was missing in the agenda. So is concurrent chemoradiation is the standard of care in cervix, and maybe the modern people, modern postgraduates might think that it is a question, and I think that this is a right question, whether concurrent chemoradiation is the standard of care. So something what we call it as intro bank. So I view this as a question and an exclamation. Next. So I'm going to break my talk into 3 sessions. What is the reality of the past? So over 100 years there has been a lot of improvement in advancement in radiation, and that is a reality which we can never deny it. Till today, for locally advanced cervical cancer and even in early cervical cancer, radiation is the treatment of choice, and that foundation has been laid for more than 100 years. So next would be about the results of the present day. There are a lot of present day research on chemotherapy. More than radiation, we always think of a lot of combinations, and there are a lot of research on chemotherapy, and we need to understand the future. The future is immune modulation in cervical cancer at least. And to start with cervical cancer, this immune modulation would be explored in other sites of cancer also. Now what happens is, I think people might remember last year talk I told the same thing. Immunotherapy is now in the hands of medical oncologists, but it should not be, because radiation is the first immune modulation treatment which has been tested, tried and proved. So it is an era in which we need to understand everything about immunology, and we need to take the step forward. Next slide. So what is the reality of the past? Next slide. So we should never forget these 3 people. These 3 are the people who are stalwarts of cervical cancer radiation, and Sir Albert Doddrein was the first person who used radiation for the treatment of cervical cancer, and Dr. Margaret Cleese, and she's the first person who combined external radiation and brachytherapy in the year 1910s, and still now we are doing this treatment. And Dr. Robert Abbey is the one who documented the first cure with cervical cancer. Next slide. So we all know, next slide. So we all know radiation is the standard of care, and a few lines of it. There will be good response to radiation in cervical cancer. It will be very heartening to treat a cervical cancer patient, because in 5 fractions a patient is going to have a very good control of the symptoms. And we all know that 4-field technique is better than 2-field technique. And nowadays we have moved from conventional technique to 3D conformal, IMRT and VMAT technique. And APD is very important. When the APD is small, it is preferable to use higher energy, mainly in conformal technique and conventional techniques. And brachytherapy is very well integral part in the cervical cancer. Without brachytherapy, we can never think of cervical cancer. And we have moved from low dose rate, high dose rate, and today's era we are talking about MR based image guided brachytherapy. And whatsoever, the treatment duration is very, very important. any treatment which is going to be completed in less than 56 days will definitely have a very good survival. Next slide. So what are the radiation enhancers? Many things has been tried earlier. Hyperbaric oxygen, hypothermia, carbogen, and photodynamic therapy. Recently there are a lot of studies in photodynamic therapy. Next slide. But most of the studies which have proved benefit is in hypothermia. Ironically, what happened is before the usage of chemoradiation, this benefit is not very well proved. And I remember Dr. Vasandan sir, our professor who has done this study on hypothermia, did not show any benefit. There was no benefit in the hypothermia arm. But later studies which were done in 2013 and 2016 used concurrent chemoradiation. When we use concurrent chemoradiation, there is a difference of more than 9% survival if you are going to use hypothermia. So still hypothermia is not out of question. It is we did not use it properly. Now there are a lot of equipments have come in which we can measure the temperature whatever we are giving and to see whether there is a uniform temperature that has been delivered to the core of the tumor. So this is a place where we need to explore more. Next slide. And there are a lot of radiation sensitizers. So we all know misonidazole, etranidazole and nimodazole all have been proved to have a radiosensitizing property, but again in phase 3 trial did not show any benefit. The same with tirapazamide. The interesting thing will be mitomycin C. Mitomycin C is a hypoxic cell sensitizer. So wherever there is a hypoxic tumor, we can use, but unfortunately this trial has been used only in anal canal, and today in anal canal only mitomycin C is the standard of care. Maybe future studies might be very useful. And now we are in the era of nanoparticles which acts as a radiosensitizer. Next slide. And coming to radiation chemotherapy, and this is published in our institute by late Dr. Sarvalakshmi ma'am. It's a 4-arm trial which showed the benefit of chemotherapy, and all these trials definitely show that chemotherapy helps in radiation. The thing what I liked in this paper and also many papers which have been published before 2000 is everyone studied radiation with chemo. But eventually it has evolved that. Go to the next slide. Next slide. Even Perez now tells that it is chemoradiation. I asked my first years to call it as chemoradiation or radiation chemotherapy, which is fine, and why you are calling so? And one told a very interesting answer that it sounds good if you tell chemoradiation. I think as a radiation oncologist, we should shout it as radiation and chemotherapy. And again, cisplatin has been established as the drug which should be used with radiation in cervical cancer. Next. And we all know that cisplatin is a radiosensitizer, but the main effect of radiosensitizer is not because of its inherent property. Cisplatin, even though known as a radiosensitizer, many studies have proved that it is the cytotoxic property of cisplatin which has been very helpful to give the desired effect in the patients. Because clinical trials with 8 mg per meter square every day like a radiosensitizer did not work with cisplatin. Only 40 mg per meter square, and now recently TACO trial, the results are not out, which used higher dose of cisplatin. 3 weekly cisplatin showed a much more benefit. So the benefit of cisplatin is not because of only radiosensitivity, it is mainly because of the cytotoxic effect. Next slide. So what are the other chemotherapy regimens have been tried? Many other platinums, capecitabine, 5-FU and gemcitabine and cisplatin, paclitaxel combination. Everything is possible, but still nothing has won our confidence above than cisplatin to be used. Next slide. And so what are the present day research? So I'm going to break down into 4 sections in which what are the present day research on chemotherapy where we now stand. Next slide. So neoadjuvant chemotherapy. I have termed as flop of neoadjuvant chemotherapy, and I would certainly say that it is so. Because there is a very good response for neoadjuvant chemotherapy. There is no doubt about it. With Taxol Cabo, more than 60% of the patient will have a good clinical response. But the survival benefit in all the neoadjuvant chemotherapy is only when surgery has been combined with chemotherapy. Say, whatever is going to work with neoadjuvant chemotherapy will work with radiation also. Whatever is going to work with radiation will work with neoadjuvant chemotherapy also. So, whenever neoadjuvant chemotherapy has been combined with radiation, the outcome is very good. It's not my interpretation, it is interpretation from the meta-analysis, and there is no survival benefit when radiation is the local treatment, and delay in the initiating of the chemotherapy, chemoradiation could be the main reason, and they have strongly said that 3 weekly regimens, they do very badly in neoadjuvant setting. Next slide. So this is a forest plot which shows that there is no benefit, and I hope everyone is searching about the Interlace trial. I'm going to talk about it, but I don't see Interlace trial as a neoadjuvant chemotherapy, because you are just using weekly schedules of 6 cycles, which is not, you are not going to use it for the neoadjuvant property of chemotherapy, but it has worked. Let's see why it has worked. Next slide. So what are the failures of adjuvant chemotherapy? See, adjuvant chemotherapy has been also tried in many settings, and Outback trial is the large trial which has been very well done and which has proved that adjuvant chemotherapy should not be used in cervical cancer, and the statement is very strong that should not be used in cervical cancer unless it is proved. You can see, even though there is slight benefit, that benefit was not being spoken of properly in Outback trial. Why is 22% of the patients, that is 92 patients, nearly 100 patients who are in the arm of adjuvant chemotherapy did not receive adjuvant chemotherapy. In spite of that, there is a difference of 2% in distant failure control if you use adjuvant chemotherapy. So many of the patients in the adjuvant chemotherapy arm did not receive the adjuvant chemotherapy, and still we can't hold with this data to say that adjuvant chemotherapy is out of order. Still many node positive cases who, I think we know that whenever node positive they are going for distant failure. So still for those patients we need to create a evidence and see whether we can use adjuvant chemotherapy. Next. And this is Outback trial. You can clearly see there's a difference in the survival, but still this difference in survival is not able, we are not able to prove, mainly because these 92 patients did not receive adjuvant chemotherapy. Next slide. Next slide. So, foundation of concurrent chemotherapy, there are many trials which prove that cisplatin with radiation is the standard of care. If cisplatin patient is not eligible for cisplatin, carboplatin is an option, and cisplatin and capecitabine is also an option. And there's an interesting study called TACO study, which was published, which is an ongoing study. Still we are waiting for the results. It has proved that in the initial phase 2 trials proved that giving cisplatin at 75 mg per meter square tri-weekly is better than weekly cisplatin. Again, we need to wait for the trial evidence to practice it. And bevacizumab in concurrent setting was promising. Only one trial has been used in concurrent setting, but we need to re-evaluate it. And again, 6 cycles of weekly Taxol carbo, the talk of the town. It enhances the response of concurrent chemoradiation, and I would not call it as a neoadjuvant chemotherapy. It is like a conditioning chemotherapy. Just before neoadjuvant concurrent chemoradiation, you are just giving 6 cycles. Let's see how it works. Next slide. So there's a very good survival benefit with Interlace trial. We should not see this as a negative trial. It's a very good, well proven that Taxol carbo 6 cycles is going to give a good survival benefit in cervical cancer patients. Next slide. And this is the reason. So there's another one study which concluded that in the upper part, G part, you can see that it's a tumor, the biopsy which was taken before the neoadjuvant chemotherapy, and CD8 cells are the marker for the immune responsiveness. So you can see there is a immune responsive cells naturally present in a cervical cancer, and FOXP-T3 plus is a marker of T regulatory cells. These are immune suppressive cells, and those cells are also expressed in a tumor. After 6 cycles of Taxol carbo, you can see there's a very good response histologically, and there's a very good regression. And if you see the case slide, the immune suppressor, the immune responsive cells are still maintained. There's no decline in the immune responsive cells, but the immune suppressor cells are very well reduced in neoadjuvant chemotherapy. So the 6 cycles of Taxol carbo is very useful to condition the tumor, in which they kill all the immune suppressor cells. It tilts the milieu towards immune responsiveness, and it will enhance the radiation and concurrent radiation benefit. So I think we need to stop naming it as neoadjuvant chemotherapy. I can call it as immune conditioning. So you condition the tumor and then take the patient for chemoradiation. Next slide. one thing is, all these trials and mainly this interlaced trial, the benefit of 6 cycles Taxol carbo was there only for early cancers. Again, in node positive cancers, this 6 cycles of weekly Taxol carbo has not reduced the distant failure. Again, we can't do a subgroup analysis, we need to do further trials regarding it. And now it's a forecast of immunotherapy, and we all know there are many agents. There are anti-PD-1 antibodies, there are anti-PD-L1 antibodies. There is a partnership between the tumor and the immune cell. And I would call it as a very, very unnecessary partnership, illegal partnership. And we need to break that illegal partnership with all these markers so that whenever you give radiation, whenever you give chemotherapy, the tumor is going to respond. Next slide. And there are also anti-CTLA4 antibodies, ipilimumab, which can be used in cervical cancer. So the last, and I need to complete this slide. And there are many studies which has proved safety of immunotherapy. All phase 2 trials are using ipilimumab, pembrolizumab show that there is a benefit. But again, phase 3 benefit is the only for pembrolizumab, and I think we should start using pembrolizumab wherever feasible so that it will enhance the tumor control probability. Next slide. So this is for the future. What are the revelations which we are going to have for the future? Next slide. So we all know this is a tumor microenvironment, not only immune cells, there are many other cells into it. Many times we see one by one, and that is the reason why we fail in many of the trials. We need to take a comprehensive view of everything, and then we need to see the tumor. One treatment is not going to fit the other treatment. So I am dreaming of a day in which you take a biopsy, send to the molecular oncology, in 2 days they are going to tell, first you give Taxol carbo and then you give chemo-RT. This patient no need conditioning, you straight away go to chemo-RT. This patient don't give chemotherapy, only RT is enough. This patient you add adjuvant chemotherapy. I think that day is not so far. So we will be able to do this in a very fast manner, and I think in cervical cancer there are a lot of research going on in this. So when we achieve that in cervical cancer, definitely it is going to be a trendsetter in head and neck and other malignancies. Next slide. And we all know, this is the thing, how a tumor has been balanced by either way. There are T regulatory cells which causes immune suppression in the microenvironment, and also there are CD84 cells which are immune responsive cells which are going to help in tumor killing. Next slide. And we need to pursue more about immunotherapy. We need to learn more, we need to do a lot of trials. There are a lot of dual bispecific molecules. The studies are going on, and there are T-cell targeting agents, tumor infiltrating T lymphocytes can be injected into the patient, and there are a lot of cancer vaccines, DNA vaccines which will act through this immunological phenomena, and also about dendritic cell vaccine. Next slide. And this is very important. We need to see where to use what type of chemotherapy. And chemotherapy, if we use as a preconditioning regimen like Taxol carbo 6 cycles, it has its own benefit. It was very interesting. Even cyclophosphamide, which is a very cheaper and well-tolerated chemotherapy, has this immune conditioning property. Maybe, I think, I just want to put the thoughts only. I am not talking any evidence here. If you are going to precondition with a week or 2 weeks of cyclophosphamide, might be helpful. We need to do studies to prove that. And 3 weekly Taxol carbo is inferior compared to 6 cycles of weekly Taxol carbo if you are going to give before chemotherapy radiation. And eventually cisplatin is the standard of care. We need to think of using those intense regimens. They might have more benefit, that is at 100 mg per meter square or 75 mg per meter square. Very importantly, we need to avoid corticosteroids. Steroids is a very much abused drug by an oncologist, because this also can tilt the tumor microenvironment towards immune suppressive thing, and there are a lot of papers and evidence for that. We need to be very careful in using corticosteroids. And now in our institute, more often we use olanzapine, and that is very safe, very comfortable, and we need to credit our medical oncology department to bring us a state of care in our institute. Like many patients with olanzapine, they are more comfortable even though they are not going to use steroids. So we need to still more evaluate adjuvant chemotherapy, no positive patients. I think only with outback we should not tell Tata bye-bye to adjuvant chemotherapy. There are a lot of things we need to explore, because these node positive cases are really a very high risk patients in which we need to see the further benefit. Next slide. And not last, many things we need to do in radiation, because now See, I don't know, it's my feeling that many radiation oncologists are going towards medical oncology, and I am so uncomfortable with that, because radiation oncology is such a field that no one can forsake. So I am not telling everyone of forsaking and going, they are going for their own reasons, but still the second years, first years and the final years should take this to the heart. Radiation oncology is such a field that you should never forsake it. So there are a lot of, I read 2 or 3 papers about immune cell sparing radiotherapy, very interesting. In SBRT, you spare thymus glands, spare lymph nodes, so that you can enhance the immune responsive radiation. I think we all read about red radiotherapy, flash radiotherapy, all works through immune modulation. Bone marrow sparing radiation, which was initially in 2010, it was so popular. We started to use mainly to reduce the toxicity, but also it will have its benefit in immune, like to preserve the immunity of the patient. And wheresoever possible, we need to avoid prophylactic nodal radiation. I think we will be so comfortable to use prophylactic nodal radiation. Maybe friends from Cancer Institute will shake their head, because we used to practice prophylactic paralytic radiation for a longer time. But having read everything, I think that unless it is indicated, better not to use a prophylactic nodal radiation, because in lung, in many sites, prophylactic nodal radiation has come out. And I was thinking about why not to initially hypofractionate a tumor and then continue the normal fractionation, so that we can tilt the tumor towards immune responsiveness. And also we can use simultaneous integrated boost to give more radiation to the tumor, so that we can enhance the immune modulation property of radiation. What about doing early brachytherapy? And we also done a study in which early brachytherapy patients, they really done well. Their outcome was very good, but still we need to do some randomized controlled trial to prove that. And completing treatment within 6 weeks will definitely tilt the table towards better immune modulation. Next slide. And we all know radiation is an immune suppressive treatment, there's no doubt about it. Radiation is going to enhance the immune suppressiveness by a lot of mechanisms. Next slide. But we need to understand. Next slide. But we need to understand that radiation itself is a vaccine. I think we can call it as Radis vaccine, radiation in situ vaccine. So if you are going to use it properly, it is going to benefit our patient. So initial radiation response will definitely do a immunogenic cell death. There will be a lot of immune related cell death is there. We need to take it for our benefit, and then complete the treatment as fast as possible. You give other chemotherapy and make sure it helps in radiation, reduce the toxicity, so that what happens is, if this milieu is there going to be for a longer time, it goes to a chronic immune suppressive state. And the only way out of immune suppressive state is to remove it by surgery. That's what all clinical studies have proved. Once after radiation, you have created an immune suppressive state, then it will be very difficult to remove with radiation itself. So it's very important we hit the target as fast as possible, and we need to achieve it. Next slide. Next slide. I think you're going back. So it's an era in which we need to integrate everything. We need to integrate surgery where surgery is needed, where chemotherapy, we need to use chemotherapy, and we need to explore more of immune checkpoint inhibitors. And we should never forget, radiation is integral. Nothing can match insufficient external radiation and brachytherapy. So you miss a nodal boost and you can't think that chemotherapy is going to match. If you are going to miss a brachytherapy, you can't think that surgery is going to match. Never miss adequate dose of external radiation and brachytherapy in all the patients, and that has been proved in embrace studies. So if you are going to give adequate dose, the local control is going to be good. Next slide. So TLC is the way of future, and many people might think that it is total lymphocyte count, but I want to give a small piece of advice to my juniors. Next slide. TLC is a tender loving care. Active listening is very important. Your touch means a lot to the patient. Examine with care and comfort to the patient. Connect with the patient, reassure, search for their fears, not only what they express, but search for the fear and extinguish it. Counsel, be available to the patient, don't ignore any symptom. Symptom control is very, very important, and timeline is also important. Follow up the patient for good survivorship. And progressive disease, let the patient live till the die. Let us not give chemotherapy till the end of their day. Let them have a good symptom control and let them have a peaceful life at the end. And this last line is very, very important. Any RT morbidity leading to mortality, don't sleep until you accept, refine and correct. So I have been practicing only in Gynec. I will see lot of radiation. I have seen lot of radiation morbidities, lot of perforations, obstructions. Even though we can tell that the patient has been cured, the patient would have lot of morbidity and we are losing the patient. Whenever you have a morbidity, first we need to accept it and we need to refine our practice. So there is no end for refinement and we need to refine and then we need to correct. Next slide. And this is my last slide. So I urge every doctors here, mainly my junior doctors here. First we are bachelors of medicine, right? We done our MBBS. So already our medicine, we have completed a course and we got a degree. Then we are radiation oncologists. So you think about it before you go to another field. In radiation, there are a lot of things need to be explored. There are a lot of things we need to do. So value radiation also. And this is a famous quote from Ronald Ross. He discovered mosquito and in that he exclaimed this like this poetry, and this should be our heart's cry. Many patients, cancer patients, cervical cancer patients, they are losing their life because of the disease. So yes, death values your strength and grave values your victory should be our intent to explore more about a best possible treatment to the patient. Thank you.
Thank you, Dr. Vasant, for your excellent talk on the concurrent chemoradiation. Is a standard of care in local advanced CSRs. That is the topic. It is done wonderfully. We will the topic is open to question.
Neoadjuvant chemotherapy don't play, sir. We need to see the 6 cycles of Taxol cover as a conditioning regimen. You give weekly 6 cycles and then you give chemoradiation, it definitely tilts the balance towards a good response to radiation. And this balance is seen only in early stages. And even in early stages, better local control is achieved with 6 cycles of Taxol cover. And I think that we need to start practicing it. I think as a radiation oncologist, immediately if someone is telling neoadjuvant chemotherapy, no, that is our response. We need to start using it, see where we should not use, and then we need to tailor our treatment. So the present evidences we can use and see. There's a wonderfully done study which has proved the benefit. Yes, sir. The given, if you see the forest plot, there is a very interesting forest plot. The adenocarcinoma or poorly differentiated histologists whom we think would have benefited with neoadjuvant chemotherapy did not receive the benefit. For them, concurrent chemotherapy only, the outcome was good. Similarly, patients whose age is less than 40, their biology is very aggressive. Those patients also did not do well with initial 6 cycles of Taxol carbo because they progressed during that cycle. Note positive, there is no benefit in giving chemoradiation. I personally feel with all these data, any note positive, they are the candidate of adjuvant chemotherapy rather than initial chemotherapies. So all node negative squamous cell carcinomas, we can definitely think of using 6 cycles of Taxol carbo followed by chemo.
Now, the CS cervix is basic thing. We divide into early and local advanced and metastatic. Chemoradiation comes fitting into the local advanced CS cervix. Now, which is the standard of care? Is concurrent chemoradiation or the interlace says no neoadjuvant chemo and concurrent chemoradiation? He also proved there is a 10 to 12% of PFS improvement and also survival also improvement is there. So what is its standard of care?
So the standard of care is chemoradiation.
That's what I want to say emphatically is this is the standard of care.
Yes.
Yeah.
The standard of care is radiation chemotherapy.
So don't say chemo radiation, say radiation chemo.
And interlace trial, the thing is, not lot of Indian population has been tested, sir. We need to start doing trials, or we need to start using 6 cycles of Taxol Carbo. And definitely when we use, we will definitely see the difference, what I feel, but we need to start using it.
There's no question, we'll conclude this session. Thank you.
My question was, see, if your induction chemo is going to, the conditioning chemo, okay, is going to create an immune response. Do you think in the future it's going to happen something like you condition, induce an immune response and go for immunotherapy, don't know what? Just like what is happening in rectal.
So actually what happened, I don't think so in cervical cancer it would be, sir. Radiation is the integral in cervical cancer. Even if we use immunotherapy without chemotherapy is not working. Definitely immunotherapy without radiation also won't work.
This is what surgeons would have thought in rectum.
Rectum, okay.
Those with the cervix is much higher than equilibrium, like those of the 80
The beauty of cervical cancer is you are able to give 80 grade, 90 grade to the tumor without any much morbidity, and I think that can never be shaken for another century.
Separate paper, I said that forest plot in interlace trial, because the interlace paper Lancet notoriously did not give that forest plot. Right? Usually all
That was from meta-analysis which studied about the 2024 recent paper only. I can share it.
Because usually all
RCDs have this forest plot, and interlace did not have that forest plot, which was.
Yeah, I did not put it here. The interlace already it is in the supplement. It is in the supplement, and which shows that node positive tumors don't have benefit in interlace protocol.
Thank you.
Thank you, Dr. Vasan Christopher, sir, for your valuable insights. May I now invite the chairpersons to honor the speaker. We invite our Dr. Devanayagam sir, Organizing Chairman, 40th State AROI, and our beloved Professor and HOD, RCC Tirunelveli, to give memento to the chairpersons. Proceeding on to the next session, image-guided brachytherapy has now become the standard of care in carcinoma cervix. With advanced imaging, we now deliver radiation more accurately and more safely than even before. To chair the session, we invite Dr. Balasundaram sir, President AROI-TNPY, Rela Hospital, Chennai, and Dr. Rajaram sir, Devagi Specialty Hospital, Madurai.
So good morning to everyone. For this session, we invite Dr. Karthika Sivaprakasam from GKNM Hospital, Coimbatore for the talk.
Good morning everyone, and thank you for this opportunity. I think the organizers have well chosen the topics, and thank you Vasant for setting the stage and telling that radiotherapy is the way forward in CA cervix, and brachy plays a very important role in treatment of CA cervix. So my topic is on image-guided brachytherapy in CA cervix, and I'm Dr. Karthika Sivaprakasam. I'm a radiation oncologist at GKNM Hospital, Coimbatore. So the learning objectives that I'm planning to cover is the rationale, the choice of applicator types, the imaging modalities used, the target delineation, prescription, the application reconstruction, optimization, and a little bit about plan evaluation and, if time permits, application in clinical cases. So going on to rationale, so we are moving from 2D to 3D. It's not that 3D is a new concept. 3D in radiotherapy has been well known for decades. We've been practicing 3D teletherapy for, I think, quite a few years. Everybody knows about 3D CRT, but not so with brachytherapy. So we have enough evidence to say that 2D brachy is inferior to 3D brachy. So you can see the slide showing that the dose conformity, it's less conformal with 2D because it is point based. With 3D you have a highly conformal dose and the plan is individualized. Since it's highly conformal, you can give very high doses to the target and you can also spare your organs at risk. So obviously the results are better. The local control rate goes up to 90% with 3D brachy, while with 2D it's inferior, showing a 65 to 75% local control. And with OAR toxicity, the 2D brachy again far inferior, so it is 10 to 20% in 2D brachy, while with 3D image guided brachy it is half of that, 5 to 10%. So all of this is backed by evidence. So we started the 3D brachy way back in 2008 and there has been enough evidence, but the latest is the Embrace 1 and the Retro Embrace done on our Indian population, which have reiterated that 3D brachy is the way to go. So this transition from 2D to 3D, suddenly there's a boom. Why is there a boom? Because there has been an improvement in the imaging techniques. We are able to integrate CT and MRI, and almost every other hospital has an MR and a CT now, unlike before. And applicators, we have a plethora of applicators now. We have interstitial applicators and intracavitary applicators as 2-in-1 called as hybrid applicators. Dosimetry, again, we have enough of dosimetric guidance which we didn't have before. So our journey from 2D to 3D has been helped. We have moved from ICIU 38, which was used in 2D brachy, to ICIU 89. So the gynecology again, we moved from 1 to 4, all recommending on how to go about doing 3D brachy. And our own Indian Brachytherapy Society has concrete evidence and guidelines on how to go about doing 3D brachy. So of course I'm not going to dwell into all of them for want of time, but just a brief overview of why we have not moved to 3D. You can see it's a busy slide, but it's very different from 2D to 3D. So hence I think the hesitation comes from using a 3D brachy. So it starts from the pre-planning. For a 2D brachy, a clinical workup is sufficient, whereas for 3D image guided brachy, you also need an MR to know where your residual disease is. And for applicator, with regard to applicators, a traditional applicator is sufficient with intracavitary 2D brachy, whereas with 3D you need MR compatible or CT compatible applicators. Procedure wise, just an insertion and packing is sufficient, whereas with 3D you need to do a CT and an MR or either one of them, and you need protocols on how to delineate the target. So again, imaging, X-rays is quicker, MRI, CT is going to be time consuming, contouring not needed in 2D, whereas here you need to contour both the organs at risk and the target. It's very similar to external beam 2D and 3D. And applicator reconstruction not necessary in 2D, just X-ray markers, take an X-ray and specify a dose, whereas here you need applicator commissioning and dedicated protocols, dose definition, point definitions to OAR and to the target. Here in addition you have to do volume parameters for the tumor and the organs at risk. And planning, here just a standard loading or a manual optimization sufficient. Here you have to spend time and do a standard loading, you have to do manually, then a geometric optimization or an inverse planning. treatment delivery, you can use LDR or an HDR. Here it's going to be HDR based. So there's a lot of variation between a 2D brachy and a 3D brachy. So I'll move on to the choice of applicator types. So here again, to decide on the applicator you need to do for a 3D brachy, you have to first decide what category the patient falls under. Generally, it's divided into 3 categories. The category 1, there's a point.
There's no pointer there. It is there.
Sorry. I'm going back. Can you from there? Go back. Go back. Go back to choice of applicator. Go back. Sorry. Go back. Go back. No. Anyway, so the brachytherapy category 1, you see that there's no residual disease or it's limited to the inner third of the parametrium. Whereas in the second category, you see that the yellow one, the residual disease is up to this, is also at the cervix and it extends to the medial 2/3 of the parametria. Whereas in the category 3, the yellow line can be seen extending up to the distal parametria. So next slide. So the choice of your applicator is going to depend on your brachytherapy category. The first one image shows your hybrid applicator, Venezi applicator. So that has a ring and a tandem. This is similar to a Fletcher suit. It works the same, tandem and a ovoid. So this can be used for your brachytherapy category 1 and it can cover a disease extent of 15 to 25 mm. The brachytherapy category 2, where the disease extends to the medial parametria, you're going to need straight needles and it can cover a distance of 25 to 30 mm. So, and the third category, you're going to need divergent needles and cover a bit more, which is up to 40 mm. But as you see, it's going to be difficult to deliver brachytherapy if your residual disease is going to be more than 40 mm with interstitial and intracavitary alone, these kind of hybrid applicators. So you'll need something different. So next. So imaging modalities, the next slide please. So next. So here you can see, you can use an MR or a CT for your image guided brachytherapy, but it's clear to see that your MR is clearly showing a much better picture than the CT. MR gives a much better soft tissue delineation. You will be able to draw your GTV, your HRCTV, your IRCTV, everything on your MR, whereas that can't be said of your CT. The CT does not show you a good soft tissue delineation, so it's going to be difficult for you to delineate any of them. So the applicators, again, you can visualize in both. OAR wise, both can be used. Both MR and CT are similar in drawing your organs at risk. The problem comes that MR is very time consuming, so you will have to shift the patient after application and do sometimes both a CT and an MR, and you're going to end up, with complex complex procedure plus time consuming and the cost. CT is readily available. So nowadays, the upcoming option is a contrast CT instead as a variation. So next will be the target delineation. So now you've done an MR or a CT. So I'm going with an MR because it's much easier to show the tumor. So you can see the white line is the GTV, which is the residual disease at the time of brachytherapy. You cannot draw GTV on a CT scan because you're not going to visualize. So never draw a GTV on a CT image based brachytherapy. It's only for an MR based brachytherapy that you draw your GTV. And the HRCTV is the initial disease volume, that's the yellow line. So this is the initial disease of presentation. You can see it covering the cervix and a little bit further down. And the red line is your IRCTV, which is a 5 to 15 mm margin around the HRCTV. It's only a craniocaudal extension. You do not extend it towards the OARs on the sides. So you see it only on the craniocaudal direction. Your HRCTV is more important than your GTV because your IRCTV is based on your HRCTV, not on your GTV. So which is why you can also get away with your CT based delineation. You can fuse your CT image with your pre-treatment MR, and you can delineate your HRCTV and draw an IRCTV around it. So next slide please. So you also contour your organs at risk. The yellow one, the bladder, the rectum, the sigmoid, which are the 3 requisites which we have to mandatorily do. Now we are coming up with also delineation of the small bowel, the urethra, the vagina, the anus as well, with the ICIU 89 reporting 2. Next. So now we've covered target delineation, we come to prescription. So it follows principles similar to EBRT. So once you've done your target delineation, you have to decide how much you're going to prescribe and to where you're going to prescribe. So for the target, we have parameters called as D100 and D90. Some of them use a D98, which is similar to D100. This is nothing but the dose delivered to 100% of your target. In brachytherapy, you try to achieve, for example, you're prescribing 7 gray, you try to achieve the 7 gray to 100% of your target, and the target is going to be your HRCTV, not your GTV or IRCTV. But we do not use D100 because even a small change in your contour is going to lead to a very sharp change in your dose gradient. So instead we use D90, which is dose delivered to 90% of the target. Here by target, again I say it is HRCTV. D90 is less sensitive. This is if your 90% of your target gets 7 gray, that's considered to be a stable parameter and a good achievement. V100 is volume receiving 100% of the prescribed dose. We do not use this generally. We use this only if you're delivering multiple fractions with the same application. So you do D100, D90 for all 3 volumes, GTV, HRCTV and IRCTV, but what we use is for D90 for HRCTV. Next slide. So for the OARs, we use 0.1 cc, 1 cc and 2 cc. So what does this denote? This is the dose which is delivered to the most irradiated volume, which remains close to the applicator. 1 cc, 0.1 cc is the maximum dose. It's like the Dmax which we refer to. So this can cause a fistula formation. T1 cc and 2 cc can also be useful. This is an acceptable morbidity. So this causes telangiectasia. More than 5 cc, fibrosis is the endpoint. So this is the checklist recommendation recommending the targets and the OARs. You can see on the bladder and the rectum and the sigmoid, which lie closest to the applicator. Those are the 2 cc volumes which receive the maximum dose. So this has to be reported for the rectum, bladder and sigmoid as of now. So how much do you aim for? So this is reported as a EQD2. So D90 obviously has to receive the entire dose. It has to receive the 100% dose, which is 7 gray. So with the 3 fractions or 4 fractions you're planning, it has to receive a total of 85 to 90 gray. The 45 to 50 gray comes from your EBRT, and your IRCTV should receive about 60 gray. Your organs at risk, the 2 cc bladder should get less than 90 gray, and your rectum and sigmoid, similar dose constraint, 70 to 75 gray. So off late we are finding that if you deliver a 45 gray with your EBRT, this is easier to attain rather than using a 50 gray. So people are moving towards 45 gray in 25 fractions. 60% in India use only 50 grade. So this practice has to change. So now a few words on applicator reconstruction and commissioning. So not only does the physician's role end with prescribing and telling what to do, you will also have to look into a few points on applicator reconstruction. So you can define this, you can see the physicist defining the source path, which is nothing but the 12 positions being marked on the ring applicator in the picture shown there. And the second point is merging this source path on the patient's anatomy. If there's going to be a slight deviation, you see the white line deviating from the red in the second picture. So that can cause the dose to be delivered elsewhere rather than on the source path intended. So both the steps are very imperative, and the physician needs to check whether the source path and the merging is done in the accurate way. Then you will also have to enter the correct, check whether the correct offset value has been entered. I see most of them not knowing what an offset value is, which is why I've included it in this presentation. Each applicator comes with a prefixed offset. This is nothing but the distance from the tip to the first source position. You may think you've gone up to the fundus of the uterus, but there's a particular offset which limits you from delivering the dose up to the fundus. So, for example, Venezia applicator has an offset of 1.2 centimeter. So you may insert an applicator of 5 centimeter, but ideally it's starting to deliver only much lesser than your 5 centimeters of intended length. Next is the catheter numbering. So it's very, very important that you name your catheters and connect them properly. Digitizing the tip and the catheter in, you can find that there's an yellow dot and a red dot. If you have not done them properly, you can see in the bottommost white picture that the loading has been done lower down than in the intended top portion. So all these three are very important that you take care when you go into planning. So next is the optimization. What is optimization? It means the same as the word. Optimization is getting what you desire. So what you desire is delivering the maximum dose to the target and a minimal dose to the organs at risk. So this can be achieved by using certain tricks. So this first picture is a non-optimized plan where the sigmoid is getting way beyond what is necessary, whereas an optimized plan, you see that the dose is much less. The green line has gone off in the optimized plan. So next slide.
Madam, you have 2 more minutes.
Yeah. Optimization methods, we use manual, graphic and geometric, or it can be inverse based as well, as we do with our IMRT planning. So manual dwell time, you tweak the dwell time and the dwell positions, and the graphical optimization, you can see that globally it can be done all over and it is removed from the femur heads, or you can do it just locally with a few points. So geometric optimization, it's more used with interstitial applications. Inverse the same, you use it only with interstitial applications because their manual optimization is going to take time. So I'll skip this for want of time. So I'll probably just to retrieve. So if you are going to use an interstitial application, the brachytherapy category 2, you follow the first step as you do for an interstitial application and then load the needles as per your HRCTV requirement, and the loading has to start with 10% dwell time and you can go only up to 20%, and with divergent keep it to 10%. You cannot load the needles in the vaginal region. So, and the optimization always starts with point A, so you can't do away without point A, even though you practice a 3D brachy, and then you start doing a manual dwell time optimization, and then based on your institutional practice, you modify the loading. So then you evaluate your plan, and put it on a spreadsheet which is available, and all of them have to be submitted. We have 3 levels of reporting. We are moving towards the 3rd level of reporting. So I'll skip this for want of time. So good planning and optimization cannot turn a poor insertion into a great plan. So you need to insert it in the proper way to get a proper optimization and deliver the ideal dose to the patient, and you need to go hand in hand with your physicist to get an adequate plan. So this survey on brachytherapy imaging was done at Europe. You see the increase in from 2007 to 2023. We are hoping that this will happen in India as well. So, and a big thank you to the patient listening and to GKNM Institute for making it happen.
Thank you, Dr. Karthika, for enlightening us on image-guided cervical brachytherapy. And almost, I think many of us are still doing 2D radiotherapy, 2D brachy as of one day, and many centers have upgraded to 3D. Any questions and any doubts?
The dose delivered is the same.
No,
45 grade, you achieve for a 85 to 90 grade to your HRCPD. So if you're delivering 45 grade, you need to give the remaining 40 through your brachy.
Dose per week, 7 or 6?
Depends. You can give 6 grade into 4 fractions or 7 into 4. There are different variations which you can practice. We have not done contrast CTs, but it's upcoming. Centers do use contrast CT instead of an MR. So we can do just an MR based planning as well, but the problem with MR will be that you cannot locate the tip if you're doing an interstitial along with it. So you will need an MRI and a CT, but if you're going to do only an intracavitary brachy, you can go ahead with just doing an MRI. You don't need a CT along with an MRI.
Thank you, Karthika. Thank you so much. Just I would like to inform the august audience that we have a robust Indian Brachytherapy Society with more than 700 members in it. So if you're not a member of IBS, please become a member of IBS. The second thing is IBS has given very clear guidelines. Even if you don't have an MR compatible applicator, you can use CT scan as a planning. There is an IBS guideline where you can do a CT used image guided brachytherapy. You can get it on website or through IBS website. Thank you.
Thank you. Thank you.
So with this, we thank the organizers for giving this opportunity.
Thank you, ma'am, for enlightening us with your research and clinical experience. May I now invite the chairpersons to honor the speaker. We invite Dr. Rajkumar sir, organizing secretary by treasurer, 48th state AROI, to give memento to the chairpersons. Next session is on re-irradiation and astrocytoma, and let's explore the evolving strategies to manage recurrence with precision and care with our esteemed speaker. We now invite the chairpersons, Dr. Srinivasan sir, AROI Secretary General, Beyond International Hospital, Chennai, and Dr. Alex Prasad sir, Chennai Cancer Hospital, as chairpersons for the session.
We welcome Dr. Rajesh, Christian Medical College Bello, to talk on re-irradiation brain tumors, astrocytoma alone. Dr. Rajesh.
what I'll do is I'll take you through the places where when to consider re-irradiation in gliomas. The slides are not moving. So this will be my outline of my presentation. We will see what is the challenge in giving re-irradiation for gliomas, how to select an appropriate patient, what are the approach you need to take, what are the guidelines you have for contouring, what are the constraints and what is the evidence, and how to make clinical decisions. So as you all know, we have been treating high-grade gliomas using the Stoops protocol, that is maximum safe resection followed by concurrent chemoradiation with temozolomide followed by adjuvant chemotherapy with temozolomide. Whatever you have been tried, this is the current standard of care which was established in 2003 and still the standard of care is the same. With this one, what we are able to achieve is we are able to get a 5-year overall survival of around 10% with concurrent chemo-RT with temozolomide and the 2-year overall survival of around 27%. There is some slight advantage when the patient is having a methylation. NKMT methylation slightly improves the overall survival at 2 years to 50%. Why this is happening? It's because 90% of the gliomas they recur within the first 2 years and 80% of the recurrences happen within the 2 centimeters of the initial tumor, and the median survival after the recurrence is only around 6 to 9 months. So the options what we have for the recurrent glioma treatment is very limited, and we also need to balance this with the quality of life considerations. If you see in this graph, majority of the patients, whatever is the study, they found that around 90% of the recurrences happen within the first 2 centimeters of the initial tumor. So the patterns of recurrence in gliomas, they could be either local type which occurs very close to the initial tumor, or it could be the initial tumor, or it could be very close to the initial tumor, or it could appear in a different location. So when it is very close to the initial tumor, you can consider type of Re-RT also. That will be definitely Re-RT. But if it is at a different location than the primary tumor, then it's called as repeat RT. Re-RT is giving a second course of radiation to the same place, and repeat RT is slightly giving it in a place where the recurrence is not in the first place itself. Or it could also be an intraventricular dissemination, or it could have leptomeningeal enhancement, where the option is going to be different. So why we need to consider Re-RT? We have made a lot of advances in the radiotherapy techniques. We have made a lot of advances in the imaging part as well. In the techniques, we have IMRT, protons, radiosurgery can be given.
Can come close to the mic.
Yeah. So we can give, with advanced RT techniques, you have IMRT, protons, radiosurgery, fractionated SRT. A lot of techniques are there which can help us to reduce the toxicity. At the same time, we also have a lot of techniques to see what is the tolerance of the normal tissue and treat it in a better way. A lot of advances has happened in imaging as well. You have good MRI systems available with spectroscopic imaging, perfusion imaging. You can also have a PET-based delineation. I'll come to the PET part in the later thing. And what all we can achieve is, we can achieve a definitely a meaningful survival when you give a re-irradiation. It also offers a better palliation for the treatment for the patient. So what we are worried about is the toxicity. That is mainly the radiation necrosis and the cognitive decline which the patient can have when the patient is going to have a re-irradiation. That's what is our concern. And we have also moved from 2D to 3D to IMRT, and now we have even specialist techniques available to have a normal tissue sparing. What we need to improve on is the better patient selection criteria and how to integrate them with the current systemic treatments. So coming to the patient selection factors, there are 2 sets of factors. One is the clinical factors and the technical factors. Clinical factors will be basically the performance status of the patient. That is the performance status of the patient which is more than at least 60 to 70 kps, and what is the time from the initial radiation, whether it is more than 6 months. Ideally it should be more than 12 months, which will be better. And what is the pattern of recurrence, whether it is a focal recurrence or whether it is a disseminated recurrence or a leptomeningeal enhancement. That is the one which you need to consider. Technical factors will be the cumulative dose with the critical structures, basically the brainstem and the chiasm part. And if the volume of recurrence is very small, less than 50 cc, then definitely have a good prognostic factor. And how close is it to the critical structures? These are the factors which you try to see before you select a patient for ERT. And one thing I would like to stress upon is the inclusion of multidisciplinary treatment at the time of recurrence.
you need to include, if the patient is fit for a surgery, then definitely re-surgery is an option which you need to consider before re-RT. Re-surgery followed by PRT along with concurrent chemo. So this trial from RTOG 0525, it had 4 arms where they tried with best supportive care, re-RT, only chemotherapy, or re-RT with chemotherapy. They found that with the combination of all multimodality treatment, the survival is much better than the single modality of treatment. So the ideal candidate for re-RT is a patient who is young, has a good histology, grade 2 converting into grade 4, they are good patients, good performance status, small volume recurrence, longer intervals since the initial RT. MGMT methylated status, definitely they have a good trend towards better survival even with re-RT. And if the disease is resectable and you have a good manageable residual tumor burden, that's even better. So you can have a lot of different techniques, IMRT, VMAT, protons, mRNA, each one has its own pros and cons. So whatever is available in your place, definitely it's ideal to choose one of them. So the techniques what we can use for re-RT is, you can have a stereotactic radius surgery, but the only point which is against the stereotactic radius surgery is you don't get a small volume recurrence which is very small. And the literature with radiosurgery for gliomas is very less. The most adequate literature what we have is a fractionated SRT or hypofractionated RT or conventional fractionation. Various fractionation schedules has been used. Most common schedules are 40 gray in 15 fractions, 35 gray in 10 fractions, or 20 gray in 5 fractions. And the conventional fractionation regimens include 50.4 in 28, 46 in 23, and 36 in 20. So what technique, whatever technique you use, whether it's a conventional fractionation or hypofractionation SRT, it is not going to change your OS or a PFS. So whatever is available, definitely you can offer. So the next thing about contouring, in contouring you need to know like what sequences to use. T1 contacts is the gold standard. T2 flare you can use it for finding out the surrounding infiltration, but you don't give a margin of expansion to the T2 or PFS, and the 12-year local control was very similar in both, and the radiation necrosis rate was much higher in the PET arm because your volume of radiation was higher. So they concluded saying imaging modality may not alter outcomes, patient biology, patient selection and biology still remains the key. Coming to some other evidences, there are two evidences, basically meta-analysis, one from Kazmi et al. And Chun et al. Chun et al. They focused on fractionated stereotactic RT, and they found that confirmed that the outcomes is much better with small volume recurrences. So in the study from Kazmi et al., so it was 50 non-comparative studies. They had near about 2,100 patients, and what they found is the overall survival from Re-RT and PFS at 6 months was 73% and 43%, and at 1 year it was 36% and 17%. Nearly about 40% of the patients will be alive at the end of 1 year. They found that PFS is much better with the shorter fractionation schedule, that is less than 5 fraction RT, basically because the volume of the lesion what you are treating is small. So in that way, your survival is also much better. So coming to post-op scenario, so like some patients who had a recurrent supratendular tumor, when they are completely excised, is there a benefit in giving RT? And this is the current trial which is currently ongoing, that's a NYA trial 70, where the experimental arm showed like they gave post-operative RT at a dose of 46 grain 2 gray per fraction or 36 grain 3 gray per fraction. Observation arm was just follow-up. Post-op completely removed tumor. So this trial is still ongoing. Whether we can get better with immunotherapy, definitely there are a lot of trials which are looking at this, combining checkpoint inhibitors and Re-RT. The rationale is Re-RT might enhance the tumor antigen presentation, thereby it can boost your anti-tumor immune response, similar to what Vasant was saying about radiation-induced vaccination, very similar to that principle. And the abscopal effect, which is also theoretical, but it's a good example for a prospective study. So these are the various trials which is currently ongoing. All these trials you can classify them into comparative trials of RT techniques, immunotherapy combination, or a dose escalation, or a image-guided re-irradiation, advanced imaging used for contouring, or bevacizumab in this thing. All these trials are still awaited, and maybe in the next 5 to 10 years you might have a lot of answers. So proton therapy definitely is going to be the standard for re-irradiation because it has its own advantages of brachy, where you can reduce the integral dose. It can help us to spare the normal healthy brain tissues, and it can help us to permit even a large volume retreatment is possible with that. And you have evidences with Gali et al. Who showed that the median overall survival of 14 months with the low toxicity rates. So when to consider Re-RT? Coming back to the main question, good performance status patient, no leptomeningeal disease, you have exhausted all your salvage options, you understand the risk and benefit, and then focal recurrences and interval is more than 6 months. So this is a illustrative case. Here you can see this is the initial tumor, and this is the initial radiation which was given, and this is a recurrent tumor. This volume is very small, so this is an ideal case for Re-RT. When not to consider Re-RT, poor performance status, multifocal recurrence, leptomeningeal disease is present, the imaging shows features of radiation necrosis, early recurrence within 6 months, the volume of recurrence is huge, and the dose constraints you will not be able to meet to the critical structures. So this is the initial tumor, you are given initial RT and the patient has recurred with the contralateral hemisphere. It's more like leptomeningeal disease. So this is not an ideal case for Re-RT. So toxicity, coming to the next part. Common side effects during Re-RT in the first 3 months is the fatigue and the headache. You can manage them adequately with steroids and antiemetics. Late toxicity is basically, we are worried about the radiation necrosis. It's around 15% chances. Cognitive changes, and the treatment for this is bevacizumab once the patient fails on steroids, and regular MRI surveillance is necessary for identifying the radiation necrosis. If you see radiation necrosis among different techniques, with radiosurgery the rates is around 25%. When you fractionate, the rate comes to 13 to less than 5%. Coming to specifically for IDH wild type, so basically now the WHO classification has changed. Now glioblastomas are always IDH wild type. Most of the data whatever we have in the past were combination of both the IDH wild type and the IDH positive tumors also. So this study was basically limited to IDH wild type glioblastomas. There are 88 patients and minimum RT time was 6 months. You can see that the 6-month overall survival is around 72%, which reduces to 10% at 24 months.
they do very bad. Diffuse midline gliomas, they also do very bad. The median overall survival is around 6 months when you give Re-irradiation. But one thing you need to remember here is for Re-irradiation dose for diffuse midline gliomas is only 20 to 30 gray. You are not going to give a very high dose of 40 gray or 50 gray to diffuse midline gliomas. So the primary goal of a treatment would be like to maintain or improve the neurological function. Symptom control should be our key priority. You try to see whether you can reduce the dose of steroids. Cognitive preservation is important, and caregiver burden also you need to consider. Also try to include patient's outcomes, patient reported outcomes also as a part for your overall treatment decision management. So future is like you need to see whether you can combine RT with CAR cell therapy, oncolytic viruses, and whether there is some targeted therapies you can add. Biology guided radiotherapy is a part, and whether you can predict a patient with AI and radiomics to see whether this patient is going to benefit or not. So coming to last two slides, the decision algorithm is like first you confirm whether it's a recurrence, true recurrence, you have to rule out pseudo progression and radiation necrosis. Once you are defined that this is recurrence, then you see whether the patient is a fit candidate for Re-irradiation. You calculate the cumulative doses to the critical structures, choose appropriate technique, implement the technique, and after that you need to have a close follow-up and monitoring, and early intervention for toxicity is needed. So take home would be like you need to have a collaborative approach, multidisciplinary approach which is necessary, good patient selection, there is a small volume disease, focal recurrence, good KPS, time period between the first course and the second course, and the histology is important. Always try to use a modern RT technique such as VMAT or protons, use a short course radiotherapy whenever possible. So this might help us to improve the quality of the life of the patient, and whenever possible, if there is a clinical trial, try to include them to clinical trial. So this will help us to have a good radiotherapy plan for a re-irradiation. Thank you.
Thank you, Rajesh, for finishing on time. Is there any one question or two?
Rajesh, if there is an availability of two different techniques like VMAT and SRT for that patient, what would you choose? And if so, why?
So if you have both the techniques available, I will definitely go for a SRT based technique rather than a VMAT, because in SRT you can use multiple non-coplanar techniques and you can have the normal tissue dose to be much under control than a VMAT.
What will be the dose for bevacizumab for radiation necrosis?
Bevacizumab for radiation, usually we follow Levin's protocol where you give it a dose of 7.5 mg per kg once in 21 days. 4 cycles is the regimen, but unfortunately we see like a lot of patients, if you stop at 4, they come back with a rebound thing. So we try to give it as much as possible extend.
Any prophylactic steroids?
Ma'am, that's a good question, but we try to, because steroids when you give, the immune system comes down. So we had a lot of time, we have been debating whether to give steroids or not to give steroids along with it. But the question is, if you try to avoid steroids, you get patients with a lot of complications whom we might need to consider for admission, reducing the thing. But still we give prophylactically steroids. We give it a dose of 2 mg twice daily for 1 week and then start tapering it.
Thank you so much. We'll conclude the session.
Thank you, sir, for your engaging presentation and the knowledge you have shared. May I now invite the chairpersons to honor the speaker. We invite Dr. Krishna Kumar, sir, Head Scientific Committee AROI, to give memento to the chairpersons. A small announcement. Refreshments are being served outside. Due to want of time, further sessions would continue. Those who have not finished your registration can do it at the reception desk outside. We now move on to a much anticipated session of the day, panel discussion on carcinoma breast. We look forward to a dynamic and enriching conversation from a powerhouse of panelists from all over Tamil Nadu. We welcome Dr. Surendran sir, Dr. Kamachi Memorial Hospital, Chennai, and Dr. Karpavali ma'am, Government Aringanana Memorial Cancer Hospital, Kanchipuram, to chair the session.
stage. So there are about 9 panelists. I don't know how all of them are not. But the most important is Dr. Re-irradiation from Kalchi and Dr. Deepak Ramurthy. May I invite Dr. Deepak Ramurthy. May I invite Dr. Sophia Rajesh. May I invite Dr. Murugesh Kangapermal and Dr. Rajeshkar. I don't know, I have not seen her. Dr. Sundaram and Dr. Balaji Jagannathan, the both invited. Okay. Dr. V. Armugam and Dr. M. Pradeep Kumar. Moderator. Moderator of videos already. Okay. Please go ahead. Yeah.
Good morning to all of you present here, and I thank the organizers for this opportunity. I think without further delay, we will start the panel.
Ma'am, without further delay, can we start the session?
We are glad that the session on cancer cervix is absolutely over, because we normally say cancer cervix is our bread and butter, so that part is complete. Now the breast cancer is also our bread and butter nowadays. In between the brain tumor and 50.
Yes, I completely agree, sir. It's become a very important adjuvant part of treatments, and there have been so many changes coming with breast cancer treatments that we are never too sure of how much more to give or how much less to give. So it becomes very important to take certain decisions. So without further delay, we'll start. So as I welcome all the panelists, and as it is told, all of you are senior members, stalwarts in your own fields. So it is not going to be like, I'm going to be doing something which is going to be different. So I'm only going to be leading warriors in their own field. So just like this Krishna leading, so all of you are subject experts. We are only going to facilitate discussion and what is the standard of care and what are the burning questions which are there in breast cancer. So the first question, as shown, is there's a 44-year-old female who's premenopausal multifilous, lump in the right breast in 6 months, and clinically she's having a 3 cm tumor in the upper outer quadrant with no PUD orange, chest wall is free, right axilla we can see small 1 cm nodes are palpable, and rest everything is normal. Staging workup, whatever is needed is being done, non-metastatic. Biopsy is IDC grade 3, ERPR positive, HER2 negative, and Ki67 30%. So how would you like to proceed? Anyone can take up the thing. Mike?
So as per the case scenario, it is an early breast cancer in a premenopausal lady. So ERPR positive, HER2 negative. So metastatic workup is normal. We can go up from surgery.
Okay. So all of us agree with that? So early breast cancer, ERPR positive, HER2 negative, luminal B, and young female available to surgery, we go ahead with straight surgery. So what surgery would you like to do?
Thank you organizers for having me in this panel. Before that, I would like to say 3 slides. What is the staging workup that is recommended nowadays for CS?
That's a very good question. Any of you may...
No, as per NCCN, they don't recommend any staging workup at all.
Correct.
But normally what we practice is we do for early breast cancer, chest X-ray and ultrasound abdomen.
Correct, yes.
But NCCN recommends you go according to patient symptoms. If there is any sites of metastasis that is likely to be involved, you direct your investigations against.
Yes. So thank you, sir, for bringing this out, because this was something which
this is practical.
thinking. Yes.
I don't know whether this medical legal days.
No, actually, as you're saying, staging workup for early breast cancer is nothing more than an X-ray and ultrasound. And if symptomatic, you go for further things like bone evaluation or something of that sort. Otherwise, for early breast cancers, we do not do any formal staging.
Regarding the surgery, first is the patient's willingness, whether she wants the breast to be. We can offer breast conservation as well as mastectomy. If she is willing for mastectomy, go ahead with the modified radical mastectomy.
Okay.
And the levels of dissection will be level 1 and 2. If there are obvious metastatic nodes in level 1 and 2, then you do level 3 also. But if the patient is willing for breast conservation, you can go ahead with the breast conservation surgery, which is a wide local incision, giving 1 centimeter, aiming for 1 centimeter clearance. As far as axilla is concerned, here what we practice in Tirunelveli is axillary dissection, that is 1 and 2. But if facilities are available and your expertise is available, you can go ahead with the sentinel and proceed accordingly.
So anybody else wants to comment on lumpectomy and ALND or SLND? what would you all prefer in your different institutions? If you
Our institute, we have been doing SLNB on a trial basis, IC and IG, Inaugural. And like we have been picking up good results, and maybe shortly we will be shifting to SLNB.
SLNB. So
the issue with the SLNB is you need to have that double tracer method. So if it is available and if your technique is standardized.
ICG is also proven to be
Yeah, but if it is, you have to standardize your technique. Only when it is false negativity rate is less than 5%, then it is acceptable.
So for the benefit of PGs, so SLNB should be done ideally when there is a dual method, that is the methylene blue which we inject and the technetium whatever is there, the gamma camera and all. Or as sir is saying, even IIG is a proven method, so even that can be done. But dual method has to be practiced. Sorry? No, yeah. So node positive disease is not proven with FNA. So it can depend upon whether you are doing, because nowadays even with 1 or 2 nodes positive, you can still go ahead with an SLNB and give RT to the axilla. So that is also there. In this case, it has been cleared completely. But otherwise, with SLNB also, to avoid morbidity, we can still get away if there is 1 or 2 nodes which are central and node positive. We can get away with only central and node and give RT to the axilla, since we are already going to be treating the breast. N0 clinical, yes. In this we have not done an FNSE. So in this, for a thought-provoking discussion only it was asked whether SLNB also.
And again, this SLNB is being thought about. Just an X-ray and ultrasound is not enough.
Not enough. FNSE has to be done. Yes. So that is also one more thing. If it's an early breast cancer, a little bit high risk, we feel that there are clinically positive nodes in the axilla. We do an FNSE to prove it so that we can manage it better. Node positive, we do an ALND because that's a gold standard. SLNB, very thoughtful procedure. If you are seeing that 1 or 2 nodes are showing light on the procedure, you do a complete dissection, or else you can still get away with RT to the axilla. So BCS has been done, and ALND of course, wide local excision and ALND. Tumor size is 2.5 centimeters with adequate margins. 2 nodes positive, all level 1. No PNS or LT. What would we like to do next?
Whole breast radiation with a tumor post. Axillary nodes.
Okay. Anything before the radiation?
Chemotherapy, yes. Oncology is going to take over.
Okay. Yeah, definitely she needs both adjuvant treatments, that is radiation and chemotherapy. So what chemotherapy would we like to give?
Not positive, so we will like to add taxation cells.
Okay, so what would we like to give, sir?
Both
Adriamycin, cyclophosphamide and paclitaxel. Okay. So would we for a dose-dense regimen or a 3-weekly regimen?
Dose dense only for triple negatives.
If tolerable, okay. If tolerable, dose dense or else 3 weekly is also fine because it's a luminal B, not any high risk like triple negative or HER2 positive. So after this is going to be RT definitely. So what are the sites which we would like to give with this histology? What would be the total dose and what fractionation?
So nowadays we are starting people doing the fast forward trial. So
okay.
With 40.4 grade the whole breast, but along with the SIB with 40 grade to the post-op side. And of course we used to cover the axilla with 40.4 grade. So that is the recommendation. That's been we've been practicing. So it's quite helpful for the patient to complete early, and we don't even have the skin reactions also.
Okay, so 40.4 grade in 5 days?
No, it's been 15 days.
15 days, okay, so moderate hypofractionation.
Moderate.
Okay. And in this case, you would like to cover the axilla yourself?
Of course.
Why?
Because it's 2 positive and the age of, what is the age of the patient?
44.
So it's because young AD and node positive, even though it's 2 node positive.
Complete IMN chain or the first 3 or 4?
Completely.
Complete IMN chain. Okay.
I too will avoid accident. Treatment.
Okay. Sir, next. Sir, we'll finish RT and then we'll go to that next.
Madam, excuse me.
Yes,
One more doubt. So, is there any difference in sequencing? Means chemo first in a post PCS. Is there any different practice anywhere?
Usually everywhere standard of care, and as per whatever available evidence is there, one local treatment is over, we give chemotherapy followed by radiation, unless and until it is a margin positive case, in which again re-excision is advised, that is revision of margins. So in no case do we go for RT immediately, except if it's margin positivity, revision not possible, not done. In those cases only we tend to defer. Otherwise everywhere commonly it is one surgery is done, we do chemotherapy and then only the radiation part. That is also good.
How is the tumor indexed in this case? I mean, how do you localize the local tumor for boost?
For boost. So that is the question which panelists have to say.
Surgeons have to say how it is.
Yes.
Normally what we do is after resecting, we place radio-opaque markers there, clips we used to keep. So that will show the cavity. Even if you are doing oncoplastic procedures also, we will place the clips along the margins of our resection. So in case it turns out to be margin positive, we go and we will orient the specimen also. Superior margin, medial margin, lateral margin, deep margin, like that. So if they give whatever margin is positive, we go ahead again and re-resect that cavity and prove it to be margin negative, then only the breast conservation is complete. If it is going to be persistently margin positive, we'll have to convert it into mastectomy.
Yeah, just a comment. Yeah, so I agree with Sophia that we will not include the axilla. We will include only the SCF, early nodal disease. The second thing regarding IMN, we always do upfront PET CT for all the patients.
Yes.
If the upfront PET CT doesn't show IMN, I never include IMN.
For an inner quadrant tumor also, sir?
Yes.
Okay.
Ma'am, will you go for APPI?
Node positive, so no. So patient selection criteria will not be fulfilled. So we've got a question on APBI also, should be coming towards the end. So that will also be covered in this. But this patient definitely no APBI. It's only the whole breast radiation with SCF fossa plus or minus axilla, depending upon how the surgeon has communicated. If the surgeon feels nodes are removed but not very adequate, can give if the axial dissection is not complete. But if you are sure it is complete, can get away with only SCF fossa radiation and whole breast. And placing of clips is very important, especially since more oncoplastic procedures are done. And it is very important to delineate the entire tumor cavity, because an oncoplastic scar is very huge. We do not want to be irradiating the entire thing. Now another question is ultra hypofractionation. Are we comfortable doing, Dr. Murugesh, your thoughts on that? Are we comfortable doing the fast forward?
For this patient, I won't suggest ultra hypofractionation, because routinely the trial also only no negative patients and were included in the trial. So for this patient, I won't recommend ultra hypofractionation.
So if she's not negative, you would recommend ultra hypofractionation?
Yeah, we can try, madam. Yes.
So what are the pros and cons of ultra hypofractionation if...
The pro is patient can complete treatment within a week, and the con is when compared with the 40 gray or 42 ultra hypofractionation, they are telling there is little more telangiectasia, little more fibrosis.
Yes. So
that's all. Otherwise,
used with caution, but can be in some cases.
Ma'am, is there any mention about the extracapsular extension and LVS in the histopathology?
No.
Because it is for the postgraduates learning.
So,
what is PNS and LT?
PNS is perinodal spreads or extracapsular extension. LT is lymphatic
tumor
emboli.
Okay, thank you.
So both are negative in this case. So that's why the next question was inclusion of regional nodes. So we have already spoken that we will include SCF. So had it been an incomplete dissection or lymphovascular emboli being present or extracapsular extension, would we like to change the fields to or include anything further?
In that case, I think axillary
radiation. So axillary radiation, IMN also we have covered, so it's fine. So what about hormonal treatment after this? As Balu sir was saying, what do we give for her? She's premenopausal.
can start with the tamoxifen. Premenopausal lady, we can go with the tamoxifen.
For how many years, sir?
So as of now, we are practicing for 10 years.
Okay.
So in the perimenopausal period, then we can switch over to aromatase after checking the FSH and estradiol.
Okay. Anybody has got other thoughts?
Hormones, along with I will advocate bisphosphonates.
With tamoxifen, sir?
What about ovarian suppressions like medical ovarian suppressions?
That's what, yeah.
Because 44 years
yes.
after chemotherapy, whether she achieves a chemo-induced amenorrhea.
So do we practice prolonged ovarian suppression with leuprolide and letrozole plus or minus CDK inhibitors, or do we go with the traditional tamoxifen itself?
As you said, tamoxifen, then switch over to aromatase inhibitor is equivalent to 5 years of aromatase
inhibitors. Okay.
But whether she achieves a
menopause or no, we are not sure.
We do that test.
On tamoxifen, how sure are we the FSH-LH drop is because of not tamoxifen?
That is
that is another thing.
That is
Yes.
why we switch over 2 years of tamoxifen and then 3 years of.
So this being moderately, not very high risk, I think tamoxifen 10 years is a decent and cost-effective option. Had it been a little bit more high risk, like multiple nodes positive or a larger tumor size or skin involvement, probably prolonged ovarian suppression with letrozole and plus or minus CDK inhibitors could have been an option.
She's node positive.
She's 2 nodes positive, yeah.
So node positives, aromatase inhibitors
are preferable. Okay.
And also CDK4 inhibitors.
That's all. So that's why. So if an MRM had been done for this patient, any role of RT? So we want to give. So we'll give gestol, SCA fossa. Okay, so this is quite clear. So the evidence is, we know the long-standing evidence, EBCTG meta-analysis of 2011, 2014, START B, fast forward. All of these trials cover all these things, and we have got an undeputed benefit that definitely there is a significant gain at 10 years and 15 years, which is quite historical now. And the thing of radiotherapy to regional nodes in early breast cancer, that is the SCA fossa and all, this was a meta-analysis. Again, it's quite time tested, and the new update has come out now in 2023, which showed that the newer trials showed a more benefit as compared to the older trials, which shows that with improved RT techniques, I think it is very plausible for us to go ahead with radiation to the local treatment as well as to the regional nodes wherever it is indicated. So now we move a little bit towards neoadjuvant chemotherapy in breast cancer, which has been the current rage.
The fractionation is new to me. What is the overall treatment time in that?
So we give 26 gray in fractions.
Only 5 fractions.
Only 5 days.
So it is 5 days.
5 days it is over.
In sequence chemotherapy after that, no? So, see, in short course RT,
the rectal.
only because of the convenience.
That is a very valid point, except in this case, because of the node positivity, they are ultra-fractionated, they practice. But those that are negative, they will, as you say, first they finish off with the thing, then we go to red.
So the thing is, evidence is one thing which we have to see, because they have all used it after chemotherapy. Secondly, rectum behaves more loco-regionally, breast behaves more systemically. So we need to sequence chemotherapy a bit faster as compared to giving 2 local treatments at the same time.
Yes, what's the point in giving a 6 months of chemotherapy and then ultra-fractionating?
So that is why dose dense chemotherapy wherever, see, even you want to become shorter, even we want to become shorter. So ultimate aim is to have the patient finish everything faster. So I think when you give dose dense, you finish it off in 3 to 4 months. And then giving the hypofraction will make more sense, because breast cancer is more systemic. We do not want cells to be spreading.
Yeah. So ultra hypofractionation came during the COVID era. During the COVID era, we want to reduce the number of days patient comes for radiation. That's why it was started, and it's found to be equivalent to 15 fractions. But still, if you have patients with a larger size breast, a lot of fat necrosis that happens with ultra hypofractionation. So I don't practice. I tried, but a lot of fat necrosis happens. So we don't practice ultra hypofractionation unless the patient wants to go to their country sooner. Then we give ultra hypofractionation.
So we'll focus on neoadjuvant chemo because many times we face this dilemma when a patient comes and we are left to think that what should we actually do for her. So this is the next case. So 45-year-old premenopausal uniparous lady, carcinoma left breast T2, N1, M0, FNSU of the left axilla shows a positive node, and she's ER/PR negative, HER2 enriched. For her, staging workup has been a PET CT, which is negative, and she desires breast conservation. Her tumor size is 4 into 5 centimeters, little larger size. So what would we like to do?
Large breast cancer. It is node positive and rectal positive. I prefer neoadjuvant.
Now again, what is the indication for PET CT in CA breast?
Node positive is considered to be high risk, and many of the oncologists are comfortable doing a PET CT for a HER2 positive. We are going to give neoadjuvant, so we do not want to miss anything later on.
So in this case, before starting neoadjuvant chemotherapy, we need to clip the axillary node that is positive, as well as for the tumor, if already they have done a true cut probably, so during that time they could have placed the paste. If not, it has to be placed before discharge.
Yes.
So when do you clip it actually? After the first cycle of chemo? Or?
No, it has to be done ideally upfront.
I think it's good to do it after.
Yeah, some surgeons prefer after one cycle.
One cycle of chemo,
the center of the tumor becomes more normal.
When you prove it is positive, at that time you
To prevent dissemination, the idea of doing it after only.
Like the regression sometimes is spotted, so you can get a good delineation after a second cycle.
Yeah, even my surgeon prefers that we clip after first 1 or 2 cycles, because the regression of the tumor we do not know in which direction is going to happen. So then we want to be absolutely sure where is the center of the tumor to place the clip. So it depends actually. It can be done upfront. It's better than missing to clip. So clipping of the tumor and the node is a must, which is very important. And to miss it is not good, because then we have to end up with an MRM unnecessarily for that lady. So better to clip the tumor either upfront or within 1 or 2 cycles ideally. So next, what chemo would we like to give in this case?
So HER2 positive, we would like to give the HER2 targeted treatment. So ideally you can go with the TCH with P if there is no financial issues.
Okay. So again, based on Neosphere.
Dual block.
Dual HER2. So is there any benefit of giving dual HER2? Like we know that the cost constraints are very high for majority of the patients in our country. So what do we do when she's not able to afford the pertuzumab?
we can't give trastuzumab, and then if residual is that, you cannot escalate to ADC, because the paradigm is to escalate or de-escalate. Suppose if you give a dual HER2 blockade, you can escalate to a TDM1.
But she is not at all affording, sir. She's saying no, she can take. She doesn't have any money. Only carpet is there.
So you want to give 6 months of trastuzumab. All these are all national recommended. 1 year of adjuvant trastuzumab. In node positive, we have to give a dual.
Of now the recommendation would possibly better with the dual blockade. Otherwise we can go with the TCH blockade.
So definitely anti-HER2 is a must. Anybody wants to differ here with anything? So anti-HER2 is a must, definitely, as per the Neosphere, whatever it was. There was shown to be a good PCR effect, as pathological complete response. But if you see the overall survival, there is not too much of a deviation. If you see the range was anywhere between 20% to even 1%, 2%. So I think if somebody is affordable to give, ideally you give dual blockade. Otherwise even trastuzumab for 1 year preferably is definitely the best. At least if not able to take, something is better than nothing. Our 6 monthly or weekly FinHER, even that is quite okay. But ideally wherever possible we have to give dual blockade. So she underwent a BCS. Her post-op histopathology is YPT1N0 with PNS and LT. So now what do we do? The T size is 1.5 centimeters. 1.5.
Whole breast radiation. And I would include the axilla. upfront, positive, large breast lesion,
Okay.
young patient.
But axial dissection is complete.
And I think it's our protocol to treat that.
It's your protocol to do axilla. Okay. Anything different? So, Dr. Sophia or Dr. Mukesh or Dr.
Whole breast RT followed by boost 10 40 grain.
What about regional nodes, sir? SCF or anything you would like?
Axilla, I would. What is PNS?
PNS LT is present. PNS perinodal node spread and.
Then I would prefer to include axilla as well.
Okay, okay.
Now it is N0.
I know. No, the tumor is showing PNS and LT.
So axilla will be.
Axilla will be given.
What if it is negative? PNS LT is
Negative.
What if PNS LT is negative?
Then if the surgeon has addressed the axilla, I would omit axilla. Complete clearance is done.
If the nodal section is complete and there are no iris, just you can omit axillary artery. So if there is no PNS LT, we'll give whole breast plus SCF and a tumor bed boost. And if there is PNS LT, we'll also include the axilla. So that is very clear about this.
And
so
one
what
more
about
thing, is there any adequate axillary clearance was there?
Yeah, it was adequate.
It was adequate. That should also be taken into account.
Yes, definitely. If it's an SLNP, definitely we have to give the axilla. This is a complete dissection, so M0.
Again, what is the indication for a complete axillary dissection in this case?
Upfront axillary node positive.
You have given chemotherapy. Then again, you have targeted, you have placed a clip. If you are going to do a dissection, there is no point in keeping a clip at all. So whatever node that is in the level 1 and 2, it is going to come off. But having placed a clip, here is a role for again sentinel lymph node biopsy and what is called as targeted axillary dissection. That is, you remove the clipped node along with the sentinel lymph node that is identified, and if it is at least three, then your dissection is adequate. So it becomes a targeted axillary dissection. So if that is negative, I presume that is what it was negative. You are saying it is axillary dissection.
Complete dissection because majority.
So the idea of if it is going to be an axillary dissection and again RT is also added, the complications of axillary dissection and lymphedema and other things, it's going to be aggravated.
Yes, definitely.
So if at all there is a role here, I feel that having clipped SLNB will be better than doing an axillary dissection.
That's right.
You have conserved the axilla and then you cannot conserve the primary also, breast also. You cannot be conservative in one area.
One area.
Because the morbidity of the lymphedema is.
So yes, so rightly brought out. Since we have clipped the axilla, we can get away with doing only a targeted axillary dissection or even an SLNB along with the removal of the clipped node. But if a complete dissection has been done and these are the features, then RT to axilla will become critical in either ways.
I have a query here.
Yes.
To all the medical oncologists and radiation oncologists, because many a time the patients go to the medical and radiation oncologists for further treatment. What is it doesn't come to the surgeon. What is the incidence of this lymphedema, which is being widely touted as the reason for all these developments, SLNB and other things? In my personal experience, say around 100 surgeries I have done, some 60% come back to me for follow-up at least for 2-3 years. And amongst the 60, most of them initially I was doing up to a level 3 dissection. And many of them would have undergone RT also. So the incidence of lymphedema per se in those patients was around, say, 2 to 3 among the 60. Okay? So I don't know whether it is, and it is not like the huge lymphedema that is being, the picture is shown in your clinical pictures. It's not like that. It's a lymphedema which can be managed over a period of time with the stocking, pressure garments, etc. So I just want to know from your experience how much is the incidence of lymphedema?
Yeah, this lymphedema things, most of the thing when we are more than 45 gray, these things were reported and that's been carried on forward. But ever since we started using 45 gray in in 25 fractions, it has become less. And the point is there are also studies exploring to avoid, to give only radiation if there is a PET CR, having the clip there, give radiation, no surgery. There are trials exploring that.
I had the same doubt as Dr. Sundaram sir, because I have treated many patients to I have targeted axilla also, because I know what patient I have treated the axilla. And follow, as you told, the lymphedema is very, very less. Many times I have thought that lymphedema is overhyped.
Yes,
because we don't see that much lymphedema.
Yes, it's actually one point which
but
is...
imagine you are doing a breast conservation and you are particular about the cosmetic score in the breast, and then she gets an edema.
Sir, as rightly told, SLNB is the way forward, and we are also very much into it.
And targeted
yes, and art to the axilla.
With the targeted axilla section and radiation, naturally it has.
So ideally, yes, that should be the way forward, since we have clipped in this case both. So this is something which I wanted during the discussion to come out, because it's been clipped, so we can still go ahead with SLNB. But many times when the node is positive, we do not clip the axillary node, because the cost of placing clip is also very high. The cost of placing a clip, one clip,
I don't
is very
think
high.
it is as high as pertuzumab.
Yeah, exactly. I agree, but this is for a patient who is not able to afford pertuzumab, cannot afford two clips in her breast and the axilla. So sometimes when you have got a resource limited setting, in those cases clip only the breast tumor and do an axilla dissection and see if it is no indication. As per the discussion with surgeon, we can omit the axilla. So we try wherever possible not to include the axilla unnecessarily in radiation. Both of them definitely will add to the morbidity, but as Dr. Murugesh told, it is a bit overhyped. We do not see that much of an incidence, probably around 10% to 12% can be. Correct me if I'm wrong.
Yeah, 3%, 10 to 15%, but it actually depends upon the surgeon's call.
Sorry?
Yeah. Locally it's 20%, and we have also looked into our institution, it's 18 to 25%.
Okay.
So lymphedema is not
Overhyped. No, it is like every patient of a breast cancer is receiving because of axillary RT. That is the misconception I want to get rid of. Because many times it is like...
Again depends upon the surgeon.
That depends upon the surgeon then.
So that's what I'm saying.
That depends upon the surgeon actually. Because we do not see... Level 2. No, it depends, because in our institution I can say it has become... Yes. No, in our institution, since we are having a dedicated physiotherapy department who is doing it as a part of their research thesis and all, based on that I can say, when we do treatments like CTRT which gives axillary RT and all, that cases we see lymphedema. Routine cases we do not see much of lymphedema at all.
It's more about rehab. More
Probably
about
about rehabilitation and...
How many more cases you are having for presentation? 3 more.
Okay, we will go very fast. It's not shown here.
Targeted acceleration, we are not sure if the number of accelerators is less than the indication for acceleration. So if we do that, then doing accelerating bringing the more chances of lymphedema. So before considering a TAT, we should plan patient accordingly, because any node positive, it's an indication for regional lymph node also. So in that scenario, if you remove only 2-3 nodes, then the complete axillary resection is not done, then that's the indication for axillary RT post.
So with the third case. So 30-year-old premenopausal nulliparous lady, known family history of breast cancer, CA right breast, T3N1 M0, and FNSC axillary node is positive, triple negative. So how would we like to proceed? Very quickly, since we are running short of time.
PET whole body PET, definitely GPET.
Yeah, staging workup is normal. Staging workup is normal, we have done an FDG PET.
So as of now, we are practicing triple negative breast cancer with neoadjuvant chemotherapy upfront. So either patient is affordable, go with immunotherapy with chemotherapy, or otherwise chemo alone. AC followed by Taxol carbo. This is our practice. AC followed by Taxol, AC dose dense AC followed by Pagli carbo, then go for surgery. If affordability is not an issue, then you can add pembro also.
So that is the standard now. So BCS is done after NACT and immunotherapy. She is YPT2N0. So what do we do next? radiation side?
Adjuvant chemo followed by take for RT.
Chemo is done, NACT is done.
Oh, NACT. Okay, then we take for RT, whole breast RT followed by.
So after that, anything else? Medical oncologist would want to add.
Yes, so we follow 5-2 regimen, adjuvant immunotherapy also.
Okay. Or capecitabine, sir, which would you prefer if she's not affordable or anything?
It's a residual disease, post-chemo residual disease.
Post-chemo residual disease.
Residual disease, we can go with adjuvant capacity, maintenance therapy.
Okay. So, any other workup needed like genetic testing?
Family history, so genetic testing, NGS.
Anything Dr. Pradeep would like to?
So 30 years with family history and triple negative. So I'm a clinical geneticist by the way. So definitely this is clarity. Nobody is going to miss genetic evaluation. But I want to make a point that previous 2 cases also will need genetic evaluation considering the age, 44 and 45.
Yes.
Next generation sequencing is the ideal test to be done here. We have to keep few things, concepts in mind because you don't need to only check BRCA and BRCA1 and 2 because we know beyond BRCA1 and 2 there are many other things which can give rise to genetic cancers. So I would prefer to go for a wider testing, maybe whole exome sequencing or your panel, cancer panel which includes hundreds of genes. But we have to keep in mind that this covers about 90 to 95% of the genetics. If you do next generation sequencing, we will be missing the deletion duplications also. So once this test results comes negative, that doesn't mean we have completed everything. The minor part also has to be covered later. So this has clinical implications in the family. For this particular patient, how we are going to follow up with surveillance. And for the family members, the siblings or even the parents if they are young, 30 years mother. Her mother should be around 50, 55. She may also need, if father also may need, we may not know who is carrying. So it has implication in the extended family as well. There you can prevent so many breast cancers if you do a next generation sequencing and pick up a mutation here.
So what are the differences between somatic and germline testing?
So testing options are widespread, multiple. We need to decide for what we are doing the testing. For this family, I am looking for a germline mutation. Go do a next generation sequencing, try to get the results. Somatic mutations in liquid biopsy, if you want to do it, is for more of therapeutic options. Of course, we'll get some clue regarding germline there also, but it is more for treatment. If you see some mutations, it will be amenable for treatments. It may not be used, this treatment may not be useful. Based on that, you can take decisions. For that, biopsy and somatic mutation can be identified, germline and somatic. So, anything else, ma'am? Raman spectrum scope, yeah.
Excuse me, what about fertility counseling for this patient?
Ma'am?
Actually, what Dr. Pradeep telling is okay. But our patients are always, they will not be able to afford next sequencing or even BRCA1, BRCA2. If you are going for private institution, they cost very much. So in a triple negative, that to young lady, we can advise the family for a preventive aspect. You can ask them to go for, instead of doing all wasting money, advise the parents, that is the patient parent, and the children if they are having, or 30 years she will be having very small child. So advise them if they are having female child, it should be given breast PCS, that is self-examination of the breast, and what are all the preventive aspects that you can give guidance. Instead of doing next sequence, of course, if they affordable, it can be done. But I think it is so costly, and most of our patients may not be affordable. That is one part. And this case, actually, you have told me 30-year-old, very one child, nulliparous. Okay. In that case, ideal will be, even the stage is low, we have to cover the radiation as well as chemotherapy. Some medical oncologists, they are giving us with adjuvant, they are adding carboplatin also, because they found either neoadjuvant or adjuvant. Because they found carboplatin helps in triple negative. Or adjuvant, you can give capecitabine as 14 days therapy, or you can go for metronomic dose for 1 year. That is also helps the patient. But sequencing with regular follow-up and that should be very close follow-up is very much necessary for these patients.
Okay, ma'am. Thank you.
Thank you.
Thank you, ma'am. I like that point.
Yes.
Two
Sure,
check.
definitely.
Yeah. So that was a valid
point. And resource board setting, definitely there is an issue. But we have to compare between doing all the surveillance for everybody who may not be having the risk of cancer, rather than precisely selecting family members and doing one thing. Next thing is this cost. The cost will be around 15,000 to 20,000 to do for a particular patient. Once you identify a mutation, that mutation alone will be checked in the family members. That will be around 5,000.
Yes.
That is not going to be this costly. There are so many other options like with cooperative rhythm in government hospital, we can apply and get it done in a cheaper rate or even free of cost. And most importantly, if you think that this breast cancer is going to present as breast cancer only and you are screening only the breast clinically, you will be missing so many other cancers if the mutation is going to reflect in all other organs.
Yes. So now actually the governments are very interested in putting up a molecular lab, and we are getting proposals for training and all. So then it is something which may slowly start coming less of cost and for everything, because there are very therapeutic implications also. We find out a mutation, we can target that. Recurrences are very common in TNBC, and it will be helpful for that lady to get those. Yes. Oh, we'll go to the last.
Excuse me, ma'am.
One more question.
Due to lack of time, can we move on to the next case?
No, this is a relevant one. So I have a patient whose mother is no more, and we do not know the mutational status of that mother. So she wants to get genetic testing done for herself. What is the thing to be done?
Ideal person is the index person who is affected, where the mutation identification is little better than asymptomatic person. But again, if you want to screen a symptomatic patient, we can advise doing germline mutation analysis for the mother. We have to take it with caution because we will not get black or white results. Sometimes we will stack up with variant of concern and significance. I'll be discussing that in the afternoon session.
Yeah. So last case, very quickly, 68-year-old lady, postmenopausal multiparous, diagnosed with cancer T2N0, ERPR positive or negative, KS7 30%, underwent PCS. Post of HP is PT1C N0. Received adjuvant chemotherapy. Role of RT. Pure RT question.
So I think she's a favorable, but other than K67.
Yes.
So I'll definitely take her for RT, whole breast RT with those.
Okay. Anything else? Any other thoughts? We are going to focus only on RT. She's got chemotherapy for want of time.
Chemotherapy.
She has got, that's what I told. She's got chemotherapy, we are focusing only on RT. Any role of APPI?
It's a possibility.
Yeah.
That is where I can take.
So, revised criteria, we are only focusing on that. So, age more than equal to 50 years, negative margins, T1 or less, DCI is low, intermediate grade, less than 2.5 centimeter margins, and cautionary criteria is all of these. So, we know that APPI is a feasible option. Now, with the fast forward, we can also finish it in 5 days. So, there are, I think you were going to say that.
I was about to tell that instead of APPA, we can do ultra hypofractionation.
Now, Priya, what about what about during surgery, multi-catheter break, you finish it up at that time? Why do you want to postpone that? See, you have done surgery, BCS, do a multi-catheter at that time, frozen you will get the reports. By the time you do a multi-catheter, on the table do a multi-catheter, by the time the surgery is, the catheters are, the suture is removed, the catheters are out.
So that's a very valid point. Yes, I have not come to the methods because we of us won't be having the expertise to do a brachytherapy. So many are focusing on conformal or
This has been done actually. AIMS has been doing what KK told.
Yes,
sometimes we came across.
No, I have done around 40 cases of multi-catheter, so and we are still practicing
it. Happens
like
we tried it, and post-op sometimes the note comes positive. So even there is a solution. This is taken as a boost, and then the EBR is continued.
No, because frozen we do it, and then only we will proceed.
No, even then notes doesn't.
Rarely we do it.
Actually, our institute surgeon is not very comfortable taking a decision only with frozen. So he will want to see them. So we are limited in that. We are not able to practice catheter for those
reasons. We do have an advantage with PET CT. Then if it is not picking up, we still have an advantage.
And we can omit RT for this case.
No, K67
because some one of the
there's a Prime 2 study.
says
There's a Prime 2 trial in which such patient can be omitted on RT also. Yes. But it depends upon whether we really want to do it or no.
K67 is one thing I think you should consider.
Age more than 70 and age more than 65.
Age more than 65, yeah. Age more than 65 can be cautionary, can be omitted also.
I think we could have done.
Dr. Priya?
Yes, we'll close the session.
Thank you. That was an excellent session, wonderful. And one thing,
genomics cannot be just
given up for want of money. That's very important. You should fetch money somehow to get things done. That's an important point. That was an excellent session. Thanks to all the panelists.
Thank you. I thank all my panelists for an excellent discussion. And any other points if anybody would like to add?
Thank you, ma'am. Still out of time, we'll move on to the. Just requesting the chairperson to honor the
moderator and panelists.
We now invite Dr. Devanayake sir to felicitate the chairperson.
We'll move on to the inaugural session.
We now reconvene for the social events. We extend. So just for the postgraduate, sorry, we are conducting the ROAM program for postgraduates, which will be held on the 30th of this month, 30th August. So kindly, who are interested, PGs, final year, exam going PGs and second years, even first years can register and participate. This will be held at Cancer Institute, Adyar,
Please, we will open the registration and everything soon. This is just for your information. Thank you.
We now reconvene for the inaugural address. We extend our heartfelt gratitude to the National AROI for entrusting us with the honor of hosting the 40th TNPY State AROI Conference. We thank AROI-TNPY Committee for providing this opportunity to conduct the 40th AROI-TNPY State Conference. Our theme for this event, Redefining Boundaries in Radiation Oncology, is not just a statement but a call to action. As practitioners, researchers and visionaries, we stand at the forefront of a transforming era. An era where traditional limitations are being challenged, where technology and human insight converge, and where the boundaries of possibility are continuously pushed forward. May I now request all the dignitaries and RC committee members to kindly take their seats on the dais. Now we welcome invite Dr. Bhupal sir, Senior Radiation Oncologist, Chennai, as Chief Guest of this day. We now invite Dr. Srinivasan sir, Secretary General, National AROI. We now invite Dr. Balasundaram sir, President, AROI-TNPY. Now we invite Dr. Balaji sir, Secretary, AROI-TNPY. Next we invite Dr. Baladev sir, VS Hospitals, Chennai, to occupy the dais. We now invite Dr. Balasubrahmanyam sir, VS Hospitals, Chennai, to occupy the dais. Now we invite Dr. Krishna Kumar sir, Chairman, Scientific Committee, AROI, to occupy the dais. Please sir. We now invite Dr. Devanayagan sir, Organizing President and Head of Department of Radiation Oncology, RCC, Tirunelveli, to occupy the dais. We now invite Dr. Vijayaraghavan sir, Patterson Cancer Center, Chennai, to occupy the dais. We now invite Dr. Rajkumar sir, Organizing Secretary and Treasurer, 40th State AROI, AP RCC Tirunelveli, to occupy the dais.
Before we begin today's proceeding, let us pause to remember our departed members of AROI. I request all to rise and 1 minute silence. Departed souls were Dr. Munuswamy, former Director of Kanjipuram Cancer Hospital, Professor Nagarajan, HOD of GKNM Hospital, and Dr. Sankar Narayanan and Dr. K.M. Rai. Ram Ratan Rai.
ஞாயிறும் திங்களும் ஞானத்தின் ஒளி தீபங்கள் ஞானிகளின் அறிவொளியில்
ஒளிவிடும் திக்கட்டும் ஒளி வீசும் தீபங்கள் பலவிதம் தீவினை அகற்றுவதே தீபத்தின் வேதம். இயற்கையோடு இணைந்து குத்துவிளக்கு ஏற்றி விழாவை சிறப்பிக்க மேடையில் உள்ள சிறப்பு விருந்தினர்களை அழைக்கிறோம்.
We now invite Dr. Rajkumar Sir, Organizing Secretary / Treasurer, 48th State AROI, to deliver the welcome address.
I thank you all the dignitaries on the stage for giving us this opportunity to conduct the 40th AROI-TNPY 2025 down south to Madurai, that is Tirunelveli, the first time. I welcome our chief guest, Dr. Gopalan sir, for his esteemed presence and interest for this conference, and Secretary, Dr. Balasundaram sir, the State AROI President, Dr. Balaji sir, the State Organizing Secretary, and the senior teachers, Dr. Bal David sir, Dr. Balasubramanian sir. Because of him only I am standing here. He only encouraged me to continue this course at MMC when I joined there. Dr. Vijay Raghvan sir, and my beloved Professor HOD, Dr. Devanayam sir, he only trusted me and he gave me the full opportunity and he gave me the full free hands to conduct this 40th AROI-TNPY 2025 at Tirunelveli. I welcome you all dignitaries, and I also extend my welcome to all my senior consultants, all my colleagues, all my some of you people are my students, and all the postgraduates. Because of you people only this hall is full. And those who are have registered and who have given me the confidence to attend this conference, and those who people, my colleagues, my PG students who are stands with me for all the support to for the ongoing program to for this mode conducting sessions, and I wish you to make this day not only as a memorable occasion and also a meaningful session. Thank you all.
Thank you, sir. We now invite Dr. Devanayam sir, Organizing President, 40th State AROI, Professor and HOD, Department of Radiation Oncology, RCC Tirunelveli, to deliver the presidential address.
Good morning, Governor. Welcome, and a very warm welcome to all of you. It gives me immense pleasure and pride to welcome you all to this year's AROI conference, 40th conference, a gathering that brings together some of the most brilliant minds and compassionate hearts in the field of radiation oncology. As the Chief of the Department of Organizing President, I stand here not just as a host, but as a fellow clinician who shares your dedication, your dilemmas, and your dreams for a future where cancer is not just advanced, but also accessible and equitable. This conference is more than just a scientific meeting. It's a celebration of collaboration, innovation, and resilience. Over the next few days, we will be witnessing engaging talks, panel discussions, and debates that promise to challenge and ignite thoughts. We have curated a program that spans from bench to bedside, from cutting-edge molecular targets to everyday clinical encounters. And in the spirit of collegiality, we hope to make space for meaningful connections, old friendships, and new partnerships. To the young minds in the room, may this conference be a spark that drives you to pursue more and reach further. To the seasoned experts, thank you for continuing to guide us with your wisdom, grace, and humility. I would like to thank AROI, our scientific committee, sponsors, and every single team member who worked tirelessly behind the scenes to bring his visions to life. As we come together here, not just as oncologists, but as advocates, researchers, and teachers, let's remind ourselves why we do not what we do to give our patients not just more time, but better time. Let the learning begin, let the conversation flow, and let this conference be one to remember. Thank you again.
Thank you, sir. Now we welcome Dr. Bhupal sir, Chief Guest of the Day, to address the gathering.
I'm really taken aback beyond expression, and I'm feeling grateful for the 14th AROI-TNPY conference for having chosen me as a chief guest, which honestly I feel I do not deserve. For such of those people who do not know about me, I am a product of Andhra Medical College for my undergraduation, product of postgraduate in MMC. So my alma mater in medicine is Mother Medical. My alma mater in my post-graduation is MMC, and my alma mater in government service is Tirunelveli Medical College. That's the most important thing I wanted to share with you. For all the way I see the scientific proceedings, it's not to boast you or me, it is really very much above level. I wish this continuing medical education programs continue like this forever. God bless.
Thank you, sir. We now welcome Dr. Balasundaram sir, President AROI, to deliver today's keynote speech.
So good afternoon everyone. Respected teachers, all the 4 are teachers. So here we have a lot of teachers. For these teachers, they are the teachers. So it is a real honor for us to have them as chief guests in the dais. So we welcome Professor Dr. Bhupal sir, Professor Balu David, Professor Balu Subramaniam, and Dr. Vijay Raghavan, and our esteemed senior colleagues, dear friends, and respected AROI members. It is with great honor and enthusiasm that I stand before you today at this August gathering, the 40th AROI-TNPY State Annual Conference being held in this scenic Kuttalam. So, the burden of cancer continues to rise. In Tamil Nadu, they have reported close to 85,000 of new cases per year. So, this demands a well-distributed oncology care infrastructure. Luckily, our state, we have made a notable advancement in cancer care services. Today, the state has got close to 60 functional cancer centers, including governmental, private, and charitable institutions. So many of which are well equipped with state-of-the-art radiotherapy facilities. So the new personalized protocols, we are pushing the limits of what is possible for the patient's care. I extend my gratitude to the host of this 40th AROI conference, the Department of Radiation Oncology, RCC, Tirunelveli Medical College and Hospital, and Deva's Cancer Care Center, Tirunelveli, for organizing this academic feast in such a beautiful setting. Our thanks to Secretary General of National AROI, Dr. V. Srinivasan, for his support and guidance. Our thanks to Professor Dr. Devanayagam sir, our organizing president, Dr. B. Rajakumar, our organizing secretary, for their tireless efforts and inspired leadership. The entire organizing team deserves appreciation for an outstanding academic experience. I would also like to acknowledge the support of our AROI State Chapter team. So thank you Dr. Balaji, Dr. Deepak, our treasurer, for your constant efforts in driving the chapter's vision forward. A special word of appreciation to Dr. Krishna Kumar, chairman of the scientific committee. And he has crafted a good academic schedule which is a rich and relevant scientific program. I also commend Dr. B. Rajesh of CMC Vellore, Dr. Karthikeyan Perumal and Dr. Jiva of the core committee for their excellent work. Throughout for the past 2 years, I think they have done close to 15 to 20 programs. So which is a benchmark. Nobody has done that so far, I feel, and it's a very wonderful work by core team. So as we move ahead, let us collaborate, learn and innovate together, because every stride we make here, every protocol we refine, and every patient we serve brings up one step closer to the world, where cancer is no longer a death sentence. It is a conquerable challenge. So let us continue to stand together as clinicians, as researchers, teachers, and above all as healers. So thank you. I wish you all for a highly successful and enriching conference. Thank you very much.
Thank you, sir. To deliver the next keynote speech, we invite Dr. Balaji sir, Secretary, AROI-TNPY.
Respected President, senior members, Executive Committee, esteemed members of AROI-TNPY, dear friends, colleagues, students and guests, Vanakkam and very good morning to all of you. It's an honor for me to stand before you today, here amidst the serene beauty of Kuttalam as we inaugurate this year's 40th Annual State Conference of Association of Radiation Oncologists of India, Tamil Nadu and Puducherry Chapter. As your State Secretary, I have had the privilege of serving this prestigious association for the past year. This journey has been filled with immense learning, collaboration and above all, a deep sense of responsibility. Today, as I stand at the end of my tenure, I look back not just with pride but with profound gratitude. Over the past year, we have strived to strengthen academic engagement, encourage research initiatives, and build a stronger sense of community among radiation oncologists in our region. We have conducted successful CMEs, webinars, and collaborative programs. Thanks to the untiring support of our executive committee, organizing teams, and every one of you who participate with dedication and enthusiasm. I extend my heartfelt thanks to organizing chairman, Professor Devanayagam Sir, organizing secretary, Dr. Rajkumar, and the entire Tirunelveli Department of Radiation Oncology and his team, and the scientific committee who worked tirelessly to bring this event together. Organizing a conference in location like Kutralam, known for its natural beauty and wellness, is both a challenging and a blessing. And I must say they have done a phenomenal job. Kindly give an applause. It is with deep sense of privilege and gratitude that I present the Secretary's annual report, summarizing the activities and what we have done. Academic activities for this calendar was vibrant and engaging. We have conducted 7 CMEs and 13 core workshops. As a part of a membership drive, we continue our works, expand the AROI-TNPY family, bringing in new members and encouraging active participation from all corners of the region. We have enrolled 123 new members in the past 2 years. Thanks for all the institutional heads for encouraging the refugees. We have collaborated with Freedom from Cancer Care Group. For the past 2 years, we are conducting CMEs along with them. This year, we are proud to host the annual conference at Kutralam. And regarding communication, we have done regular WhatsApp updates and open discussions, help ensure clarity, transparency, and engagement across all the levels of our session. Acknowledgements. I take this opportunity to thank our President, senior members, Executive Committee, Core Committee, and their unwavering support. I extend my special thanks to Dr. Karthikeyan for efficiently managing academic programs, Dr. Rajesh Kar, who worked diligently to arrange sponsorships for CMEs, Dr. Varadarajan and Dr. Deepak from Billroth Hospital for graciously allowing us to use their department space for AROI-TNPY office purpose. Thank you. Serving this association as secretary has been a tremendous honor. Though my term ends, my commitment to AROI will continue as a contributing member and friend. To all the young minds and postgraduates here, I urge to continue carrying the torch, academic curiosity and compassionate care. You are the future of our specialty, and it's heartening to see your active involvement. As I prepare to pass on the baton, I thank AROI-TNPY family for trusting me, guiding me, and giving me the opportunity to serve. Special thanks to my fellow colleagues, seniors, members who stood by me through this journey. This isn't a goodbye, it's a promise to continue contributing as a member of this vibrant community. Let us now look forward to 2 days of meaningful scientific exchange, bonding, celebration under the healing skies of Kutralam. Thank you all. Long live AROI-TNPY.
Thank you, sir. Now, marking the moment with mementos, time for felicitation. We now invite Dr. Balasundaram sir to felicitate Chief Guest of the Day, Dr. Gopal sir. We now invite Dr. Devanayagam sir to honor Dr. Baldevan sir. We now invite Dr. Srinivasan sir to honor Dr. Balasubramanian sir. We now invite Dr. Balaji sir to honor Dr. Vijayarajan sir.
எல்லோருக்கும் வணக்கம். முதல்ல இந்த கான்ஃபரன்ஸ்க்கு வரும்போது நம்ம ஃபஸ்ட்டு எல்லாருக்கும் சொல்கிற மாதிரி ஐ எம் அ பர்மனன்ட் ஸ்டூடெண்ட் ஆஃப் ஆங்காலஜி. ஸோ இந்த கான்ஃபரன்ஸில் கற்றுக்கிறதுக்காக வந்த பிறகு இந்த மாதிரி மேலையில் உட்கார வச்சு ஒதுக்கி அப்புறம் தலைப்பாகையும் தலையில் வச்சு என் தலைக்கு வரதெல்லாம் தலைப்பாயோடு போயிட போதும் பயமாயிடும்.
We now invite Dr. Balasundaram sir to felicitate Dr. Devanayagam sir.
பாருங்க
We now invite Dr. Balaji sir to honor Dr. Rajkumar sir. We now invite Dr. Devanayagam sir to honor Dr. Srinivasan sir. We also request Dr. Devanayagam sir to honor Dr. Balasundaram sir. We now invite Dr. Rajkumar sir to honor Dr. Balaji sir. We also request Dr. Rajkumar sir to honor Dr. Krishna Kumar sir. We now invite Dr. Rajkumar sir, Organizing Secretary and Treasurer, 40th State AROI, to deliver the vote of thanks.
Hello. Sorry, time நிறைய போயிட்டு இருக்கு. Sir, Bobby sir பேசு. பேசணும்னு நினைக்கல, பேச சொல்லிட்டாங்க. Respected Professor Gopal, my teacher, when I joined DMRT in 1982 in MMC along with Dr. Sekhar Selliplay and Soundroli Harris and Kalaivanan, and he was my teacher, excellent teacher, especially in brachytherapy, and this radiative isotopes is wonderful, he will teach. And other dignitaries, I know my dear students and my friends, I am very much happy to be in the midst to have this joint conference, learn something from you. The Bible or Vasanarku. நான் ரொம்ப நேரம் பேசல, டைம் ஆயிடுச்சு. பைபிள் ஒரு வசனம் இருக்கு. Remember them who have taught you. உங்களுக்கு போதித்தவர்களை நினைத்து. In that way, I have the privilege to remember my teacher, Professor M. Jagadishan. He's a very good teacher, above all very good father. Not only he will behave as a teacher, he will behave as a father to the students. And Professor Bhupal எனக்கு அடிக்கடி சொல்லுவார், கழுவுற மீன் நழுவுற மீன். அப்படி சொல்லி என்னை டீச் பண்ணாம so friendly with us. So I thank Dr. Devanagam. 2001 MMC was first HOD, was MD doing, and also, and I thank you because remembering me and invited me, sir, you come here, we want to honor you. So God bless you, and thank you for Rajkumar wonderfully, and God bless you. I wish you all success this conference.
இங்கு குழுமியிருக்கும் மருத்துவ வல்லுநர்களே மற்றும் இயற்பியல் துறை பேராசிரியர்களே, எனது அருமை மருத்துவ மாணவ அணிகளே, உங்கள் அனைவருக்கும் எங்கள் உளம் மகிழ என்னுடைய வாழ்த்தினை தெரிவித்துக் கொள்கிறேன். நான் முதலில் 1984ஆம் ஆண்டு இந்த துறையில் அடியெடுத்து வைத்தேன். அப்போது என்னுடைய பேராசிரியர் பூபால் தான் என்னுடைய பேராசிரியர். அவர் தான் எனக்கு முதலில் ரேடியோ தெரப்பியில் ABCD என்பதை சொல்லிக் கொடுத்தார். அப்போதெல்லாம் 2D ட்ரீட்மெண்ட் தான். நாங்கள் கோடு போடுவோம், அவர் அதை கலைத்து விட்டு கரெக்டாக கோடு போட சொல்லிக் கொடுப்பார். அதுக்கப்புறம் நாங்கள் ரோடு போடுவோம். அதே மாதிரி என்னுடைய இயற்பியல் துறை பேராசிரியர் தயாளன் அவர்களும் எனக்கு டோஸ்னா என்ன, கிரெயின்னா என்ன, எப்படி ஒரு லீனியர் ஆக்சிலேட்டர், ஒரு அப்புறம்லாம் கோபால்ட்டு எப்படி அதை நிறுவனம், அதெல்லாம் எனக்கு ரொம்ப அருமையாக சொல்லிக் கொடுத்தார். இன்னும் அவர் எனக்கு அறிவுரை சொல்லிக் கொண்டு தான் இருக்கிறார். அதே மாதிரி என்னுடைய மாணவர்கள், எனக்கு ஸ்கூல்லேருந்து டீச்சர் ஆகணும்னு ரொம்ப ஆசை. அதுக்கப்புறம் நான் மருத்துவரான பிறகு இந்த மருத்துவக் கல்லூரியில் எனக்கு டீச்சர் ஆகும் வாய்ப்பு கிடைத்தது எனக்கு ஒரு பெருமிதம் அடைகிறேன். அடுத்தது நான் என்னுடைய ஃப்ளாஷ்பேக் சில துளிகள். முதலில் அராய் என்பது 1984ஆம் ஆண்டு இது 40வது அராய். அது முதல் அராயை பற்றி நான் கூறுகிறேன். பேராசிரியர் பூபால் அவர்களுக்கும் பேராசிரியர் தயாளன் அவர்களுக்கும் தெரியும். முதலில் அடையார் பார்க் என்னும் 5 ஸ்டார் ஹோட்டலில் சென்னையில் முதலில் அது கொண்டாடப்பட்டது. 5 ஸ்டார் ஹோட்டல்னால் என்னன்னு அப்போ தான் நாங்கள்லாம் பார்த்தோம். அந்த 5 ஸ்டார் ஹோட்டலில் முதல்ல அந்த ஃபஸ்ட்டு அராய், ஸ்டேட் அராய் கொண்டாடப்பட்டது. அப்போது ENT டிபார்ட்மெண்ட்டோடு சேர்ந்து அது அங்கு மிகவும் சிறப்பாக நடைபெற்றது. இன்னும் அது அப்படியே மெருகேற்றி மிகவும் சிறப்பாக நானும் 40இல் ஒரு சிலர் தவிர மற்ற எல்லா மாநாடையும் நான் தவறாமல் கலந்து கொள்வேன். மிகவும் சிறப்பாக நடந்து கொண்டிருக்கிறது. இங்கு இந்த குற்றால அருவி போன்று இங்கு நாலேஜ் அருவி கொட்டி கொண்டிருக்கிறதை பார்க்கும்போது மிகவும் மகிழ்ச்சியாக இருக்கிறது. இந்த மாநாட்டின் வரலாற்றிலே பொன் எழுத்துக்களால் ஒரு பொறிக்கப்பட வேண்டிய மாநாடாக அமையும் என்பது மற்றும் எல்லாருக்கும் எல்லா நன்மைகளும் கிடைக்கப்பெற எல்லாம் வல்ல இறைவனை வணங்கி வாய்ப்பளித்த நல்ல உள்ளங்களுக்கு நன்றி கூறி விடைபெறுகிறேன். வணக்கம்.
அனைவருக்கும் வணக்கம். நான் ஏற்கனவே ஃபர்ஸ்டே சொல்லிட்டேன், இந்த 40th அராய் TNPY 2025 நடத்துறதுக்கு சப்போர்ட்டாக இருந்த எல்லாருக்கும் முதல்ல ஒரு பெரிய தேங்க்ஸ். ஏன்னா நீ நடத்து அப்படின்னு சொல்லி எல்லாம் ஃபுல் ஃப்ரீடம் கொடுத்து சப்போர்ட்டாக இருந்த எங்கள் சீஃபுக்கு ஒரு பெரிய தேங்க்ஸ். பூபா சார் டே ஒன்லேருந்து எனக்கு என்ன ஒரு பெரிய ரெஸ்பெக்ட்கிட்டு மெசேஜ் பண்ணுவார். எல்லாம் அவருக்கு இவ்வளோ பெரிய டீச்சருன்றதெல்லாம் நான் இங்கே வந்து ஸ்டேஜில் வச்சு தான் பார்க்குறேன். அது எனக்கே ஒரு பெரிய சந்தோஷமோ, இவர் நம்மளை இவ்வளோ இதுவாக வச்சுருந்துருக்காரு அப்படின்ட்டு அதுக்கு ஒரு பெரிய தேங்க்ஸ். என்னோட டீச்சர் பாலசுப்ரமணியம் சார் அந்த கோர்ஸ் ஜாயின் பண்ணிவிட்டு மாறும் போது வேண்டாம் ஹீரோ உங்கள் ஏரியாவில் யாரும் இல்லை, நீ போனால் இதில் கொஞ்சம் நல்லா ஷைன் பண்ணுவேன்னு சொல்லி எனக்கு இன்னைக்கு இந்த ஸ்டாண்டர்டுக்கு நான் வந்ததுக்கு என்றைக்குமே அவரை நான் மறக்கிறது கிடையாது. இன்னொரு டீச்சர் நல்ல SSK சார் எனக்கு கான்ஃபிடெண்ட்டாக ப்ராக்டிஸ் பண்ணுறது எல்லாத்துலேயுமே அந்த ஒரு கான்ஃபிடென்ஸை க்ரியேட் பண்ணி கொடுத்தது அவர் தான். அவருக்கு ஒரு பெரிய தேங்க்ஸ். பாலு டேவிட் சார் வந்து எங்கே சார் அவர் என்னோட டீச்சர்ப்பான்னு அவங்களெல்லாம் ஹானர் பண்ணணுன்ட்டு விஜயராகவன் சார்லாம் இவ்வளோ பெரிய சீனியர்னு ஃபோனில் பேசும்போது எனக்கு தெரியாது. மோரோவர் இங்கே இருக்கிற எல்லா டிக்னிட்டரிஸ் மெயினாக நம்ம பாலசுந்தரம் சார், ஸ்ரீனிவாசன் சார், அவர் ஏதோ வெளியில் இருக்கும்போது கூட நான் பாட்டு ஃபோன் பண்ணுவேன், ஒன்றும் இல்லைடா பார்த்துக்கலாம் வச்சுக்கலாம் நீ அனுப்ப நான் பார்த்துக்கிறேன். அந்த அளவுக்கு ஒரு சப்போர்ட். நான் இது வரைக்கும் இந்த கான்ஃபரன்ஸுக்கு முன்னாடி வரைக்கும் யார்கிட்ட இவ்வளோ பக்கத்தில் போகிறதுக்கு எனக்கு ஆப்பர்ச்சுனிட்டி கிடைக்கல. அப்படி ஒரு ஃபார்முலா விஷ் பண்ணுவோம் அதோட போயிடுவோம். பட் அதுக்கு நான் பெரிய தேங்க்ஸ் சொல்லணும். சீனிவாசன் சார், பாலசுந்தர் சார் காலையில் சொல்லுவார் நடத்த அது தொடங்கிட்டேன்னு வச்சுக்கோங்க அது அப்படியே போயிடும் அப்படின்ட்டு. கொஞ்சம் டென்ஷன் இருக்கும், இவ்வளோ பெரிய கான்ஃபரன்ஸ் ஏதாவது நடக்குமோ ஏதாவது சரியாக வராதோ அப்படின்ட்டு. அதுக்கு அவருக்கு ஒரு பெரிய தேங்க்ஸ். பாலி சார் அப்படியே சிரிச்சுட்டே சொல்லுவார் ஒன்றும் இல்லை பார்த்துக்கலாம் அப்படின்ட்டு. அலெக்ஸ் சார் ராஜ் விடுங்க ஒன்றும் இல்லை அப்படின்வாரு. தீபக் சார் we are here to support you. அந்த மாதிரி நான் யாரையும் மிஸ் பண்ணியிருந்தா ரொம்ப சாரி. அவர் வரதராஜன் சாரும் எது கேட்டாலும் டக்குன்னு ஃபோனில் ரெஸ்பாண்ட் பண்ணுவாங்க. கோர் மெம்பரில் டாக்டர் கார்த்திகேயன் பர்மா சார் அகாடமிக்ஸில் இவ்வளோ பெரிய இன்ட்ரெஸ்ட்டாக சும்மா இருக்கிறவனே காதை பிடிச்சி எடுத்து படிக்க வைக்கிற டீச்சர் மாதிரி அதை நடத்துகிறேன் இதை நடத்துகிறேன் வாங்கன்னு சொல்லி அவ்வளோ அகாடமிக்ஸில் இவ்வளோ இன்ட்ரெஸ்டடாக எங்களுக்கு பதிலாக அவர் ஒரு ப்ரீ கான்ஃபரன்ஸ் ஒர்க் ஷாப் எங்களுக்கு இங்கே வச்சு நடத்த முடியாதுன்ற நாங்கள் எக்ஸ்பிளைன் பண்ணிட்டோம். பட் அவர் நான் நடத்துகிறேன்னு சொல்லிட்டு ஒரு ஆன்லைனில் 4th அன்னைக்கு ஒரு ஒர்க் ஷாப் நடத்தி கொடுத்தாரு. அவரும் ராஜேஷ் சாரும் ஜீவா மேடம் வரல. சயின்டிஃபிக் கமிட்டி கிருஷ்ணகுமார் சார் எனக்கு பெரிய பேக் சப்போர்ட். இந்த கான்ஃபரன்ஸில் எனக்கு பெரிய ஹேண்ட் அவர் பின்னாடி எனக்கு ஷேடோ மாதிரி இருந்துட்டு நிறைய கைட் பண்ணார். ஏன்னா அவங்கெல்லாம் பெரிய எக்ஸ்பீரியன்ஸ் பீப்புள் ஹேவ் கண்டக்டட் ஸோ மெனி கான்ஃபரன்சஸ் அண்ட் ஆல். இது இப்படி பண்ணணும் ஒன்று ஃபோனில் பண்ணும்போது நான் பயங்கர ஃப்ரெண்ட்லியாக எனக்கு அவ்வளோ நல்லா என்னென்ன ஸ்டேஜில் என்னென்ன பண்ணணுன்ட்டு. அதை தாண்டி இங்கே இருக்கிற எக்ஸிக்யூட்டிவ் மெம்பர்ஸ் எல்லாருக்கும் ஒரு தேங்க்ஸ். எல்லாத்துக்கும் மேலே என்ன யாருன்னே தெரியாது, எனக்கும் தெரியாது. நான் இங்கே தான் பேர் வச்சு கேட்குறேன் நீங்கள் தானா அப்படின்ற மாதிரி. அந்த மாதிரி நான் ஃபோன் பண்ணதுக்கு எல்லாம் அக்செப்ட் பண்ண பேனலிஸ்ட், மாடரேட்டர்ஸ், ஸ்பீக்கர்ஸ், அந்த ஹோல் சயின்டிஃபிக் கமிட்டி டீம், உங்கள் பிரியா மேடம் எல்லாருமே நான் அந்த கமிட்டியில் ஆன்லைனில் தான் பார்க்குறேன். ஜெகதீஷன் சார் ஃப்ரம் ஜிக்மர், செல்வமணி மேடம், அப்புறம் ஜீவா மேடம், எல்லாருக்குமே பெரிய தேங்க்ஸ். என் அண்ணனுக்கு எல்லாத்துக்கும் அக்செப்ட் பண்ணிக்கிட்டு சார் உங்களை ஸ்பீக்கராக போடுறோம், உங்களை சேர்பர்சனாக போடுறோம், மேடம் இப்படி போடுறோம், எல்லோரும் ஓகேன்னு சொல்லிட்டு வந்தாங்க. அவங்களுக்கு எல்லாருக்கும் ஒரு பெரிய தேங்க்ஸ். இது நான் சும்மா தேங்க்ஸ்னு சொல்லிட்டு போகிறது ஃபார்முலாக எல்லோரையும் கவர் பண்ணிட்டேன்ற மீனிங் இல்லை. இட்ஸ் ஃப்ரம் மை ஹார்ட் பிகாஸ் ஐ வேல்யூ ஈச் அண்ட் எவ்ரி பர்சன்ஸ் டைம். எல்லாத்தையும் தாண்டி அவங்கவுங்களுக்கு சில பர்சனல் கமிட்மெண்ட்ஸ் எல்லாம் தாண்டிட்டு நம்மளை ஒரு வேல்யூ பண்ணி அதை அட்டன் பண்ணுறதுக்கு வர்றது இவ்வளோ தூரம் செலவு பண்ணி வர்றதுன்றது ஈஸி ஜோக் கிடையாது. ஏன்னா நானும் அங்கங்கே எங்கே போகிறோம் இல்லையா, நமக்கு உண்மையிலுக்குமே அதுக்கு போகிறோன்னா அதுக்கு எந்த அளவுக்கு இம்பார்ட்டன்ஸ் கொடுத்து போகிறோன்றது அர்த்தம். அந்த இம்பார்ட்டன்ஸ் கொடுத்த எல்லாருக்குமே மிக மிக நன்றி. அது எல்லாத்துக்கும் மேலே என்னோட கலீக்ஸ் முன்ன பின்ன அப்படி கடைசி நேரத்தில் எல்லாருமே இவ்வளோ ரஷ் பண்ணாங்கன்றது வந்து எனக்கு பெரிய சந்தோஷம்தான். அது அவங்க கலீக்ஸ்க்கு ப்ளஸ் என்னோட பிஜிஸ் சொன்னதை வந்து ஏதோ சிம்பிளாக முடிப்பாங்கன்னு பார்த்தா மெனக்கட்டு விடிய உட்காந்து இவ்வளோ ஒர்க் பண்ணது வந்து பார்த்தேன். உண்மையிலுமே ரியலி அப்ரிஷியபிள். அண்ட் ஐ தேங்க் ஆல் த போஸ்ட் கிராஜுவேட்ஸ் ஃப்ரம் ஆல் த வேரியஸ் இன்ஸ்டிடியூஷன்ஸ் அண்ட் ஆல் த ஹெட் ஆஃப் த டிபார்ட்மெண்ட்ஸ் அண்ட் their teachers specifically to support their postgraduates to present the oral presentations and the e-posters. ஏன்னா அதுக்கு ஹெச்ஓடிஸ் எனக்கு பர்சனலாக ஃபோன் பண்ணும்போது தான் எனக்கு புரிஞ்சது, ஓஹோ இவ்வளோ ஸ்டூடெண்ட்ஸ் பின்னாடி இவ்வளோ பண்ணலாமோ அப்படிங்கிற மாதிரி. அது அவங்களோட அசிஸ்டன்ஸ் எல்லாருக்கும் தேங்க்ஸ். என்னோட டீச்சர் இப்போ எங்கள் சுந்தரேசன் சாரும் நித்யா மேடம் வந்திருக்காங்க. அவங்களும் எல்லாம் எந்த அளவுக்கு இது பண்ணியிருக்காங்கன்றது எனக்கு புரியுது. ப்ளஸ் எங்கள் கான்ஃபரன்ஸ்க்கு சப்போர்ட் பண்ண ஸ்பான்சர்ஸ், இது எல்லாத்தையும் தாண்டி வெளியில் மற்றவங்க எவ்வளோ பேர் சப்போர்ட்டாக இருந்திருக்காங்க. இவங்க எல்லாருக்கும் தேங்க்ஸ் சொல்கிறதுக்கு நான் வந்து கடமைப்பட்டிருக்கேன். மிக மிக நன்றி. தேங்க்யூ ஆல். நைட்டு கேலா டின்னர் எங்களுக்கு தெரிஞ்ச ரேஞ்சில் அரேஞ்ச் பண்ணியிருக்கோம். எல்லோரும் என்ஜாய் பண்ணுவீங்கன்னு நம்புகிறோம். மேக்ஸிமமாக எல்லாருக்கும் ஒரு ப்ளூ கோட் கொடுத்துருக்கு. ப்ளூவோட மீனிங் எல்லாருக்கும் தெரியும். அண்ட் ஆல்சோ ஐ திங்க் தட் இட் வில் ஷோ த யூனிட்டி அமாங் அவர் செல்ஸ். தேங்க்யூ ஆல். தேங்க்யூ.
Thank you, sir. Now I kindly request all to stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगल दायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे.
So he taught me clinical medicine as what I know it today, and for that I'm always grateful to my mentors in head and neck, Dr. Venkateshan in London, Ontario, where I did my fellowship, Dr. Siraj Hussain in Calgary, Alberta, and my expertise in prostate cancer and genitourinary cancers are all thanks to him. And I can never forget my teachers, Dr. P.N. Vishwanathan, Dr. Subhashini John, Dr. Paul Ravindran, and Dr. Ravi Raja Singh, who have really shaped me for what I am today. So I think the question now is, why did I choose head and neck and esophageal cancers? So I'll come to it. So I'll just do the outline. I'll talk about the challenge. Then I'll talk about my work, which has mainly been in functional imaging head and neck cancers. I'll talk about the various modalities, PET, CT, functional MRI. Then talk about the few studies we did on CMC, and then talk about what is there in the future for us. So I think I don't need to elaborate this again. We are all living in India where head and neck cancers are rampant, and almost 30 to 40% of all cancers we see are head and neck cancers, and more than 90% are squamous cell carcinomas. And in India and the subcontinents, we know we have this habit of tobacco chewing, tobacco smoking, wheat liquid, areca nut, slate, knife, gurkha, all create havoc on our populations and end up with head and neck cancers, and I may even extend and say esophageal cancers. Unlike many of the other cancers, we don't have very well developed or very well designated biomarkers. The only one which we have is a couple of ones. We have HPV, which is the biomarkers IHC and P16. Again, not very common. Most of our patients, it's only about, the various studies have claimed to be around 7% to 33%. But as we all know from the seminal paper from Keynote, that most of our population use tobacco, wheat liquid, areca nut, slate, gurkha, and then that negates whatever benefit they have of these cancers having a good prognosis. Then we have EBV DNA titers in undifferentiated carcinomas of the nasopharynx. Again, these are very specific to our population, most common in Nagaland and the northeast. So many of our other patients who come from the rest of India may not have these same histology, or may not show titers, positive titers when we do their EBV DNA titers. And of course, this leads to poor outcomes. The recent data is showing that 5-year overall survival for patients who use tobacco and alcohol is only 29%. And there is a delay in diagnosis in India, which is still happening. So very rarely we see patients in stage 1, first stage, where you can have a survival of almost 100%, but we usually see patients much later stages where it can drop to almost 42%. So again, we need a lot of work to do. And so what is the imaging modalities we have in head and neck cancers? So this, I think all students know, we are doing it for all our patients. The most common modality is contrast enhanced CT. Then for some subsites, we're using the magnetic resonance imaging, using gadolinium as a contrast agent, and of course, positron emission tomography, CT scans, which give us some idea of the biological function of these cancers. So, before I go into what I'm going to talk about, I just wanted to tell you what was the background of getting interested in functional imaging. So first, I don't know why I got interested in head and neck cancers. It's just that maybe when I was a student, I liked ENT, so that I had a natural affiliation. When I joined radiation oncology, to gravitate towards head and neck cancers. And through my time as a postgraduate and my early years as a radiation oncologist, I found patients stage by stage, side by side, they'll have the same disease, but they will have absolutely different outcomes. So we could not explain why this was happening. And the same, if you put two same patients, one would get cured, one would not get cured. And we had no idea why that was happening. And that was when I said, okay, we have to look further into this. And my interest was piqued when I went for an ISRO conference, I think it was in Amsterdam, where the pre-conference workshop was on functional imaging in cancers. So there I heard the world experts talking about the various modalities available to do functional imaging and why we need to do it. So when I came back, it started my desire to see what we could do in our resource constrained setting. We did not have the funding which is available in Europe and in the West, where you can get grants and you can use a lot of money when you try to do these studies. So finally, I could sort of center in on diffusion weighted imaging, and which I'll elaborate more later. So just to tell you about what is, why do we need to do functional imaging? So we all know head and neck cancers, one of the major reasons why they don't respond to radiation or chemoradiation is because you have hypoxic areas. So we need to identify these radio-resistant areas. And then we need to see we need to do patient selection. So you can't throw the same thing, same treatment at everyone. You need to stratify them. So you need, if you have a patient who's not responding well, maybe you need to go up on the radiation dose. If you have good responders, there is a case in point to de-intensify. And I think a lot of research is going on into that, where we're trying to reduce the dose, trying to reduce the chemotherapy, and reduce the toxicity. And of course, we'll have these non-responders. So we have patients who may progress during treatment. So these are the patients where we must say, okay, I think we need to stop and look at other options, or maybe go into palliation, because we're just giving toxicity without any benefit. So what are the various modalities available? So which are the areas we need to look at? So we first talk about metabolic information. So for that, the best investigation we have is the PET scan. Then if you want to look at cellular information, what is happening within the tissues, you look at diffusion weighted imaging. Perfusion information, that is how well tumors are perfused by contrast enhanced MRI. Then there are some other techniques, which are the arterial spin labeling, MR perfusion, oxygen by R2 bold, so which actually look at the iron levels in these tissues. So I'll just briefly talk about PET scan, which is not the focus of my talk today, because we all use it. We all know how useful it is and why we need to keep using it. So it is, I think it was one of the first metabolic functional imaging which was available to us as oncologists. So we use it all the time for our diagnosis, staging, radiotherapy planning if we have the possibility, and of course for post-treatment surveillance. These are all the first, it's all standard of care. And we know that SUV values can predict, pre-treatment can predict the stage, and they can also talk about how big the tumor will be, how it will have poor differentiation. But of course the SUV max values are still not standardized. We still have, it can vary from machine to machine, center to center. So it can range anywhere from 3.7 to 9 milligram per ml. So that is the kind of values which you can have a range for. But now we know that you can look at some other parameters which can be better to tell us about prognosis and outcomes, which are the metabolic tumor volume and total lesion glycolysis. These are better parameters. So I think over time we will be moving away from looking at just SUV max and we will be looking at these other parameters. So if you have students, young faculty who are looking at doing the PET scan, I would urge you to look at this, see whether we can come up with something more definite for these parameters. So of course we do PET scans during radiation. We can look at if the SUV is coming down, and if you have a response, we can predict a better local regional control and overall survival. Of course we have PET guided adaptive radiotherapy. So what are the challenges we have with PET scan? I think as radiation oncologists we know that if you do a PET scan immediately during treatment or after treatment, many of the findings are nuclear medicine specialists are not able to say definitely whether is it due to malignancy or is it due to inflammation or is it an infection or a hematoma or it's just post-RT changes. So that is a big challenge. And if a lesion is very small, we are not able to say with certainty what it is. Of course, cost is another factor. Most of our patients are unable to afford. They may do one at the beginning, they may not do one post-surgery, but continuously during treatment, immediately after treatment may not be possible for many of our patients. And of course, access. You need to have access preferably within your own center if you want to do any PET-guided radiotherapy and PET-guided adaptive radiotherapy. So these are the challenges which made me look elsewhere. Is there something which is simpler, which is more cost-effective, and which doesn't have any radiation, additional radiation to the patient? So that is when I looked at diffusion-weighted imaging. I'll come to that. So then the other parameters which are available is dynamic contrast enhanced MRI, where you have you will use gadolinium contrast, and then you have the other parameters which I talked about. Again, those are not yet standard of care because the results have not been encouraging. So dynamic contrast enhanced MRI is still one of the modalities we can use if you have it. You can look at how the perfusion is done. You can quantify the perfusion. Qualitatively, if you see more rapid increase in the perfusion, it usually means it's a malignancy. And quantitatively, you can look at absolute values and changes over time. And so this can also help us to predict outcome, local regional control and overall survival and disease control. So I'll come to the main focus of my talk today, which is diffusion-weighted MRI. So how did we come to doing this? So I was exploring various modalities. So then I realized diffusion-weighted MRI can be done with a patient. For a patient who's had a CT scan, you can just do one sequence and you can easily look at the diffusion weighted, you can do the MRI and look at the apparent diffusion coefficient. And you don't need, it doesn't take much time, even in a busy radiology department, you can get a slot easily and get these patients to have this study done. You don't need any contrast, no additional radiation. So it ticked all the boxes, and so we didn't have much problem getting it cleared from our institutional review board as well, because we just said it's going to be observational and we are not going to be giving putting the patients to any risk if we do the diffusion-weighted MRI. So what is the basis of diffusion-weighted MRI? So if you imagine tissue as is a balloon filled with small balloons inside, or spheres, and you have water. So Brownian motion of the water is restricted if you have too many cells which are packed inside because the water molecules are not able to move around. And so you have a lower apparent diffusion coefficient. But as cell kill happens, as the cells become less in number, the movement increases. And so you have an increase in the apparent diffusion coefficient. But I'd also like to say that a very high diffusion coefficient at the beginning may not work well for us because it may mean the tissue has become necrotic. The cells are all dead. So you may not have much changes if you have a very necrotic tissue, but it's very good for tissues which are a lot of cells which are packed. So again, that is the hypothesis. So if you have more cellular tissue, you have a lower ADC value. Less cellular, you have higher the ADC value. So this is just what I was talking about. So you can see you have a solid tumor, more cells, treatment-induced cell death, you can have ADC increases. So we went about doing 2 studies. These were done as early as in 2014. And so we did a couple of studies. So the first one was done on looking at diffusion weighted imaging and looking at the ADC values in patients who had laryngeal and hypopharyngeal cancers. Why did we choose this? Because these were patients who would usually come to us for organ preservation and they would not be post-op. So we didn't want to look at anything where we would have post-op patients. And these were all patients who would be treated, and we looked at how the ADC values are at the beginning of treatment, middle of treatment, and after treatment, what they look like, and how they correlate to their outcomes. And similarly, we did another study in nasopharyngeal cancers. This was subsequent to the first study, which was done in 2016 to 2017. So this is the study protocol. These are standard, which we got help from our radiology colleagues. These are quite standard. We did MRT2, HR, axel, and different weighted sequence. And this is what is standard practice when they do for our head and neck patients. And this is what we use. We had a special software to look at ADC values. And for the display, we had a parametric scan. And the ADC measurements are done by region of interest on the ADC map. These are all done by the radiologist. So these are the, I just kept these studies side by side so that I don't repeat myself. So we did it pre-treatment, that is before the patient had any kind of oncological treatment. Once the staging was confirmed and we had planned the patient for radiation, patient would have it before the treatment starts. Then we did it at the end of 1 week, then at the 4th week, and 6 to 8 weeks after radiation. If you see the nasopharynx study, we did not do the 4th week because from the outcomes of the first study, we found that it was not very useful. And in the nasopharynx, we did 4 to 6 weeks, but that is the time patient comes back. At that time, we were not doing a lot of NACTs, so they would come back for their follow-ups and for their adjuvant chemotherapy. So that was the time period we captured them. So these are the numbers we had. So for laryngopharynx, we looked at mainly T3 because that was where we would do chemoradiation. And nasopharynx, we had 13 patients, stage 3 and 4. Concurrent cisplatin, we had 14 patients on the laryngopharynx. That time we were doing a lot of nimetuzumab, so we had 2 patients. And radiation alone, we had around 3 patients. Radiation dose was standard, we were treating 66 to 70 grade, 33 to 35 fractions, 5 fractions a week. And similarly for the nasopharynx at stage 3 and 4, ideally we would do chemoradiation. And then we had, most of the patients had 3 weekly cisplatin. We had some patients who were not fit, so we ended up giving them weekly cisplatin again. Doses were fairly standard. So what did we find? It was a very exciting time for us because we were waiting to see what we found. we found that all patients showed an increase in their ADC values, and any rise in the ADC value, a sharp rise, we found that these patients had complete response when they came back for their evaluations. And the response to CRT is usually if you have, so this is something we found very difficult to understand. We said that our hypothesis was a higher pretreatment ADC is not good, but we found that these patients did better in the studies in the laryngopharynx. So this is a graph which shows us the various ADC values in the patients in their first week and pre-treatment, first week, fourth week, and then follow-up. And so in the studies for the nasopharynx, we found that we had a smaller cohort, and so we found that the same findings. There was an increase in the ADC values for each stage of the therapy, primary and the nodes, and complete responders had higher difference in the ADC values, and they had higher baseline ADC values again, which was not what we had hypothesized. So it came opposite of what we had hypothesized. So this is what we found in the two studies, and this is what we found visually. So we also had the radiologist map it out visually. So they could look at the tumor, and they could see it shrinking in the ADC mapping. You could actually see they could see the diffusion restriction, and they could actually see how it was less at the end of week 1, and there was at the follow-up resolution of the tumor in the nasopharynx. So we had similar findings in the laryngopharynx study as well. So what we said was, so what we concluded as rise in ADC value is good to predict treatment response. So if you have a patient who doesn't have it, you may probably not end up having a response, and you can sort of prime them if they are already having their laryngopharynx, sort of get in touch with the surgeon. They may have to go in and do a salvage surgery. You can have both visual and quantitative measures, and so again you can either intensify therapy, follow up, and it is definitely an additional tool when you do your treatment for the patient. So it has got value. So again, so what were the challenges we faced? Challenges we faced was you would need to send the patient to radiology, you need time, and sometimes the machine breaks down and they are trying to do their own scans, so your patients may not get slots. So that was some of the challenges we had. So looking into the future, do we have a future in this? Yes, definitely. Because MR linacs are coming into the country. We already have, I think, one is commissioned. We have some more being commissioned. So this gives a lot of excitement. Maybe CMC will have one day. Maybe all of us will have MR linac one day. So what are the benefits? So you can start transiting into MR guided radiation. So you can have MR treatment planning. You can do your contouring, then auto-sub contouring. You can have MR based planning and MR only workflow. So you can actually, there is talk, but you don't need to do the CT scan. You can do everything on the MR. And on the MR linacs, you can have bulk density assignment and you can make it like a synthetic CT. So you can do your planning by assigning values, CT values to your MRI tissues. So that is the future what we are looking at. So you can have something I said, you can do adaptive radiation looking at. So daily you can look at the diffusion weighted imaging. On the machine you can adapt your treatments. You can have on-table adaptation, which is real time. You can have the same biomarkers. You can also do radiomics. And over and above that, you can have MRI biomarkers of tissue injury. That is an area which is being explored. So I think we'll soon be looking at parameters like even tissue injury you can predict using MRI biomarkers. So I think so that was the first part where we did work with head and neck cancers. We did embark on another study where we tried to look at diffusion weighted imaging in oropharyngeal cancers. We tried to stratify them as HPV positive and negative. Unfortunately, this study was started when we had COVID happened, and we almost didn't get any patients coming back for the follow-up scans. So we had to, we did not continue the study, and the findings, as you expect, we could not conclude anything from that study. So it was a postgraduate thesis for one of my students, and we just had to write up, and I think that year the university was quite generous in accepting whatever we sent them, so they said effort was made, and so we could still submit it even though we had no conclusions from that study. So the next malignancy which I worked on with looking at diffusion weighted imaging in esophageal cancers, again very encouraging reports, and so just as epidemiology, it is now considered the 5th most common cancer as well as cause of death in India. So it is a challenge for us. And standard of care of neoadjuvant chemoradiation followed by surgery. But what we do know that only a fraction of our patients show complete pathological response to neoadjuvant chemoradiations. And when a patient has a PATH-CR, they have better outcomes and benefits from NSCRT. So when we started off, we didn't have the SANO trials, were not yet recruiting, and so we published this in 2022, and Dr. Nino was a postgraduate, now she's a faculty, she's an associate professor now with us, and this is what I will walk you through this. So it was a prospective study. We had 24 patients who were all planned for NSCRT. So we recruited patients between 2015 and 2017. So the usual, they were all standard of care treatments, we didn't change anything, but we looked at the ADC values at baseline 10 to 14 days into the radiation and at the end of radiation. And all these patients, when they came back, as per protocol, they all have a contrast CT, where the surgeon would say, okay, is the patient operable or inoperable, and based on the histopathology, we call them responders and non-responders. And if a patient was deemed as inoperable for whatever reason, the patient refused, or they were medically unfit, or they were on scan, the tumor was not suitable for surgery, they were deemed as non-responders. So this is the standard MRI acquisition for the study, and this was a concept diagram. So we started off with 27 patients, and finally, if you see, we lost patients to because two had defaulted, and some were 2 patients were inoperable, and 1 was deemed medically inoperable. So finally, we had 19 patients to assess. And so we found that this is the clinical for the patients. So what did we find? We found that patients who had a pathological complete response, they actually showed a significant rise in their ADC values. At 10 to 14, they had a significant rise in ADC values, correlated with the pathological complete response. So here also we see that the ADC values of responders are always higher than the ones who were not responding. So this is visually you can see that the responders had a visible tumor reduction, where the non-responders tumor was still seen viable on the diffusion weighted imaging or the imaging. So what did we conclude? The conclusion was that mid-treatment ADC was significantly higher in patients with PATH-CR and was significant. We had a p-value of 0.011, and the ADC differential between baseline and mid-treatment correlated with the tumor response. So what is the future for esophageal cancers? So now we all know that we are already moving into the era of organ preservation. It is standard of care in rectum. So are we looking at it in the esophagus? The answer is we are headed in that direction, because the Sano trial, which looked at organ preservation, was published just recently in April, and they have said that overall survival after active surveillance is not inferior compared to surgery after 2 years. So we have phase 3 data to say we can follow up our patients who do well, who have complete response, and we can follow them up and do organ preservation. The Inaugural trial, which is looking at active surveillance versus surgery, still accruing. I'm sure when these results come, they'll have similar findings. And the Pride trial, again, you can have, they're looking at preoperative image guided identification of response to neoadjuvant chemoradiation. Again, they are using PET scans as well as diffusion weighted imaging MRI studies. So I think the future looks bright for organ preservation in esophageal cancers. Again, the answer is get an MR linac. You can do all this, you don't have to send your patient elsewhere. You can do it on table, you can adapt your treatments. So I think that is the way forward, and I'm happy the work which we did many years ago is probably ahead. The world is headed in that direction. We did a small trial. Since I talked about biomarkers, we looked at EPV DNA titers pre and post treatment in undifferentiated nasopharyngeal carcinoma. Negative titers or fall in the titers correlated with response. One patient showed an increase in the titers, and when we investigated, we found there was a patient that developed hepatic metastasis. So again, we cannot use it widely because we have the population which is endemic is mostly in Nagaland. So we're trying to see if we can work with one of our collaborating centers. If we can start this there. We had applied for a grant, we didn't get it, but we hope we can start it and benefit the population which has the highest incidence of EPV DNA associated nasopharyngeal cancers. So what are we doing now? I think you all have heard about the quantitative imaging and artificial intelligence lab. I think you had all seen it, those who had come last time to when we hosted the AROI-TNPY. So the main work is in radiomics and head and neck cancers. So why radiomics? You don't need to do any additional imaging. You can look at signatures, quantitative signatures in a CT scan which you acquire for treatment. So you don't need to do any extra imaging, no extra contrast, just you can use that. So I think the data has been collected, we are analyzing it. We should be having some results out by the end of the year. Again, we are looking at adaptive radiotherapy. So that is going to be one of my postgraduate's dissertation. Hopefully we'll be able to present something by next year. So this is on, we are using the Radisat Precise art for this, and so we hope to streamline and have some outcomes or results of how we can streamline use of that. So I'd like to especially acknowledge my postgraduate students who work. Dr. Solly Thomas worked on the laryngopharynx data. She presented this at European Congress for Head and Neck Oncology as an oral presentation in Rome in 2018. Dr. Amulya, we didn't have enough numbers. She's in Australia now. Dr. Nino worked on the esophagus paper. She won the best paper at the annual research day in CNC. And Dr. Warren won the best paper in AROI-TNPY in 2020. I'd really like to acknowledge my colleagues in radiology, Dr. Aparna and Dr. Suniti, who helped me a lot and always cooperated when we had problems getting the MRIs. Of course, my department, my unit, Radiation Oncology, Unit 2, where I work, very good bunch of guys, colleagues, students, And I want to thank all the faculty, staff, students who work with me, students in the past, present, and hopefully the future. They've all shaped me in some way or the other, and I can never forget their contributions in my life, and both professional and personal. And I'd also like to thank my wife and daughter who have stood by me. Even though I throw tantrums, I know you won't believe it, I do. So I'm human. So thank you all for giving me this opportunity. This is our lab, and this is the team which I work with. Thank you all very much. I'm honored, privileged, and nandri.
Thank you, sir. We now request the chairpersons to honor this orator.
கொஞ்சம் ஒரு பாயிண்ட் ஃப்ரண்ட்ல வரும். நீங்க பாருங்க.
Moving on to the next session on breast brachytherapy. To chair the session, we invite Dr. Bhupal sir, Senior Radiation Oncologist, Chennai, Dr. Balu David sir, VS Hospital, Chennai.
Members and delegates, it's an honor given to me to chair this particular session because I have a backdrop. People know by now that I have a passion for brachytherapy. More importantly, I cite an incident when I went for my MD exam. The case that was given was carcinoma cervix bleeding. I examined everything, and Dr. Padam Singh was the examiner. He came and asked me, "What do you do?" I said, "I will go to the examination." "How will you proceed?" "After per abdomen, I will go for local examination." "What is that you will do for local examination?" "I'll do for vaginal, then I'll go for speculum." "Why not speculum?" "Sorry sir, in this case, I'll do only PV, then only go on to speculum." No, I want to do speculum." I said, "Jolly well do it, but I won't do it." Then he said, you're arrogant. Sir, I'm arrogant, I think. But I have a point to try. That being a leading person, there's no point in doing instrumentation. The soft finger can be the better option. That's why I said perversion. He asked me to get out of the exam, and I was late. In diploma, I went to the same examiner. He said, an exam he did exceedingly well in MD, so he's given diploma recently. This is a matter in which I got trained in CSRX, and crowning was I delivered the balancing oration in All India level on brachytherapy. With this, I request the speaker, Dr. Alex, to go on.
Dear friends, colleagues, ladies and gentlemen, in the next 20 minutes I'm going to talk in terms of breast interstitial brachytherapy, more in terms of accelerated partial breast radiation, and in the middle of this brainstorm session I'll make sure this 20 minutes will be brain breezy sessions. நீங்கள்லாம் சென்னை வாழ் மக்கள், நீங்கள் வந்து பேய் மலை தான் பார்த்துருப்பீங்க. நீங்கள் வந்து குற்றா சாரல் வந்து நீங்கள் ஃபீல் பண்ணுங்க. அதை ஃபீல் பண்ணிங்கன்னா வேறு லெவல். இன்னைக்கு குற்றால சாரல் ஈவினிங்கில் வரணும்னு நினைக்கிறேன். கேலா டின்னரோட தேவில் போய் குற்றால சாரல் வரணும்னு நினைக்கிறேன். ஸோ என்ஜாய் தேட். And I would like to first of all thank the chairpersons, Professor Dr. Bhupal, Professor Dr. Balu David, and the organizing team, and organizing president, Professor Dr. Devanayagam, and the organizing secretary, Rajkumar, and the whole team for having given this wonderful opportunity. So, I'm movie buff, so I always try to do some movie-related thing, and I like Vadivel a lot. Vadivel is full of face, full of emotions and body language. And இது பார்த்தீங்கன்னா இது பற்றி ரொம்ப பரபரன்னு யோசிக்க வேண்டாம். I'll make it very short and sweet and very short in this presentation. நீங்களாம் very hungry ன்னு எனக்கு தெரியும். So இந்த மாதிரி ஃபீல் பண்ணாமல் இருங்க. I will make sure it's very short and sweet, crispy presentation. And ABB techniques, what is the techniques available? Brachytherapy itself, you have interstitial method, balloon catheterization, SAVI. And then you have external beam radiation and single dose intraoperative radiation. That is the thing done by Vaidya. So we are here to talk more in terms of brachytherapy, especially more in terms of interstitial brachytherapy. And APPA boost, if you think so, this is talk in terms of boost, not in terms of APPA boost. Photon, electron, brachytherapy. These are all the different ways of giving boost. Brachytherapy seems to be the preferred option if the patient is high risk for local recurrence, if the patient is a young age, and the positive closed margins are there, and the tumor is going to be deeper. If the tumor is going to be beyond 4 centimeter deep, you will go for a brachytherapy. The reason behind this, the internal dose will be very less if you go for this, if you go for interstitial brachytherapy. And if you see the rationale for accelerated partial breast radiation, the rationale is majority of the local recurrence. About if you see 80% of the recurrence, if at all it happens only in about 1 or 2 centimeter at the primary site, and only 20% come to other areas. And this is the rationale for accelerated partial breast radiation. And this is SAVI, stud adjusted volume implant. The small incision done. And then the instrument goes here, and then once it enters into the lumpectomy area, it goes to lumpectomy area, then it gets split up over there. Then the seed source goes there and drains that area and comes back. And if you see here, brachytherapy radiation is always from inside outside, whereas external radiation is always from outside inside. So basically, if you see by external radiation, the internal dose is very, very much high compared to the internal dose, which is very much lesser for brachytherapy radiation. Another thing is brachytherapy always, it's confined only to confined to tumor alone. or confined to the tumor lumpectomy. And if you see in terms of external radiation, there is always PTV, and PTV is what CTV with a margin, but brachytherapy you see here, CTV is PTV. In brachytherapy, CTV, PTV is always same. There is no margin at all. And this is breast brachytherapy. There are two ways of going for breast brachytherapy: intra-op and post-op. And this is intra-op one, that's a post-op one. And intra-op, we see here, there are pros and cons for the breast brachytherapy, intra-op and post-op. We see the intra-op pros. Intra-op, you see here, the pros is you can visualize the tumor in intra-op. The extent, the location of the tumor is seen. In the cons, you cannot use a template, and the needs expertise is always needed. If you see for the post-op brachytherapy, the process use template. If you use for template, the geometry is perfectly there. And cons based on surgical scar clips and cannot visualize the tumor at all. These are the pros and cons in terms of intra-op and post-op breast brachytherapy. And this is a template brachy here, and what you see here, there is the breast. If you see the templates here, they said the template looks like two plates, exactly like a mammogram plate. These plates confine to the breast and conforms to the size and shape of the breast. So there is the caliper, scale, and the rod adjusting over there. And in the plates, what you see here, there are perforated holes there. The holes are designed in terms of either triangle or square, just to make sure a geometrical implant. For volume implants, there are two ways. You have to think in terms of two geometries, either a triangle or square. And in the triangle square, I'll explain, the next further slides will explain to you. And this is the one. What you see here is the stainless steel tube or the needle passes through the enteric area and comes to the other area. There are all graded zones like grade 1, grade 2, grade 3, and in the grade things you'll have number 1, 2, 3. So this will match with the other exit plate also. So if you enter this area, that should get to the other area and come out the same thing, the grade thing. So you try to visualize the tumor. Visualizing the tumor is very common in terms of prostate. Prostate, they go for visualize the CTV mapping. The CTV mapping has to be done, or if you go for a template brachytherapy also. Based on the PTV planes and tubes, you need to work out on the number of planes and the number of tubes and each plane and the source activity and tubes. What you see here is, you see the tumor is seen as length and breadth and thickness. The length and breadth will decide the number of tubes, and the thickness will decide the number of planes, superficial, deep, or in between, the in between plane also. So you always try to work out and then you go for the procedure. And another thing is source activity. I don't know whether you all go for brachytherapy. You ask the physicist for the source activity. I don't think anyone asked that. You should know that because source activity is very much needed. If the activity is high, if the source is hot, then the chance of getting hot spots are high. And the same thing, if the source is lower, then what you do is you can try to, the dose rate, what you can get is you can, the tubes can be get close to each other to get a good dose rate. If you go for a hot dose activity, not hot source, then what you think is you try to the tubes away from each other so that the hot spots are not there. So basically you need to know that whether the source activity is properly there. Activity is the one which decides in terms of the dose rate. And this is a needle insertion here, and there are two plates over there. And you can always replace these tubes with in terms of plastic catheter. And this is a plastic catheter over there. And you see here, the homogeneous, the isotope distribution you see here, brachytherapy is completely different. And for the external element, the thing is completely different. What you see here, the integral dose is very much high for external beam radiation. And for brachytherapy, the integral dose is very much lesser. the APP criteria eligibility. Stage 1 T, tumor inside to T1, unifocal, unicentric, invasive non-lobar, negative margins, tumor less than 2 cm, central lymph nodes, external lymph node negative, node negative. This is the criteria for the APPI. So APPI, why brachytherapy? What are the advantages over external beam radiation therapy? Brachytherapy is the most conformal way of radiation, and CTV, PTV is almost same. There is no need for any expansion at all. And few challenges for setup variations, respiratory motions are there. Otherwise, brachytherapy is a choice in terms of external, in terms of APPI. And what you see here, as I told you, the brachytherapy, PTV and CTV are same, and EBR is CTV with a margin behind. So it's CTV with a margin. PTV is with PTV with CTV with PTV is in EBR is high. And this is for intra-op brachytherapy, and always strive in terms of planned incision, and planned incision by ALND and planned incision for the lumpectomy. There's a curvilinear incision here, and that tumor is taken away. The tumor size is 2 by 2 by 1 centimeter. Length, breadth and thickness. Lengthen, as I told you, lengthen the decides upon the number of tubes what you are doing for, and thickness decides upon the number of plates what you are going for, the implant. And always you try to get the entry area and exit area by making a marking at the skin of the breast. And this is the entry area, that's the exit area. And you always try to pass the tube through the entered area and try to come out through the exit marking which I have seen over there. Always mark it on the breast. That's enter and that's exit. That's one tube. And the second needle which is passed through again, see? You try to pass in the same. And what I have done here is about 3 or 4 tubes are there, all in the deeper plane. And ultimately what I have done here is 2 planes, a superficial and deep plane. And the deeper plane has got 5 tubes and superficial one has got 4 tubes. And I always the geometry I've looked in terms of a triangular geometry, not a square, triangular geometry. And there is a reason behind the triangular geometry. As I told you, you always, if you go for a voluminous implant, you have to think in terms of either a triangular geometry or a square geometry. And if you see here the tubes at the corners, the tubes at the corners give contribution of 2/3 to the center and 1/3 to the periphery. What happens is if the tubes are most drifted away from each other, then the 2/3 contribution will be much resulting in hotspots. Similarly, if the tubes are becoming very close to each other, the contribution to 2/3 will be higher, resulting in hotspots. So that's the reason why you always think in terms of either triangle and square. And உங்க பாட்டிலாம் சொல்லிருப்பாங்க நினைக்கிறேன், புள்ளி போட்டு தான் கோலம் போடணும்னு உங்களெல்லாம் சொல்லி கொடுத்துருப்பாங்கன்னு நினைக்கிறேன். புள்ளி போடாமல் பட்டீங்கன்னா கோலம் அலங்குலம் ஆயிருந்து உங்கள் தாத்தா சொல்லியிருப்பாங்கன்னு நினைக்கிறேன். ஸோ இட்ஸ் ஆல்வேஸ் யூ ட்ரை இன் டேர்ம்ஸ் ஆஃப் ஒரு ஜாமெட்ரியோட பண்ணால் the implant will be much better. And this is the scan there. And these are 2 planes there, one is superficial and deep planes. And I have tried to make at least 1 centimeter between the planes. Yeah, that's the superficial and deeper planes there, at least 1 centimeter each other. And always you try to make at least 1 centimeter between the deeper plane and the costochondritis, and between the superficial plane and the skin of breast. This reduces the chance of costochondritis, osteonecrosis, mastitis, skin peel and radionecrosis. Always there should be at least 1 centimeter away between the superficial plane and the skin of breast, and the deeper plane and the costochondral area. And as I told you, for any mantra for implant is geometry, parallel and symmetry. And dose homogeneous distribution will be needed only if you maintain this mantra of geometry, parallel, symmetry. And what you see here is this is a prescription. There always. And another thing in the implant is always you should know how to prescribe the implant. There is a way of prescribing. Prescription can be done at the superficial one, mid-plane or deeper plane. But always, the thing is you always try to get the average of BDR, basal dose rate. BDR and reference isodose, you should always, where any implant, you should know about the BDR and the reference isodose. And if you prescribe in terms of the mid-plane of the implant, the distribution will be much homogeneous. And the fractionation schedules, this is for APPA. For whole radical brachytherapy, the equivalent dose is 40 to 45 gray. The fractionated schedule will be 8 into 4, 7 into 4, 10 into 3. And the boost, the equivalent dose is 10 to 20 gray, 2 to 4 gray, 3 to 3.5, 1 by 7 gray. The treatment time is 4 to 5 days for the radical, and for the boost is the radical, the treatment time is 1 or 2 days. And the interval between the two brachytherapy procedures will be at least about 6 hours. And post-operative brachytherapy will be boost. The advantage is it's template-based, based on surgical markers, skin-based markings, skin on pre-post-operative scans. You may also think in terms of a freehand technique, without template. Breast brachytherapy prescription, always prescription should be the mid-plane of interstitial implant. That's very much needed. Prescribing is the main thing. But sometimes if you go in terms of prescription, the superficial one, that can result in radionegative in some other places. So PTV is always CTV. Check BDR and reference isodose. Try to contemplate the areas of fibrosis, necrosis. Try to avoid them. To avoid fibrosis and necrosis. Optimization when contraindicated. When the geometry is poor, always contradict with the optimization. The reference isodose chances, necrosis is high, too many cold spots, hot spots. These are the places you should always try to avoid using optimization. And underlying message here is dose optimization cannot compensate the poor implant geometry. The geometry is bad, the implant geometry is very bad. Abort the implant and get out of the scene. And this is the balloon brachy. What you see, it's like a small balloon, like a catheter with a balloon there, and the balloon gets the fluid get infused inside that, and outside that balloon, around that balloon, you treat that area. That's mammocyte. But I don't think any mammocyte savvy is being anywhere in India. Anyone using it? I don't think anyone is using it. No. So intraoperative radiotherapy, again, as I told you, this is a single dose, and it's 20 gray or 21 gray. But there are a lot of remains. This IORT and APP remains controversial. So IORT is done only in London and Europe, not in North America or anywhere in India, Asia. And this is a single IORT APPA, and APP wisdom pearls, as I told you, the suitable, costly and unsuitable one. And suitable is again same thing, age 50 years, less than 2 centimeter, NGO status, margin is negative, positive ER status, unicentric. These are all the suitable ones, and costly ones there, and the unsuitable is over there. So conclusions, I will suggest that breast brachytherapy, preservation of anatomical organs, delivers conformal local radiation, which is comparable to high pressure radiation. The economical best method to achieve conformal radiation improves local control rate and survival. The need of hour is randomized prospective multicenter trial, online of demo workshops to instill the interest, mentoring brachytherapy with passion. I would like to show some few minds over here. And this is great mind, and the genius mind, and this extraordinary mind, brilliant mind, and never mind. So ladies and gentlemen, I had a great time. I will go beyond.
Thank you, sir. Your presentation has added a great value to our program. May I invite the chairpersons to honor the speaker?
இங்கே பாருங்க.
We now invite Dr. Re-irradiation to felicitate the chairpersons. We can now break for lunch. We will return by 2:40 p.m.
சாப்பிட்டீங்களா? அலெக்ஸ்